All right. It's our long-awaited OCA board meeting in Monterey County. Thank you for welcoming us. We're going to start by taking roll, establishing the quorum, and then I'll spend a couple minutes just opening the meeting, and then we'll jump into our agenda. So if we can, please take roll.
Mark Galley,
Present.
David Carlisle,
Present.
Sandra Hernandez,
Present.
Rick Kronick,
Present.
Ian Lewis,
Present.
Elizabeth Mitchell,
Present.
and we heard present, Richard Pan,
Present.
Don Molds. All right, that's a full 8 board members here.
Okay, and I'll just start by just thanking my fellow board members for making the trip here. I know it was important for each of you to be part of this, so just grateful. And a number of other people who, to make this agenda rich, have made the journey also from probably the Bay Area or Sacramento, but grateful to be on the road. So just by way of opening, I first want to just say it is only appropriate that we come to Monterey because for the last year plus you have come to us. And it's only right to reciprocate that show of support and demonstrate our focus on what this body came to do and why the office was created in the first place. And your voices, those who are here today and those who are not here today, but still contributed to so much of the rich discussion we've had over the last year, have underscored the importance of focusing on affordability. We often do talk about so many other related issues to affordability, but at the end of the day, the stories of people who are working so hard just to keep up with life in California, and when the cost of getting good care gets in the way, this body is here to help us shape a future where that's just not the case anymore. And today's conversation is one which really uplifts the voices that we've heard, one, but two, digs into what's underneath the stories, right? The stories are really the manifestation of systems and arrangements and a history of practice of healthcare that California, like so many other states, and Monterey, like so many other counties, even in California, have struggled with for a long, long time, and probably more acutely over the last 5 years because so many of the events in the world. And so to set expectations, what I hope we come away from in this meeting is that not just the fellow board members, but those who are listening in from afar and those in the room, we start to really uncover or uplift and call out some of those data points that feed into the stories that we've heard for the last many months. And with that, this body has a responsibility to consider how that affects what we do. And so even though today's meeting will end later this afternoon, it is not over. It's really just the beginning of what we can do working together to really change the arc of those stories that we heard so eloquently and so often. I will also say that, like every story, there's a couple of sides. We're going to hear some of those sides today and not all of them, and we're going to have chances to hear more later. But this body does intend to weigh and balance all of those sides to help be effective and not just shining light on some of those tendencies and practices, but also identifying new ways moving forward to make changes that I know you all, your families, and just families across California are waiting to see. So with that opening, I want to turn it over to Director Landsberg, and we will jump into our agenda. But again, thank you on behalf of the whole board for your efforts up till now. And I hope us being in your front yard, your backyard, your whatever yard, part of your yard you welcome us into, that it is a demonstration of our commitment to pay attention closely and do something about the stories we've heard.
Thank you very much, Dr. Galley. Good morning. My name is Elizabeth Landsberg. For those of you who I don't know, I'm the director of HCI, where the Office of Healthcare Affordability is housed, and we appreciate you being here today. As Dr. Galley noted, you all have been coming to us in Sacramento. We appreciate that. We heard you, and so we are here. The team has done an incredible job looking at the data, trying to analyze the data to understand what's happening, what underlies your stories and struggles in affording healthcare. So we've done our own analysis of our HCI hospital financial data. We have reached out to our sibling departments and researchers to understand why there is so much regional variation in healthcare costs, why costs are more expensive in Northern California than Southern California, and why specifically there are such high healthcare costs here in Monterey County. Today's meeting agenda, yes, we have up the meeting agenda, focuses on sharing that research and analysis. So after the board votes on one action item regarding a member of our advisory committee, we will focus the meeting on regional variation of healthcare costs, and specifically we'll look at hospital costs here in Monterey. Our OCA team will share their analysis of financial data submitted by hospitals to HCI. So for literally 50 years, hospitals have submitted financial data. That's been a critical transparency program here in California. And now our OCA team has taken it to the next level in terms of analyzing that data. And I appreciate the work and the collaboration that led to that. We will then hear from Covered California's Executive Director, Jessica Altman, and CalPERS Chief Health Director and OCA board member, Don Molds, about their experience as public purchasers in arranging for care in California and in Monterey. We'll then hear from Chris Whaley from Brown University, who's done important research on hospital costs. He will present his analysis broadly on California and Monterey specifically, and then we'll share options for addressing cost variation and unaffordability. Last and importantly, OCA staff will present on policy tools the office and the board have in addressing high cost outliers. Secretary Galley was clear that that was an important piece. And so we can't do all of those steps immediately, but we do want to be clear about what are the policy tools in our toolbox. So we appreciate consumers asking us to come to Monterey, the board's desire to do so, and I want to recognize OCA staff's hard work to make this important meeting happen. Thank you. Happy to move on to the executive updates, Mr. Chair. Okay. Moving on to executive updates for the department. So first, I want to talk a little bit about what the department's doing to make sure that our meetings are accessible to everyone, and specifically to reduce language barriers so that we're making all of our meetings as accessible as possible. So our meeting notices include information about public meeting, about the meeting in 5 different languages, about how to request interpretation services. So if you contact the email address on the screen or found in our meeting agenda, we can provide translation or verbal interpretation services, whether that be document translation, telephonic or in-person interpretation in any language other than English or American Sign Language. Today, we have available simultaneous interpretation of the meeting in Spanish for anyone who would like it. And so please let us know if that's a need of yours. I also want to let members of the public know that we have flyers available in English and in Spanish. I believe they were just outside the room about our hospital bill complaint program. As I talked about a few months ago, hospitals are required to both have a discount policy, a discount payment policy, and a charity care policy to provide financial assistance to those who need it. So those policies are available to folks who are uninsured or underinsured, and we know more and more folks have very high deductibles, and those programs are available to folks with income up to 400% of the federal poverty level, which in concrete terms is $60,000 for an individual and $125,000 for a family of 4 this year. If you or anyone you know believe you were wrongly denied financial assistance, weren't told about a hospital's financial assistance program, or were sent to collections but need financial assistance, you can take a flyer or go to our website for access to that hospital bill complaint program. On one personnel note, I announced at our last meeting that we have hired at HCI a new chief medical officer, and I believe Dr. Lemonade Tefera is in the room, who goes by Tef, and we're pleased to have him here with us. The last thing I wanted to cover in my executive updates is about our latest HPD report. HPD stands for the Healthcare Payments Data Program, California's all-payer claims database, which we have built in California, has just issued our third major public report, this one looking at prescription drug coverage. So specifically, it looks at the more than 100 million prescriptions that were covered by commercial plans for almost 10 million Californians, costing more than $13 billion. So we have an individual piece of data for each of those claims. What was the diagnosis? What was the actual prescription drug? And so we've started to publish that data. So the report allows users to explore different pieces. We honed in on three main parts of that prescription drug data, the 25 costliest drugs in California in terms of annual statewide spending, the 25 most commonly prescribed drugs, and then focusing on consumer impact, the 25 drugs with the largest monthly median out-of-pocket cost for consumers. So some of our findings in the report are that the 25 costliest drugs are only 3% of the prescriptions, but account for more than 30% of the total costs. So we know that a small number of prescriptions are a large number of the costs of more than 3.9 billion in 2021. The four most frequently prescribed drugs in California in 2021, it may not surprise you to learn, were COVID vaccines, which didn't have any out-of-pocket costs. The 25 most frequent prescriptions account for 12% of the prescriptions. And then in terms of out-of-pocket costs for drugs, there are caps on the out-of-pocket, what can be charged for prescription drugs, and those range from 150 to 250 in the commercial market because of those state policy limits. So again, the data transparency is very important, but we took it to the next level, and our OCA team did some analysis and just want to share a couple of the high-level findings. So almost half of the top 25 costliest prescription drugs are biologics. So increasing access to these lower-cost biosimilar or generic biologics is an important strategy to improve affordability. So that's one thing that we know and that we're doing something about. Insulin is a major driver of the cost of drugs, and the branded versions of insulin Lispro, Humalog, and insulin Glargine are two of the costliest drugs identified in the report. So these findings highlight that making affordable biosimilars of widely used prescription drugs lowers costs for consumers. And I'm proud to say that we are part of the work started by the governor and Secretary Galley under the CalRx program for California to work on producing our own biosimilar insulin and investigating other drugs that could be provided at a lower cost through the CalRx program. So going forward, HCI and its work to help reduce healthcare costs will continue to use this healthcare payments data to support more drug cost affordability initiatives. So those are a few highlights from the department. And with that, I will turn it over to our OCA Deputy Director, Vishal Pagani.
Thank you, Director Landsberg. I'd like to open my remarks today by discussing the spending target and data submission guide. After the board adopted the statewide spending target, the percentages were placed in the California Code of Regulations, as seen in this slide. The spending target was able to be put in regulation without going through the rulemaking process because it is a board-adopted rate and was declared exempt by OCA's enabling statute. While the spending target is enforceable with or without this regulation, it was posted in the California Code of Regulations to make it easier for the public to find, and it is structured in such a way as to allow for future targets to follow. The next slide focuses on the total healthcare expenditures data submission guide. Earlier this year, OCA adopted regulations for total healthcare expenditures data submission by payers and fully integrated delivery systems. Based on feedback, since those regulations went into effect, some minor changes were needed. As captured here, the THCE data submission guide and OCA attribution addendum were updated to new versions effective July 1st, 2024, as a change without regulatory effect. This means the Office of Administrative Law, or OAL, agreed the updates were non-substantive and do not change any reporting obligations. The updates to the DSG included addition of non-spatial Los Angeles area zip codes and an unspecified region code to the data submission guide. The updates also included moving 7 zip codes to the correct Los Angeles County Service Planning area. These changes to Appendix C regions of the DSG were necessary to correct unintentional omissions. In addition, additional physician organizations were named to OCA's attribution addendum based on information received from payers and fully integrated delivery systems during the inaugural registration cycle that concluded in May. The attribution addendum is used by submitters to cross-reference physician organization names to other data points when attributing member-level total medical expenditures. A full explanation of these changes and revised versions of both the guide and the attribution addendum are available on the OCA webpage. Additionally, I want to provide an update on data submitter progress and OCA's engagements with required data submitters. The TME data submission deadline for calendar year 2022 and 2023 data is September 1st. OCA has convened a monthly data submitter work group of all plans expected to submit commercial and Medicare data. 18 of 18 expected plans registered with OCA in April of 2024. In July and August, OCA conducted one-on-one meetings to answer technical questions and facilitate timely submission of the TME data. And OCA has also received test files from 4 plans. So that wraps up the TH guide and attribution addendum item. I'm also going to cover an item that's not shown. So in addition, as many of you may recall, there were proposed revisions to OCA's regulations regarding notices of material change transactions, which were discussed at the June 26th board meeting, which followed a public comment period. OCA posted the revised emergency regulations with a formal advance notice of emergency regulatory action to the OCA website and sent a notice over the OCA Healthcare Market Oversight Listserv on August 5th. After the usual 5-day notice period, the emergency regulatory package was submitted to the Office of Administrative Law on August 13th. One comment was received, which OAL considered during their review. OAL approved this regulatory package on August 22nd, and the revisions became effective the same day. And lastly, as we do at every board meeting, I'd like to remind the board and members of the public about our slide formatting. As you know, the statute identifies different roles for the board in different areas. We use a yellow arrow in the presentation for items which OCA has decision-making authority. And then for areas where the board has ultimate decision-making authority, we note it with a green arrow. And I'll now turn it back over to the chair.
Okay, thank you, Elizabeth and Vishal. So I want to open it up to the board for questions, and then we'll have public comment on what was presented in both Vishal and Elizabeth's openings. Any questions? Okay, go ahead, Richard Pan.
Thank you and appreciate the presentations. And first of all, thank you so much for addressing the language access issue. I know it's always a challenge, but certainly for the API community, that becomes a big challenge as well as for many others. The data on the pharmaceutical pricing, appreciate the oral presentation. I don't know if there's something you can send us in writing about some of the analysis as well. And also appreciate the opportunities that CalRx is going to provide. And I know there's a way to get an update on that as well.
Yeah, I'd be very happy to send folks a link to the HPD report on prescription drugs and some of our findings. And I believe we've done a webinar. So yes, we're happy to get information to folks about that.
And can consider how to interject the CalRx updates within an upcoming meeting. Totally makes sense. Thank you.
I wanted to comment on the report as well. But first of all, congratulations on all the excellent work that the office is doing. This is really moving things forward. I did want to make one point about CalRx, and I think this is a major step forward for the state of California. And having naloxone be the initial product is very important because it's so hard to obtain in the private sector. Lives are literally being saved, I'm sure, by this. The same will be true with insulin as well. I couldn't help but notice when I was looking at the actual link to the report, many of the names that I'm seeing on the most expensive list, I only recognize not because I prescribe them, but because I see them on television. These are drugs that are being heavily advertised to the public market. And I just wanted to suggest that it may not be a coincidence. Thank you.
I'll just make one comment because Richard, you brought it up. David, you allude to it. One of the updates that CalRx, when we talk about progress in CalRx, I think a part of that presentation would be real-time disruption of what other people are doing because of planned activities, even if they haven't yet come to fruition. We've already seen some changes. And to your point, David, I think markets respond to certain things that places like California do. So we'll be able to share some of those tidbits as well. Other questions, board members? Okay, let's go ahead and open it up to public comments.
We will now
on these items. We'll have just to let the public know, there are lots of opportunities for public comment today. We are here to listen to that in so many ways. So we'll try to keep it focused on what you heard in the presentation just before public comment, and then we will have open general public comment at the end as well.
So we will now recognize members of the public for comments on this executive update item. Please reserve your comments on other items for future comment periods during the day. To ensure equitable access to verbal public comment, we will alternate between members of the public present in this room and those attending virtually. Those in this room may line up near the podium. Those attending virtually who want to comment should click the raise hand button. Those dialing in can press *5 to raise your hand. It will track the order in which the hands were raised. And during the public comment period, you'll be unmuted when it is your turn if you are using the call-in feature. We'll also invite you to provide written comment at oka@hchi.ca.gov. Please keep your comments to 3 minutes or less so we can hear from as many members of the public as possible. Please note that while the Healthcare Affordability Board is committed to communication and transparency, board members and staff will not be responding to public comment. Additionally, the board may not discuss or act on any matter raised during the public comment period that is not included on the meeting agenda, except to place the matter on a future meeting agenda. We will start with individuals in the room, and we ask that they turn on the mic at the podium before they speak. And it is on. All right. Please go ahead.
Good morning. I am a teacher with the Salinas Valley Federation of Teachers. One day last year, my colleague woke up and drove to work. On the way in, he felt nauseous. Soon after arriving at work, my colleague needed to go home and continued to feel very nauseous. So he called an ambulance. The ambulance took him to Chomp, the closest hospital to his home on the Monterey Peninsula. My colleague sat in the waiting room for 3 hours and then was diagnosed with acute anxiety attack and was given a pill to calm him down. A few minutes later, 2 Chomp staff, one training the other, came to present the bill to my colleague in a way that nearly gave him a heart attack. They told my colleague that his bill was $19,000. Well, actually, the bill was $25,000. But due to his insurance, the bill was reduced to $19,000. The 2 Chomp staff members quickly disappeared, and a few minutes later, they came back and told my colleague that if he paid today, his bill would be reduced to only $5,000. So my colleague quickly whipped out his credit card and paid the $5,000 on the spot. His father had just recently passed away due to a heart attack, and he was afraid that he would also have a heart attack. The next day, my colleague realized that he had experienced stress and anxiety triggered by work, and he had never experienced anxiety before. He called the HR office and claimed workers' compensation, and the district staff member recommended that he try to get his money back from CHOMP, since this was now an active workers' compensation case. CHOMP cannot charge a patient in a workers' compensation case that is active. So my colleague called CHOMP and explained his case to multiple staff members. He asked to speak to a manager, and he spent about an hour on the phone twice. After 2 phone calls, CHOMP returned the $5,000 to my colleague's credit card, and my colleague wondered, why didn't CHOMP send a bill to him in the mail a few days later instead of traumatizing him further in the emergency room bed over his personal finances? CHOMP staff had no explanation for the wildly different costs for their care, from $25,000 to $19,000 to $5,000, or the reason the cost was reduced. The experience with the CHOMP staff regarding payment while in the ER bed felt confusing and very much like a used car person's deal, selling a car. How can a teacher afford to pay $25,000 or $19,000 or $5,000? An ER visit bill that's $5,000 is approximately 1 month's salary for a teacher. And isn't it interesting that a patient is able to pay now for a bill that's only 1/5 of the original bill? So if you're able to keep the lights on, CHOMP, for $5,000, why would you charge $25,000? Thank you.
Thank you. We're looking to members of the public online. We see no raised hands at this time, so we'll turn back to the room here and see if there's any more public comment on the executive update. Seeing none, we'll turn it back to you.
Okay, thank you. Let's go then into approval of our meeting minutes. I think they've been provided to the public and to the board. Are there any edits or changes to those minutes? And it's just the June minutes. All right.
Move approval.
Okay.
Second.
Okay, can we take, oh, public comment first? Any public comment on the minutes?
Okay, then we'll take a roll call vote.
What?
David Carlisle,
Aye.
Sandra Hernandez, Rick Kronick,
Aye.
Ian Lewis,
Aye.
Elizabeth Mitchell,
Aye.
Richard Pan,
Wasn't present.
Yeah,
So I could
I
abstain.
think for both, yeah, I think
I would abstain. So I wasn't present.
abstain. Yeah, abstain. Okay. Have that record show.
and Mark Galley.
Aye. Yeah. Okay. Thank you. All right, moving along to our next item. This is the advisory committee member presentation. Is that CJ?
Yeah.
Okay.
Good morning. My name is CJ Howard, the Assistant Deputy Director over the Healthcare Spending Targets branch within OCA. We have the one action item today, which is to fill the vacancy in our advisory committee that was created when Yvonne Wagner resigned her appointment in May. She was in the hospital category representing the rural hospital district and rural hospital perspective. Her term was set to end June 30th of 25. We received 9 submissions of interest to fill the vacancy, and the subcommittee met and recommended the appointment of Travis Lakey, the CFO of Mayor's Memorial Hospital District in Shasta County. If we go to the next slide, this is what the makeup of the advisory committee would look like if Travis Lakey were to be appointed in the hospital category. And then to provide some demographics on the advisory committee and the makeup of the advisory committee. And I'll remind the board that the first time that we appointed the advisory committee, we did not collect demographic information. This is something that we will be doing ongoing. So just when you see half of the advisory committee as blanks, that is why. So next year, when we'll have gone through a full cycle, we should have better, more complete demographic information on the makeup of the advisory committee. So there's 7 females, sorry, 7 males, 9 females, 12 that are unidentified, and then we have 3 that indicated LGBTQ. And then if we go on to the further demographics in terms of race and ethnicity, you can see the breakdown on the slide. You could go to the next slide for county of residence. You can see that there's broad demographic representation across the state of California. And then lastly, I'll present the draft motion of the advisory committee, which is to approve the appointment of Travis Lakey to the hospital vacancy. The appointment would just run out Yvonne Wagner's term so it would term on June 30th of 2025. And just to remind the board, I would be eligible to reapply and for reappointment, and that we have not set any precedent for term limits. And with that, I would like to ask Richard Pan and Elizabeth Mitchell if they have anything that they'd like to add, as they were the fearless leaders on the subcommittee for this.
Thank you so much, CJ, for the presentation. Again, we had a chance to review all the applications. Certainly many good candidates. I think in my mind, Travis stood out not only given the fact that he represents a rural hospital and up in Northern California, and also has relationships with other folks, but also his sort of community connections as well and work. So I know that some of the discussion centered around beyond his role as a CFO in a hospital, does he think, but certainly his application indicated a lot of his community involvement as well. So I think that sort of helped him rise to the top, and appreciate your support for this nomination. Thank you.
I just wanted to add thanks to the staff. I thought this process went really well. We are improving and moving faster. And we had really strong candidates, which was also really encouraging. Richard and I sort of tied, but I believe that we do have a really good fit on for this person for the vacancy we had.
And I just want to second Elizabeth's comments to thank the staff. I think they did a really good job in both, getting candidates, vetting them, preparing them so that we could have a discussion, I think a very thorough discussion and come up with this recommendation. Thank you.
Sandra?
Yeah, I want to thank our colleagues, Richard and Elizabeth, for continuing to serve in this capacity. It looks like a great candidate. CJ, I just wonder, on the demographic data and the representation data, I know we're collecting it as we go. Is there any way to go back and look at the entire committee and really just survey them so we have a better sense of roughly half of the committee's representation, geography, et cetera?
Yeah, I don't see why not.
Okay. Yeah, go ahead, Richard.
So part of the reason we have half is because we had a cycle, people had to be reappointed. So, and again, thanks to the staff with the reappointment process, we will get the remainder of the advisory committee members. So even the ones who are, so anyone who's up for reappointment has to reapply, and we are now collecting that data. So I guess we could go back, but you will have it at the next cycle because that'll cover essentially the rest of the advisory committee.
So we'll get it. I'll just echo the thanks and Elizabeth and Richard's second of the fact that the process is better. Sounds like we have a long-lasting subcommittee. Right? I mean, in the world of we're looking for takers. No, but really thank you on behalf of the board for continuing to help us keep the advisory committee as strong and well representative as possible. Okay, before we take a motion on this, want to see if there's any public comment on this item.
You want a motion, Mark?
Sure, we can do motion.
I'll
We
move
go- Move it.
Second.
Second, public comment.
Okay, then shall we take a roll call
Please.
vote? All right. With that, David Carlisle,
Aye.
Sandra Hernandez,
Aye.
Rick Kronick,
Aye.
Ian Lewis,
Aye.
Elizabeth Mitchell,
Aye.
Richard Pan,
Aye.
Mark Galley.
Aye. Thank you all. Okay, we are now moving into our fifth agenda item, or 5A, variations in healthcare spending, prices and premiums across California.
Thank you, Chair Galley. CJ Howard and I will present on this item. So before diving into this agenda item, I would like to first recap some of our earlier discussion from our February 2024 board meeting where we considered the effects of healthcare spending on employment-related outcomes at the individual level. We found that high and rising healthcare costs were associated with various negative outcomes, including but not limited to reduced probability of employment, lower wages, lower total compensation, and reduced benefits, as well as that adverse health events were associated with increased out-of-pocket medical spending, higher rates of bankruptcy, and unpaid medical bills. In a state as large as California, we know that these effects may be more severe or less severe on everyday Californians, depending on where they live. To better understand healthcare premiums, spending, and price variation across California, the upcoming sections of our presentation today compare California to the rest of the nation, compare metropolitan areas in California to each other, and then drill down into how this variation looks in Monterey County. So here on this slide, we begin with an overview of data sources. These include the Healthcare Cost Institute, or HCCI, Healthy Marketplace Index, or HMI, California Department of Finance, the U.S. Bureau of Economic Analysis, CMS, or Centers for Medicare and Medicaid Services, and then various HCI data sources. While existing publicly available data can shed light on healthcare spending, prices, and premiums in California, it does include many gaps. OCA's charge is to collect more comprehensive data. As we collect and analyze new data, we will share insights with the board and the public to increase transparency on variation across the state. Next slide. So just want to provide a little more detail on the Healthy Market Index, which I mentioned is operated by the Healthcare Cost Institute. So HCCI is an independent nonprofit that collects and aggregates employer-sponsored claims data from 4 health plans that they're listed here. HCCI's Healthy Marketplace Index project focuses on drivers of local healthcare spending, including factors such as price and use and service mix for major urban areas across the U.S. from 2017 to 2021. Data for California is available for 13 regions, which they call core-based statistical areas, or CBSAs. We've provided a definition of CBSA on this slide. Next slide. And then for the purposes of our discussion today and to ensure we have a shared understanding of the language we'll be using, this slide offers a set of definitions to keep in mind as we move forward. So I'll start with premiums, which are the amount paid on a monthly basis by a consumer and or employer for health insurance. Spending refers to the amount spent by or on behalf of consumers on personal health care. This may include hospital services, clinical services, copays, deductibles, and prescription drugs. And then lastly, price is the amount a healthcare entity or provider is paid for a healthcare service. Next slide. So I'll turn it over to to CJ to cover the next set of slides.
All right, our first subsection of slides looks at healthcare premiums by comparing California to the nation. Each of these sections, premiums, spending, and price, will follow roughly the same structure. That is, there will be a section that has key takeaways and then a set of slides following that serve as evidence for the takeaways. This first section's short, as we'll have covered California and CalPERS, providing additional information on premiums in subsequent presentations this morning. So the first set of key takeaways related to healthcare premiums. California self-only and family premiums and deductible growth are consistent with national trends for the years 2013 to 2022. I'll start with trends in family insurance. Nationally, premiums increased by 37% and deductibles increased by 53%, compared with California, where premiums increased by 33% and deductibles increased by 53%. Turning to trends in self-only insurance, nationally, premiums increased by 36% and deductibles increased by 56%. Compared with California during the same time period, premiums increased by 35% and deductibles increased by 51%. And the next two slides will look at the trends in terms of dollar amounts. So as we look over the same period of time from 2013 to 2022, across the US, as shown in the orange, premiums increased by $5,902 and deductibles increased by $1,320. The trend in California, as shown in the blue line, mirrors the national trend, with premiums increasing by $5,581 and deductibles increasing by $1,273. In the next slide, when we look at the self-only insurance between 2013 and 2022, at the national level, as shown in orange, premiums increased by $2,019 and deductibles increased by $719. Meanwhile, in California, as shown in blue, the premiums increased by $1,966 and deductibles increased by $614. Next slide. We'll now move to reviewing healthcare spending by first comparing California to the nation and then comparing various California metropolitan areas. Our key takeaways about healthcare spending in California are as follows. First, California healthcare spending as a share of gross state product shows an upward trend in line with national levels. Per capita personal healthcare spending in California was above the US average in 2020. From 2000 to 2020, per capita spending in California increased by 5.4% on an annual average basis. And finally, overall spending increased for most California metropolitan areas from 2017 to 2021. In this slide, from a previous board meeting that we've brought back to contextualize California healthcare spending for our discussion today, here we look at healthcare spending as a share of gross state product and gross domestic product. Between 1997 and 2020, personal healthcare spending as a share of gross state product grew by 3.8 percentage points, from 9.6% to 13.4%. Nationally, personal healthcare spending as a share of gross domestic product grew by 4.4 percentage points, from 11.3% to 15.7% during this period. In this next slide, we also compared California per capita healthcare spending to the US average as well as to other states. We see that in 2020, per capita personal healthcare spending in California was above the US average. It was $10,299 in California versus $10,191 for the national average. And this next slide, combining data from CMS as well as the California Healthcare Foundation, allows us to chart average change in per capita healthcare spending growth in California across various time periods. Here we see per capita healthcare spending growth in California for 4 different time horizons. So for the five-year period from 2015 to 2020, average change in per capita healthcare spending was 5.2%. From 2010 to 2020, the average change was 4.7%. From 2005 to 2020, the average change in healthcare spending was 4.8. And from 2000 to 2020, the average change in per capita healthcare spending was 5.4%. On the next slide, employing the same data as the previous slide, we compared overall healthcare spending with Medicare, Medi-Cal, and private insurance. From 2000 to 2020, overall per capita healthcare spending increased by over 5% annually. Over that same period, the Medicare spending grew annually by 4.1%, Medi-Cal spending grew by 4.6%, and private health insurance spending grew by 5.1%. To gain insight into the regional variation in the state, we mapped the change in healthcare spending in various California metropolitan areas between 2017 and 2021. Our map and companion table highlight that most California metropolitan areas experienced spending increases compared with the national median, with the highest being Stockton Lodi at 33% and Santa Maria, Santa Barbara, 32%. Three areas, Oxnard, Thousand Oaks, Ventura had negative -1%, Visalia, Porterville -1%, and Bakersfield -26% spending decreases. That I will hand it back to Shaw to cover healthcare prices.
Our third and final subsection of content looks at healthcare prices by first comparing California to the nation and then comparing California metro or metropolitan areas to each other. Next slide. The key takeaways about healthcare prices in California are as follows. Average prices paid for healthcare services in California were the third highest average compared to other states in 2021. California had the lowest average utilization among US states in 2021. Average prices paid for overall, inpatient, outpatient, and professional healthcare services exceeded the national median for most California metro areas in 2021. And finally, most California metropolitan areas paid for double-digit price increases from 2017 to 2021. Next slide. So in comparing healthcare prices in California to the US median and to other states, we find that California had the third highest average among US states in 2021. Next slide. And then when we compare healthcare utilization in California to the US median and to other states, we find that California had the lowest average utilization among US states in 2021. However, I do want to acknowledge that some utilization may be underreported in highly capitated states like California. This is because some healthcare encounters are not captured and reported, unlike in claims-based healthcare systems in which a claim is necessary to render payment. However, it is generally agreed that irrespective of underreporting, utilization rates in California are lower than other states. Next slide. So the intention of the next series of slides is to drill down on this topic of prices at the more regional level. Here we compare overall healthcare prices in California's metropolitan areas to the US median. I do want to know overall prices are a measure of the prices people pay for the same set of services across the country. We find that healthcare prices in most California metro areas were above the national median. In fact, the statewide average was 36% higher. Of note, the highest price areas are San Jose, Sunnyvale, Santa Clara metro area, and the Salinas, Monterey metro area. And the percentages are 92% and 84% higher than the national median. Next slide. So moving on to how inpatient prices across California compared to the national median in 2021, we see that most California metropolitan areas were above the national median. with the statewide average being 56% higher. Once more, Salinas Monterey was at the top as the area's inpatient prices were 163% higher than the national median. Next slide. So shifting gears to looking at outpatient prices across California compared to the national median in 2021, we again see that most California metropolitan areas were above the national median. The highest areas were the metropolitan area of San Jose, Sunnyvale, Santa Clara, with the percentage being 120% higher, and Salinas Monterey metro area at 110%. Next slide. So in terms of professional services and their prices, not all California metropolitan areas were above the national median. In fact, two areas, Fresno and Visalia, were below the national median. The highest areas are San Jose, Sunnyvale, Santa Clara, and San Francisco, Oakland. Next slide. So our last slide in this series examines overall prices for a longer time horizon, the 5-year period from 2017 to 2021. As a reminder, overall prices in this context are the prices people face for the same set of services across the country. Compared to the national median, we see that most California metropolitan areas experience double-digit price increases. The highest areas are Salinas, Monterey, and Santa Maria, Santa Barbara. And with that, I turn it back over to the chair.
Great. Both CJ and Vishal, thank you. Let's go around. I'm just going to actually do a loop. I'll start with you, Richard, and come back and end with you, Ian, to give people a chance to ask questions. And I'm going to do that basically for each agenda item, so we can give everyone a chance and try to stay as organized as possible and leave as much time for public comment. So with that, Richard, go ahead.
Right. You actually wanted to start with me. Okay.
Yes,
All right.
absolutely. We'll start with Ian the next time, and then I'll
Okay.
do Sam. I mean, we'll mix it up, but
All
this
right.
time you go first.
I did have several questions. And again, thank you for the presentation. First of all, on the price increases and premium increase, so forth, are those adjusted for inflation, or is that just the raw number? Because you're talking about span of time, like 97 to 20, so it's spanning over a couple decades or a decade and a half. For those. So on the premiums.
For the premium numbers?
Yeah, for the premiums and some of the other
Yeah,
ones.
they tend to be the nominal numbers, I believe. Yeah.
They are adjusted for inflation?
No, the
okay.
nominal numbers.
Okay, all right, okay. So that might actually be helpful to do that. In terms of on the premiums on the deductibles, is that the actual spend on deductible, or is that, this is the deductible on your plan and so forth? So is this, I know it's from the MEP survey, I'm trying to think, that's actually what people actually spent on deductibles, or is that actually based on, well, your deductible is going to be X on your plan, so you may or may not have spent it depending on whether you have a chronic condition or not.
Yeah, it's their out-of-pocket obligation, but it's not necessarily
Okay.
what they accumulated towards the deductible.
Okay, so it's potentially, but it's not what they may have actually spent. Okay, that's helpful to understand as well. And then, on the spending part, and I know I made this point before, is that I think there is a little bit of a difference pre-ACA and post-ACA. Okay, I know you just put 20 years, but I think we need to acknowledge the profound impact the ACA has had. There's some indications that post-ACA actually spending as a percentage of GDP, not saying that people's out-of-pocket stuff did increase, sort of flattened out a bit. I did note that you have this little bump up in 2020. When I looked at some Kaiser Family Foundation data that went off the next year, there was a bump one year and it came back down again as a percentage of GDP. So I just wanted, I appreciate you picked 20 years, but I think, ACA, especially after implementation, so passed in 2010, implementation took a couple of years. I think, those reforms did have an impact on the marketplace. And I think, and so I think it's important to make note of that. I mean, it's a pretty substantial, it's probably the biggest thing that happened since Medicare, Medicaid back in the late 60s. So I think, we need to make note of that whenever we start doing projections going back decades, because we have pre and post ACA. I think it's important to see if there are differences there. And then in terms of sort of spending per capita, in fact, I would make note that California's probably average age is actually a little younger. I think an age adjustment would have been helpful to look at per capita, just because, again, if you have an older population, going to have more spending, more same utilization, et cetera. Younger population, probably less so. I mean, I think there's pretty sound basic data on that. So I don't believe that information on both spend and utilization by state was age adjusted.
The CMS numbers, yeah, I
Okay.
believe they don't adjust. Yeah, and Rick
Okay.
is not, board member Rick Kroenig is nodding his head, so. Yeah.
Okay, yeah. So I do think that provides some insights into, because all the states aren't, if all the ages distribution is slightly different state, whether it's substantial enough to make a difference or not. But I think it's something worth investigating. And then actually, when you talked about spending per person, sorry, I'm going through this pretty quickly. On Medi-Cal, did the Medi-Cal spend include the long-term care component, which is what a good chunk of the spending is, or is that just simply so? Because like Medicare wouldn't have a long-term care component, right? And the commercial insurance wouldn't have So is that Medicare per person spend include the long-term care part of Medicaid, which is of course, pretty good chunk of money.
The Medicaid numbers does include long-term care.
Okay, all right. So when we look at the rise and so forth, I mean, I think again, little asterisks there on the Medicaid part, because if it includes long-term care and the other ones don't, it's something to think about. And then in terms of the healthcare prices, again, appreciate the presentation. I think we need to acknowledge I don't think it accounts for all of it. So certainly one can argue that, we still spend more, but the cost of living, right? Because that's going to affect cost of labor. It's going to affect, how much you have to pay utilities, so forth. And, California's approximately what, 40%, 35, 40% higher cost of living than the national median average. So when we talk about comparison to the national average, I think we need to account for that, because that's going to impact a lot of inputs into the healthcare side of things. So I don't know if there's some thought about that. And then, of course, there's going to be variations within the state itself, right? So California is not homogeneous in that regard either, in terms of cost of living.
Yeah, I would say for the per person healthcare spending measure that we reported from the Healthcare Cost Institute.
Yeah.
So there's many factors, as you noted. There's price, how many services people use, the types of services people use. And then, one services in one area may on average be less expensive, and it could be the intensity or service mix. Sure. And then market and demographic factors is also what they notice could influence prices and patterns of care. Yeah. That would be in the mix for the variation that
Sure.
we're seeing.
Okay. Well, I appreciate that. I mean, I think, first of all, there's other factors. The increased cost of living, or I guess cost of living doesn't certainly account for the entire, because it's actually our rates our spending is actually higher than even adjusting for cost of living, at least based on some estimates of cost of living differences. But I think it's important to acknowledge that at baseline, when we're comparing to the quote national average, that we probably need to say, well, if you put cost of living there, our increase isn't quite as high, but I mean, it's still there, and there's still issues with, as you said, point out, there's lots of other factors that go in, but I think it's important to take out sort of the bigger factors that may account for some of that, so that we're not chasing the wrong thing or giving people the wrong impression. But I think I could certainly keep going, but I'm going to stop here and appreciate the opportunity. Thank you.
Yeah, no, thank you. And I'll just sort of, as I listen to the questions, there's a theme about nuance in the data and the importance to acknowledge some of the factors that might influence what that information shows. But I appreciate your last point, which is the trend line matters, where it's going, and it isn't, the nuance shouldn't distract away entirely from the fact that there are things to be done and addressed, but it might actually, paying attention to that nuance guides us towards, what might matter the most here. And I appreciate that. But overall, I think acknowledging that so much of what you shared is rich and important for us to focus on. All right, David.
Okay, well, great presentation, great analysis, great data. I thought it was really illuminating. I wanted to respond by invoking the memory of the late health economist Uwe Reinhardt, who many of us know and love and miss, and invoke his 2003 article that basically said "It's the price is stupid," I think was the title of the article. And then just a few years ago, another health economist, Gerald Anderson, published another article after the passing of Dr. Reinhardt. Basically said the title is "It's Still the Price is Stupid." And this is kind of driven home by, I think it's the difference between slide 42 and 43 in the data you presented. Looking at California's situation, we have succeeded in lowering utilization significantly in the state of California compared to other states. This is probably a historic one-time change with the advent of managed care, where we lead the country some years ago, perhaps. Then you contrast that with the slide that follows or precedes it, slide 43, and our prices are the highest in the country. I was somewhat reassured by slide 35 that I think showed that our relative to GDP, our expenditures are low, but then I realized that California's state GDP is among the highest in the country. So maybe this isn't so reassuring after all. My final comment is more of a geographic comment. I know that the CBSAs are probably coming to us rather than developed within the state. It was just notable to me that the entire northern third of the state is not captured. And even though that's a low population area, quote, frontier area, maybe the county of Shasta, which contains the city of Redding, could be a useful economic indicator that could provide some insight on cost over that entire region of California. So I'll stop there. I could keep going because this is great data. Thank you very much and great presentations.
Before you go, I'll just acknowledge, reminder, everybody probably caught it, our new advisory committee member is from that region. So hopefully his voice will help represent some of those concerns and opportunities to look into. All right, Don.
Yeah, I don't have many comments. It's a great presentation. We'll be, I think, digging in and talking about how our data looks similar and different, but largely similar. I will say just on the Northern California part that we also for a long time struggled to capture it. We've transitioned to the units that we use to measure to GRVU, which has helped us get a window into the north, but it's a scale issue but that may help with some of this analysis of looking at some approach other than a market basket approach.
Great, thanks, Don, and looking forward to hearing from you and Jessica next. Rick, go ahead.
Thank you for the presentation. A lot of really good information. A few comments, one question. First and most obviously, just to kind of emphasize, and we're going to hear this from Jessica and from Don and from Chris, but you have said you've presented that prices are really high where we are here now. And just to kind of emphasize that, that's for me the most salient piece of what you presented, and thank you for doing that. Back to Richard's comment, and if we could go to slide 35 again, which I know you had up a minute ago. We have come through a sort of very calm period in healthcare spending. And even with that, we have, $5,000, much less $25,000 for a 10-minute visit in an ER. But, these data show that from 2010 on, with the exception of that, and Richard is right, the 2020 bump was a one-year bump. 2021 comes back down to the 2019 level. We've been through more than a decade of flat healthcare spending as a share of the gross domestic product, and we still are in this unaffordable space. And although projections are always uncertain, the projections, national projections from the Office of the Actuary for what they're worth is that healthcare spending will go back to increasing as a share of gross domestic product. So just to say, we've been in good times and we're still here in terrible times. And to emphasize, I think, the importance of the work of the office and the board that we kind of need to make progress on this. And on that, though, if you go a couple more slides, what number? Sorry. The slide with Medicare, I guess it's slide 38. Yeah, thank you. Similar sort of story that on the Medicare spending per capita, it increased very quickly from 2000 to 2010. And then, and these are nominal dollars. If we were to adjust for inflation, it would show almost zero for a decade from 2010 to 2020. And at the risk of relitigating old fights, the overall increase in blue more rapid than any of the others, and that's because more of the population, or largely because more of the population is moving into Medicare, and so there's a sort of upward push from aging. And then very lastly, just a question on your last slide, on slide 39. This says difference from the national median. Is that correct title? Is this difference from the national median, or is this price growth?
That should be correct. It's
That our prices are statewide going up 12% faster than the national average, or do they go up?
This is overall spending.
Yeah.
Yeah, so we have different breakouts for price. Overall spending, per person spending. Yeah.
Not difference from the national median. That per person spending went up by 12% faster than the national median, or went up by 12%?
Yes. Went up by 12%.
Faster.
Faster. Yeah, it's comparing the CBSA number to a national number and taking the difference.
So it went up 12% faster.
Yeah.
I guess this is sort of the nuance. It would be useful to know just how much did it go up.
Yeah.
Right. Thank you. So thank you for the opportunity to comment and for the presentation.
No, I'll just say two things. The comments are, there are some, I think, either recommendations or requests to look at data in slightly different ways, or change some of the labeling and make sure it's clear. So hear those loud and clear. And then just the point, we're happy we're here, right? Like, this is important work for us to be digging into because of the information that these slides have shared. Sandra, go to you next.
Yeah, I thank the team for the analysis, and notwithstanding the nuances, I would make two comments. One, there's a reason why this organization exists, and this data in many ways underpins very much the role of OCA in this space. And secondly, to say we've heard the personal stories since really our beginning about the particular impact it has on folks that live here and in this region. And so this data, along with the personal stories, really speaks volumes. And I think the opportunity that we have and that the team has to begin to address the particular challenges we have in this region, and perhaps other regions as well, as the data would indicate, is really quite compelling. And so notwithstanding all the nuances of the data, the impact to consumers is extraordinary in this region, and really, I think, compels us as a board and as a team to try to figure out how we begin to use the tools that we have to address it. So I want to thank the team for that, and for the economists who have been saying this now for some time. The data just continues to speak for itself. So thank you.
Thanks, Sandra. Elizabeth.
Thank you. I was struck by the same information is Dr. Carlisle, when you see that we are low on utilization and yet high on cost, it really is the price is stupid. It goes back to that same premise. And I just would like us to keep in mind that it, recently there is new pricing data available through the CAA. So we're going to get much more granular pricing data that I think will really inform this. We're actually doing a pilot on that. So we might be able to share something in December or January to really see where exactly those prices are coming from. But my other point is, if these are the best of times, we are well into far worse times, because 21, 22, 23, 24 are seeing much higher premium increases. There's estimating like 9% average commercial increases this year, and we're having members seeing as high as 20, 25%. So I think that this is almost a rosy version of what we're headed into right now. And again, just underscores the urgency of this work.
Great, thank you. Ian?
Yeah, we've seen a lot of shocking data over the year and a half that we've been meeting, and this is jaw-dropping to me. We pay the highest prices on planet Earth in the United States, and to see many important parts of our state are paying near double those prices. And in this county, Monterey is paying 2.5 times the already too high average of the US for inpatient is untenable. And I point out that these are commercial prices. Medicare and Medicaid set their prices based on some calculation of what the appropriate cost of care is. We can argue how close they come or not, but these are the prices paid by the 17 million Californians who rely on insurance connected to their work. And so to me, that's a regressive tax on working people in the state. It puts a drag and pressure on every industry, on employment, as well as all the working families in this room and elsewhere. I guess a question about the overall prices slide. My impression is that doesn't include the cut that insurance companies take, right? It's on my slide 44. Yeah.
Yeah, these are prices for healthcare services, so it wouldn't include the health plan administrative portion or administrative and profits portion.
So on top of the high prices we're paying for inpatient and outpatient and professional services, we're paying the insurance companies. So back on the slide that shows the average growth of premiums and deductibles over time, we're paying more and more in insurance and getting less and less from insurance. Do you have any calculation of how much insurance has gone up if it had held steady, the value of the coverage? If deductibles had not gone up, insurance premiums presumably would have gone up quite a bit more.
Yeah, we don't. Is the question about if, because at least, increase kind of shifting the cost to employees has been a result of higher healthcare costs and, higher and higher deductibles as a result. But we're not aware of kind of any analysis addressing your question.
Yeah, we can look at that, Ian, but I think it's an important point, right? Is that as the premium, we're shifting so much more to consumers, and as a way to keep premiums down, and yet they've gone up so much, but the deductibles are truly so unaffordable for consumers.
So I get there's nuance with health plan data and so forth, although some of these other states also are heavily health plan saturated. It's not a shock to me that utilization is low in California. I thank the staff for putting these slides out there. They are incriminating. Thank you.
Okay, thank you all. I'm going to come back because it's important for us to be able to respond, or very brief comments from the board. Additional ones I saw Elizabeth going to the mic, David going to the mic. Please jump in. Elizabeth first, David second.
Just very briefly, I think it would be really helpful for this board to look at administrative costs and profits. I mean, the earnings calls of some of the health plans right now are really quite shocking. So I think we should look at both.
David, go ahead.
I certainly agree with all the comments. Thank you. I wanted to follow up on Ian's focus on slides 31 and 32, I think it is. I know that a lot of our public comment has had to do historically with out-of-pocket cost and the increasing burden there. But what I was surprised to see, given the increased prevalence of high deductible health plans, especially in California, but nationally, is that there's been no significant change or change in slope in the graphs on slides 31 and 32, or 32 and 33 in the past couple of years. I would have expected to see an increase in deductibles during this time because of these high deductible health plans. And it's really a question as to maybe why. There may be a dampening effect for numbers or something.
From the team.
Yeah, that's something we could explore. Yeah, I'm not sure kind of what's driving that. Or
I mean, the previous slide shows that they did increase by more than 50%. Well, that's between 2013 and 2022. I mean, these deductibles are going up, right? They were 2,400, 2,500 in 2013 and 3,800 in 2022. That's a pretty big change. Almost a 50% increase. That is a 50% increase from 2013.
oh, it's just the line looks a little.
Yeah,
Okay.
yeah. And I mean, the trend towards high deductibles has been going on for a long time. It's not just the last 5 years. Right?
Richard.
Thank you. I think a couple of things to think about that aren't necessarily reflecting these slides. And I appreciate what Ian said about the sort of the administrative costs layering on top of that is that also over time, they've not only, of course, there's the increased administrative costs at the plan side, they've actually pushed administrative costs to the practices, which actually gets counted as medical. So when we think about prior authorization, well, that means a practice is having more staff spend more time on the phones trying to get, but that's counted as medical cost. And we've talked about this before, but it's not just the overhead on the administration side, on the plan side, it's the increase in administration time on the provider side. By the way, again, I will reiterate, the typical primary care doctor only spends 28% of time, there's been 2 studies already, on clinical work. Right? Only 28% of their time, right? We could double our primary care workforce by allowing primary care doctors to spend actually half of their time doing clinical work. We're not even talking about majority, half, we can almost double our primary care workforce. So we have, we need to look at that aspect. It's hard to capture. And then the other issue is, as we've seen this rise in deductibles, part of the reason for deductibles, if you go back to the RAND insurance study, is that it did decrease utilization. But interesting enough, it wasn't that it was having a deductible. It wasn't having a large deductible actually made much more of a difference than a smaller deductible. There's a little difference. And so, and what we do know is when you have larger deductibles, and oftentimes they do exclude preventive care, but it decreases use of preventive care. And in fact, the RAND insurance study showed it just didn't decrease unnecessary care, actually decreased necessary care. So I do wonder this increase in deductibles, and I did ask the question, is that actually what people spent? But frankly, it's a hit on people with chronic conditions, which actually is where we spend about 80% of healthcare dollars. And what it's doing is that's preventing them from getting care. And therefore, now when they finally get care, because eventually you do, it's more expensive and more intensive just because you basically people aren't getting it at the beginning. And so I think there does need to be a closer examination of this rising deductible, even by our insurers, about is it really working or not? It doesn't seem to be decreasing. I mean, maybe our utilization is decreasing, but it doesn't seem to be decreasing our actual spend, because eventually people hit it and then, the plan has to cover it. But what happens when you lead up to that point, especially the deductible portion versus the copay? Not to say copays aren't a problem themselves. I think there's been a lot of studies shows that deductibles actually aren't very particularly effective in actually making people think about their healthcare, unnecessary utilization. And in general, again, the Rand Insurance study did not show that, and that's sort of the, I guess, the granddaddy of all of them.
Should take the advice I'm about to give all of you, speak up and speak more slowly so we can support our translators if possible. So, yeah. First, I just want to appreciate just the really rich discussion around the table. I think it's so important. I'm reminded that we're not the Office of Healthcare Prices. We are the Office of Healthcare Affordability for a reason. And all of this data in the face of the stories, and many of you said it here, I think it just doesn't add up, right? It doesn't help people live the rest of their life and take care of their health. And I think that's why it is so compelling, this information. I'm struck by, I'll just highlight some points that have already been said. The almost back-to-back slides that show California at the bottom of utilization and the highest prices. We got to understand that a lot better, because it's to the point of value. What are we getting out of what we're paying for? And I think this is a key question Californians probably ask every time they open up their paycheck and wonder what those dollars went to. So as we sort of move into the next part of our discussion, we're really lucky to have some folks who are on the board, Don, and then other folks, Christopher and Jessica. I'll let them introduce who they are specifically, but we chose them both because of their real understanding of what the national scene looks like, but also their deep work in California and the organizations that they represent that do this day in, day out to figure out how to get the best value for the people that they're purchasing healthcare for. And as a member of the Covered California Board and working closely with Jessica Altman, who will come up in just a minute, that's a role, and Sandra, who's been on that board with me before, that job is not only taken so seriously, but I think the way that Covered California has pushed across so much of the state is impressive, really being the leading edge in some ways. But I will also say part of the reason why we're here and I'm compelled to be here is because the success in pushing in this county specifically has not been as successful, has not been as rich as in some other parts of the state. And I hope that is part of the story that we'll have a chance to get into a little bit. So with that, I don't know how we're structuring the panel. I'll turn.
Yeah, we'll turn it now to Jessica Altman with Covered California. And just a note, we'll hear from Jessica Altman and then Don Mold, and then we will be taking public comment on both the presentation you just heard and on their presentations. Thank you.
Again, Don? Yeah, go. Obviously, this is a long, fluid meeting. We do have a planned break after lunch, but none planned now. So we're gonna just keep on chugging through. Jessica, take it away.
Good morning, everyone. Can everyone hear me okay? Okay. Well, I just want to begin by saying thank you for having me here. Thank you, Dr. Galley, for your leadership on our board, but also for recognizing, I think, Covered California's leading edge ways in so many ways in healthcare in the state. Want to thank all of the board members for being a part of this important work, and in particular to Elizabeth, to Vishal and the team. You've been incredible partners at the state level, and we're just so proud to be doing this work hand in hand with you as we all work to really tackle cost and the word so near and dear to Covered California as well as to OCA affordability. So my name is Jessica Altman. I have the privilege of serving as the executive director of Covered California. For those, and I'm sorry, who runs the slides? Okay, thank you. You can head to the next slide. For anyone that is not familiar with Covered California, we are the individual marketplace offering in every corner and every region of California. We cover well over 1.7 million Californians, in fact, achieving the highest enrollment ever before in the last open enrollment period we closed earlier this year. And this makes us, alongside Dawn and CalPERS, one of the largest purchasers in the state of California for healthcare. Overall, we provide a place for Californians that need coverage to buy it for themselves and for their families, and we are the only place that they can receive financial assistance to buy that quality, comprehensive coverage. Our mission is to increase the number of insured Californians, improve healthcare quality, lower costs, yes, and reduce health disparities through an innovative, competitive marketplace that empowers consumers to choose the health plan and providers that give them the best value. But as we'll talk about here today, as we strive to do that again in every corner of the state, it is harder to do in some parts of the state than it is in others. Next slide. We are incredibly proud as we talk about the role of Covered California, the progress we have made, that we have significantly reduced the uninsured rate in California, really delivering on the promise of the Affordable Care Act and building on it like no other state in the entire nation has done here in California. And the end result of that has been the largest percentage decrease in the uninsured rate of any state in the entire country, and the lowest uninsured rate in California on record based on the 2022 data, the most recent data. Next slide. A little more background, we are a true active purchaser. This is not true of really any other marketplace in the country, and that means that we negotiate with each of our health plans on behalf of consumers to deliver the best value. We negotiate premiums, we negotiate what they are doing to improve healthcare quality and access, and all of these different elements that make their way into our contracts and our discussions and our accountability with our health plans. We currently have 12 health plans offering coverage on Covered California. 2 are statewide, and the other 10 are regional, depending on their footprint. And we are proud to offer a mix of HMO, PPO, and EPO products, providing different network model choices to our consumers. Many things, because of our active purchasing, many things in our marketplace are standardized. We standardize what benefits you have to cover. We standardize your cost sharing, including deductibles. We like those to be low, as we've talked about today. And so what that results in is our health plans are really competing on the things we want them competing on. What are their provider networks? What quality are they bringing to the table as a health plan and through the providers that they generate access to? And so that's really where our carriers are focused and where we are focused in working with them and delivering coverage. I will note one thing that just flagging a difference to my presentation and Dawn's, we have 19 regions and we set prices separately for each of those 19 regions. You'll hear me talk a lot today about Region 9, that is the region inclusive of Monterey, inclusive of Santa Cruz, and Dawn's are a little bit different, more at a northern, southern, or even statewide basis, so it'll look a little bit different there. Next slide. So again, we actively negotiate rates. We sit down with our health plans and talk about all of the factors that are contributing to changes in premiums, including at a very regional level. Premium differences across regions capture variances in key factors like, is the provider reimbursement in that region different than in another region? Is the population in that region using more healthcare or need more healthcare because they're on average more sick than others? And so as we look at regional variances, I think we're all here trying to understand which of those factors is driving these differences in regional results. So just for 2025, we recently approved preliminary rates with an average of 7.9%. 3 regions had double-digit increases significantly higher than that average. Region 1, which is Northern California that you were just speaking about. Region 11, which is Fresno, and then Region 9, again, including Santa Cruz and Monterey, which is pretty much double the statewide average and the highest increase we're seeing this year by a significant margin. Looking at 1 year is never perfect. So on the next slide, I have an average over the entire existence of Covered California from 2014 to 2020. and 25. Here, you can see, for example, Fresno, an outlier on the last slide, actually an outlier the other way on this slide. So over that full time period has less of an increase than other regions. But Region 1, again, a very rural area with unique challenges as well, continues to stand as an outlier. And our only region averaging double digits over that time is, again, Region 9. Next slide. So we're candidly not surprised, we've never done this particular data analysis before, but to see Region 9 sort of stand as that outlier, given the unique dynamics in the regions and the challenges that we continue to hear about from health plans trying to offer viable and sustainable products in the region. And I'll talk more about that later. First, just to give a little bit of a deeper snapshot on Region 9 on the next slide. So again, Region 9 includes Santa Cruz, San Benito, and Monterey. We have 27,000 residents of this region enrolled in Cover California. We have 3 health plans that offer coverage in at least some of the region: Anthem, Blue Shield, and Kaiser. Kaiser offers an HMO, Anthem an EPO, and Blue Shield both a PPO and an HMO. Next slide. But of course, it is more complicated than that. So while there are 4 plan options in Region 9 across 3 carriers, only 2 are offered through the entirety of Region 9, with generally more choices in the northern part of the region than the southern. In particular, Shield has only been able to deploy their HMO in parts of the region where they can have the provider partnerships to do that. And then we are very proud to be approving an expansion for Kaiser into this region in 2025. But even with that expansion into Monterey County, Kaiser will be offering to just over half of Region 9's residents, and would note they do not have any contracts with the large hospitals in Monterey. Their contracts with hospitals are focused on the northern portion of the region. And then I do have to note, there used to be another name. Last year we had Valley Health Plan, which is a county-based health plan based in Santa Clara that had entered Region 9 in 2022 with all of the right intentions. And after being really unable to offer a sustainable product from a pricing perspective, they are exiting the region and will not be offering coverage in this part of California in 2025. And so as a result of these complexities, while consumers in some parts of Region 9 have 4 plans to choose from, many continue to only have 2. And to put that in context, 92% of Californians have 3 or more carriers to choose from on Cover California, and 85% have 4 or more. So regions like this that have fewer than 3, or even 3, but fewer than 3 with 2, this is not the norm, and in general is indicative of a region with challenging competitive dynamics, particularly on the provider side and in the region. On the next slide, we looked at premium increases. This is our actual gross premium, looking at an average across our members. Very important with Covered California to reiterate that about 90% of our members receive premium assistance. And so the actual premium does not generally translate to what our consumers are actually paying. That's captured on this slide through the difference of gross premium and net premium. But it is important to look at and think about gross premium because the relative gross premium across regions is indicative of differences in healthcare expenditures across those regions. So to call out the outliers on this slide, Region 9 is not the highest. Region 8, San Mateo, is the highest at $978 on average. But Region 9 is significantly higher than the statewide average, which is $655. So about $200 more expensive, and about $350 more expensive than the lowest cost region in Los Angeles, which I would just note is a very competitive region. Next slide. So as we begin our journey to understand why this is the case, and other speakers will tackle this in different ways, we wanted to share one of the things our data shows is not the reason. So I said earlier that one of the things that relative premium across regions captures is, are people in this region on average sicker than people in another region? And the answer in our data for Region 9 is clearly no. And in fact, on average, the risk score, which is a measure of people who have high cost conditions, in Region 9 has been substantially lower than the state overall. And from 2018 on, the average risk score for Region 9 has been 15% less than that of the state on average for the same carriers who operate in this region. And so we would conclude that health status is not a primary driver of higher premiums in this region. Next slide. So I wanted to share, what our health plans have been sharing with us about their experience in the region, and really the challenges that they have in trying to either enter the region, stay in the region, have managed care products in the region that deliver better value to our consumers. And what they have told us is that they really have challenges negotiating with hospitals, particularly in the Monterey region, particularly like CHOMP and Salinas Valley, which prefer build charge based contracts. Again, Kaiser doesn't have contracts with any of these hospitals. I would just say build charges are generally the amounts that hospitals want to charge, and that seeing contracts based on build charges, in my experience, are indicative of situations where the leverage in the negotiations is on the provider side and not on the health plan side. I would also note, so network adequacy, this is a critical consumer protection that is offered in the state of California. It is what makes sure that consumers in all of our regions have local providers that they can go to provide all the services they need. But that does sometimes mean in low competition regions that in order to meet these standards, there are providers that you have to have, and you don't really have a choice other than to figure out how can I get that contract and how can I have that so I can offer the full range of services. And so limited sort of choice, and then limited also limits direct contracts with major hospitals and complex physician hospital relationships. And that can prevent deployment of new medical groups, new clinics, innovative payment models, basically anything that can really change the paradigm. And then again, of course, in addition to Valley Health Plan, would note that Blue Shield of California has shared with us that they have considered withdrawal from this region and pulling out because of these challenges, and with certainly strong support and encouragement from us, as they are one of our statewide carriers, will continue operating in Monterey through 2025. And I expect that's a conversation that we'll have in the future. So on my final slide, I just want to summarize some of the takeaways from today. So throughout our history, Region 9, while not the only region that is an outlier in cost, has consistently experienced higher costs and premium growth compared to the rest of the state, and we would call it our largest outlier across our regions. Region 9's risk pool is generally healthier compared to the rest of the state, so health status is not a driver of premium. Consumers in Region 9 benefit from some carrier competition, but the unique dynamics related to provider networks and cost create a less stable environment than other regions, making it harder for carriers to enter and harder for carriers to stay. We are very proud to continue our role in the marketplace, one of which is keeping costs as low as possible for our consumers. We are focused on affordability in so many ways, but we are also very supportive of OCA's efforts to hold plans, providers, and others in the healthcare space accountable to meeting cost targets. This is one of the spaces where we're working to align our contractual requirements and make sure we are all moving the state in the same direction. So thank you again to Elizabeth for that partnership. And so just in close, dynamics like these in Region 9 are significant challenges for health plans and are going to impact their ability to control cost, and in particular for this group to be able to meet the targets set forth by this board. I think questions after Dawn?
Yeah,
Okay.
let's hold. We'll go to Don, but just on behalf of the board, thank you, Jessica. Beautiful presentation, a lot of rich, important data, and based on a ton of hard work. So thank you. Don.
And I will, as that's a little loud, yes, a little better. I'll just say on behalf of CalPERS, one, thanks for a great presentation, but also thank you for the ongoing partnership. It's been terrific to have Jessica over at Covered California. Covered has been a wonderful partner to CalPERS. We are trying to do as much as possible together these days, and I think have moved the needle on a number of areas in ways that we couldn't as separate entities. So thank you for that also. So I'm going to talk more broadly about the price variation that we see in California. I will be touching on Monterey County because we talk about Monterey County, not about Region 9, as Jessica alluded to. But I'll be touching on Monterey County periodically through the presentation. And then at the end, I'm going to double back and go into a little bit more detail with respect to some of the challenges that we see in Monterey. So a little bit about CalPERS. So CalPERS is the second largest purchaser in the U.S. commercial market. So the commercial market is what most people think of when they think of the employer market. So we purchase on behalf of employees and retirees. So we buy healthcare for 1.5 million people, mostly employed people, but a sizable portion of folks who have retired. About 60% of our members work for the state of California. So we have one very, very large client, and then we have a lot of much smaller clients, is our way of thinking about it. So those other clients include cities, counties, school districts, water districts, housing districts, fire districts, and they range from counties with tens of thousands of people to water districts in Northern California with 3 people who work for them. So really quite a range. It's also, I think, when we talk about the differences between the two populations, one of the things that I always try to point out is the differences in cost sharing for employees of those places. So the cost sharing formula for people who work for the state of California is set in statute. Most employees have 80% of their health care paid for, and that is pegged to our larger plans, some 90%. In a few now grandfathered instances, they have all of their health care paid for. On the retiree side, folks who are fully vested in the state of California usually have their Medicare plan fully paid for. On the public agency and school side, we have a required minimum, which is $150 or so. It goes up with the cost of healthcare, but it's a relatively small amount. And a number of those entities contribute significantly more than that to healthcare, but some don't. And what that means is that for folks who are working for schools and local agencies, sometimes they have most of these costs are fully absorbed, or primarily, I should say, absorbed by the employee. And that's a really important thing to think about, because the relation between premium and costs and premium and the employer's wages is much more direct than it is on the state side. So we buy these days, so this is a 2022 figure, but these days we buy about $11 billion worth of healthcare every year. Why don't we go to the next slide? So this is these are our 4 big strategic goals. I get a nasty text or email if I don't include this slide whenever I talk about CalPERS, but it's actually helpful to focus a little bit on the goal that we're talking about today, which is affordability, because it really is related pretty directly to the other 3 goals. So if you think about the ability of individuals to pay for their health care and how it is different depending on income, you can see the obvious correlation between affordability and equity. Quality, really important considerations there. So there's a lot of, and Dr. Pan made this point, I'll make it again, a strong correlation between cost sharing, for example, and outcomes. So people who are facing high deductible plans and can't afford to make those contributions forego care, and they just have worse outcomes. So they don't get the care they need. What would be a treatable thing becomes a less treatable thing. So you made the point that it's more expensive often. It also just results in poorer health. And then access, obviously, same correlation. So this is where we dive into the data. And this is, so we do something, and we just updated this to capture our data through 2023, but we do something at CalPERS that we refer to as the heat map. We update it periodically to look at prices across California, and it helps really focus us on price variation. And I thought before we get into the overarching slides that we would look at some of the individual conditions because they're so striking. So this is basically not that any delivery is a simple delivery, but this is a delivery without complications. And if you look at the cost, so you see statewide average in there is about $13,500 in Monterey and Yuba County. It costs about twice that much. There is a 2.5-fold difference between the cost of a non-complicated delivery that takes place in San Diego when compared to those counties. So pretty striking. Similar variation when you look at the cost of procedure like an MRI. Again, this is a procedure that does not vary in quality. For all of these, we don't pick up any discernible differences in quality relative to price. Electrocardiograms, again, more than a 2-fold difference. And these are emergency room facility charges, 2.5 or so fold difference as we transition from county to county. So now we're looking at overall costs by county, and what you see here. So this is why we call it the heat map. The darker red counties, and we're gonna look at a table in a second, which is easier to read because this is a little small. But the darker red counties are the most expensive. The darker blue counties are the least expensive. But you see about an 80+% difference in overall cost as you move from one part of California to another. And again, no discernible differences in the quality of the care that's being provided. It is just how much it costs. This is for hospital inpatient services. So we broke this down a couple of different ways. And then when we go to the table, you see Yuba more than 2%, more than 2 times the cost of care for the statewide average. San Diego, Los Angeles, Fresno, Monterey also up there. Monterey is the larger of the ones at the tippy top, obviously. Outpatient services, similar story there. You have Monterey at the very top, 2.5 times difference when compared to Fresno, a little less than double what you pay in Los Angeles. And then this is professional services, where you see differences. So in this instance, you have Monterey County a little bit below the statewide average, and you see different outliers. But you also see a significant spread. So a couple of takeaways. One, that prices vary significantly across counties overall as we move from professional services to inpatient and outpatient services. And I'm going to talk about why that's important in a second. The other is that there's an 82% difference as we go from one part of the state to another part of the state. So tremendous price variation. When I first got to CalPERS, we were doing sort of a comprehensive look at our areas, and I saw this, which was exaggerated at the time, but is more exaggerated now. And I said, "Oh, that's great. So what I have to do is fix that problem, and then I can retire." And it really is when you look at how much of a difference you have in prices from one part of the state to another part of the state, there is an opportunity there. We see an opportunity there because if you take the parts of the state without the functioning markets that you have in the lower cost areas and make them more functioning, there is the possibility of really bending the cost curve across the state. So we spend about $185 more for premium in Southern California, or I should say premiums are higher in Northern California than in Southern California by about $185. In general, these high cost areas that you're seeing in these tables are places where there is less competition. It is an ongoing challenge to keep up with the consolidation, the acquisitions, and the consolidation that you see. So as you hear about this consolidation in markets, what that says is that market's going to get worse. So the fewer providers, the more leverage they have in the market, the harder it is to be successful in negotiations. And as I said, probably too many times already, but I'll say it again, is that these prices are not associated with differences in quality. I want to talk a little bit about what we're trying to do about this, and then I want to talk a little bit more about Monterey. So what are we trying to do about this? What are the potential levers here? So CalPERS is famous for, and this predates me, so I can't take any credit for this whatsoever, but reference pricing of procedures. And what we did now, several years ago now, closing in on a decade, is we looked at areas where you had very high costs in, say, one facility and lower costs in another facility. And then we looked at quality and identified across the state facilities that and now some professional services where there were low cost, high quality places that our members could do. And we have lowered the cost sharing in many instances to zero for those places where you can get less expensive, high quality care to create an incentive for our members to go to those places. Now, that works pretty well when you have areas where there are lots of services. It works less well when there are fewer places to go. So I talked a little bit about the challenge that consolidation creates for prices. Reference pricing just doesn't work nearly as well in those sorts of areas. So in those cases, in those instances, there's a second thing that we've been trying to do, and we've been trying to do this here, in fact, which is to work with our insurance carriers to move our members from high cost places, settings, to lower cost settings. And so if you go back and you think about what I showed you in Monterey, we have very high hospital costs, and we have much more affordable professional settings. So there are a number of things that you can do both in and outside of a hospital setting. So you can do certain types of procedures, hip and knee replacements, MRIs, et cetera, can be done in hospitals, and they can be done out of hospitals. So we are in the process of working with our carriers to try to move as much traffic as possible out of those high cost settings into the lower cost settings. The other thing that we are looking at, and I will credit Chris Whaley, who is going to be presenting in a minute. He's been helping us with this. He started at RAND helping us with this, but we've been looking at how telehealth can make a difference. And I will say that what we've learned so far is that telehealth is a partial solution, but by no means a comprehensive solution. So there are certain things that certain services that work very well through telehealth. Behavioral health services is one of them. There's a lot of evidence that telehealth behavioral services stick as well. Stick is a medical term, as well as in-person does, and our members, frankly, like using it at least as well, and a lot of them like using it better because they don't have to drive. We have huge challenges with access to care in California, particularly in the north, but even in LA and San Diego and Sacramento. And so finding someone can be challenging. In telehealth, you can increase the supply pretty dramatically also and address. But in areas, in high cost areas, we have been excited about the possibility of using telehealth as a way of essentially doing what we're doing with the site of care stuff and finding things that work well for our members that are high quality but lower cost. You can't do surgery via telehealth yet. There you go. Thanks. I looked at you and I figured you're going to say that. And it works better for some modalities than others. I will also say that and this is where Chris comes in, his great work has been helpful. Our members like telehealth if it's structured in certain types of ways, and they really don't like it if it's structured other types of ways, and that's important. And so if you are never going to meet or the person who is providing care for you, there is quite a lot of anxiety about telehealth. If you even have the possibility of a periodic physical examination, people are much more comfortable with telehealth. So telehealth is another one that we've been looking at. So last, Monterey. So I've sort of talked about Monterey as we've moved. I've moved through the data. Monterey is challenging, as Jessica noted. We do not have the many different regions that Cover California does. So our members in Monterey, so our state members, for state employees, we have one region, which is the state of California. So there is no difference between a Blue Shield Trio premium in Los Angeles and a Blue Shield Trio premium in Monterey. It costs us a hell of a lot more in Monterey, but for our members, it is the same. For our members on the local agency side, we have three regions: Northern California, which is broadly construed, Los Angeles, and Southern California except Los Angeles. So those are our three regions. But pretty much everything north of Santa Barbara is Northern California. What high premiums, high costs mean here is that the plans that we work with that are participating here that their premiums statewide or in Northern California go up because they're here. And so Jessica alluded to some of the challenges with Blue Shield. Blue Shield for us just went from having a relatively small footprint in Monterey to having almost twice the footprint in Monterey, and that increased their statewide premiums exponentially. That's a problem both because of the affordability issue, but the other challenge is that the plans that we coax into Monterey get rewarded by being less competitive statewide. So there is a heavy incentive not to come down here, over here. I'm not sure. I'm from Sacramento, so I'll say down here. We typically, the second challenge is that we typically, as we have worked with plans to come here, we need to offset their costs by allowing them entrance into other lower cost markets. That creates secondary challenges that I won't get into, but it increases the number of plans to higher than we would want for maximum competition in some of these larger areas. And then in those areas, the providers get the upper hand in negotiation. So that's a big challenge. We have the same data point to share that Jessica shared, which is that this is a healthier population than average. So even though the costs are really high here, generally, this is a significantly, not generally, is a significantly healthier population than you see statewide. And we see the same thing in our contracts. They are based on, down here, billed charges, which means that if you want to generate more income, you just bill higher amounts. Whereas just about every other place in the state, they are based on negotiated contracted amounts. So it's all of the challenges that they are facing, we are facing. We are desperate to make sure that there are enough plans here to provide low-cost options. We are very excited about, so Kaiser is also entering Monterey. For us, they're mostly tucked up in the northern part of the county, so it is not a county-wide expansion. We're hopeful it will get there, but there's a big challenge there, and that is that there's not been a lot of interest in from the hospitals down here to be working with Kaiser, and Kaiser building a hospital down here would be a whole different kettle of fish that we won't get into, but creates other challenges. So I'll just leave it at that.
Okay, Don, thank you. Tremendous augmentation to what Jessica shared, and really appreciate both of you for your leadership. And I will say, sitting in my seat as HHS Secretary, to see CalPERS in Covered California and DHCS and DMHC and HCI really working together. I mean, this is not Elizabeth calling Don and Jessica for the first time to come present. I mean, they are deep in the work together, kind of trying to move forward for all Californians. And I'm very grateful for that collaborative leadership and true integration. Okay, as promised, I'm going to start with Ian and go around this way. So Richard, you'll be last this time. And because of all of the good enthusiasm, we'll probably have a makeup round at the very end to see if there's any last comments. So Ian, go ahead for Jessica and Don questions.
Yeah, one quick comment on Don, your presentation. I've been struck in many of our meetings. There's an impression out there that large group purchasers are able to bargain good rates because they purchase on behalf of lots of people. And I've never experienced that myself in California, but CalPERS is the mother of all large group purchasers, and to hear that you're experiencing the same as the rest of us is quite something. Jessica, I just wanted one question for you. You said that one of the two region-wide plans that are in Covered California's region in Monterey and San Benito and Santa Cruz is considering leaving. I don't know if the other one has or is, but could you imagine a situation where all the insurers leave a region? That's happening in the property market, where insurers aren't able to get the profits they want because of climate change and so forth. Could that happen here? And if so, what happens then?
It's a really great question. I will just start by saying there is absolutely no way that Covered California would allow a region to go without a health plan option for the residents there. But what it will take to achieve that can become harder and harder and harder. And as Don talked about, there are trade-offs that also have impacts that can carry over to consumers in this region and in other regions when you have to make those trade-offs. So I do think I would just say the plan that has told us they've thought about leaving because of the challenges has a lot more enrollment and a more competitive pricing position than the plan that is statewide and in this region, but has not necessarily said that. What would happen if the first plan left and all of a sudden all of the enrollment carried over to the plan that was remaining? I certainly think that they would have something to say. And so these things do reverberate. And so, luckily we haven't been in a position to say, what are we going to have to do to keep you here? I've unfortunately been in that position in another state in which I was working prior to this role, in Pennsylvania. And the trade-offs again are hard. And in that state, it resulted in far larger premium increases than we've ever seen here in California. And I certainly wouldn't want to see that happen here.
Thank you. Jessica and Dawn, those were fantastic presentations. Jessica, particularly thank you for not only is the data incredibly clear and compelling that these trends are consistent, but also just dispelling the myth that it's a health status issue. It's not a sicker population driving the cost. And I just think that's so important as we seek to understand the real drivers. And then Dawn, your point that Monterey prices are actually driving premium increases for the entire state, I think is really important also to take away. I do have a question though for you, Dawn. When you talked about the strategy of changing site of care, which we actually heard a presentation this year that was actually in some regions, that was a very effective way to reduce total cost. What are you seeing in terms of consolidation? What is the equal and opposite reaction to the attempt at moving procedures maybe out of the hospitals? Are you, as more and more practices or providers get acquired, how feasible does that remain?
Yeah, I mean, obviously, if there's consolidation in the area, I mean, so in some instances you have more competition on the professional services side. In some instances you have decent hospital competition. So moving, it's usually out of hospitals, but works better where you have competition in the place you're moving to. As that erodes, that creates new challenges. We're starting to see, the places where, as I mentioned, initiatives like reference pricing work best in places like Los Angeles, where there's strong competition and lower prices, and there's just more opportunity to find low cost, high quality places to provide services. We're starting to see some of the consolidation that is eaten now Northern California as the fruit is higher on the tree up here. You naturally see the migration to the south where there's more opportunity. So that's always a risk. That's one risk. The other challenge is the complicated relations between hospitals and professional services. And in a lot of instances, the folks who are providing the professional services are medical groups that are affiliated with hospitals, and that's another challenge.
Sandra?
Yeah, so thank you to you both. Jessica, nice to see you. So I sort of had two questions. Covered California has used a set of tools to try to keep rates down for individual market. CalPERS has used different tools. One could imagine what would happen to affordability across the state if we weren't doing any of those mitigations through all of the public purchasers that we have and working with the state. And so I want to just name that. I guess two questions. One is to you, Don, moving care out of hospitals is something that there's a lot of innovation going on in the state and around the country for that matter. And I'm wondering if either of you are looking at what some of those innovations and tools might become in the future as we try to get folks in general out of hospitals, which are expensive everywhere, particularly here, obviously. And so that does seem to be a movement. And I'm wondering, Don, particularly at CalPERS, as you've looked at site of care, whether those innovations have any significant promise for us and for you as we think about, in general, people preferring not to be in hospitals, and hospitals by definition being very cost-intensive structures, again, notable here. Anything on the horizon that might help us deter that?
Do you want us to tackle the first one first? And Jessica, you probably have thoughts about this, but I will, we've had this conversation about the many regions and the few regions, and the reason that we have 3 regions on our local entity side is that our local purchasers are much more price sensitive than the state of California. And we compete for their business. So if we go into Los Angeles and we offer Northern California prices, nobody is going to buy our product. They're going to go find one that is cheaper because it's there. So at the same time, we're, healthcare is healthcare, and the goal here is keeping people healthy and having them live long, healthy lives. And we really at CalPERS are committed to a comprehensive benefit. We don't have any high deductible plans. I don't believe we will ever have one. We'll certainly not have one while I'm there. But everybody, the board is lockstep, the staff is committed to the mission, and so it's we're trying to essentially socialize. I know that's not a popular word, but the costs. So covered because, and you can speak to this better than I can, but folks are much more, because it's coming, the contribution is coming from individuals. The price sensitivity is completely different.
Yeah, I would certainly second. I mean, our market is incredibly price sensitive. How that plays out in practice is quite complicated because it has as much to do with how our premium assistance, financial assistance works and what that delivers to our consumers as it does with other factors. I mean, I would say there's a lot of innovation in the space. There's important federal discussions happening about site neutral payments, for example, that would cause real sort of ripple effects, if you will, into the system that we'll all be tracking and seeing what that may bring and what it would mean for us. I think some of the challenge, and this is true in so many spaces in healthcare, you can name 10 great examples of where it's been successful, but none of it is really scalable because a lot of it is really dependent on the relationships, the providers in a region, the dynamics, right, and what's happened. And so, we have had like telehealth, Don talked a lot about. I mean, COVID had that scale faster than anything has scaled in the history of healthcare because we had no other choice, right? But making sure we're doing that right and using telehealth where it helps and provides more access and provides more choice, and not where it's taking away access and choice, right? So I think how we do this is smart. I think the challenge here is how do we take these strategies that are looking to move people to lower cost locations, but do it in a way that it can be systemic and not one-off to a given region provider relationship exists.
And on the second question on the innovations that allow for the treatment of people outside of hospitals, I don't know that we're doing anything wildly innovative on that front. We're trying to move surgeries that can be done in ambulatory settings into ambulatory settings. We don't ever want to see imaging done in a hospital. We are leaning into the interventions that keep people out of hospitals via readmission. So that is a big focus of ours. On the Medicare side, our plans have taken up with our direction many of the optional services that CMS is now allowing for. So this is rides to preventative care, nutritional meals post-discharge, retrofitting of homes, all of these things that can prevent falls, prevent people from getting readmitted because they're not getting the right food after a discharge or because they miss a preventative visit. On our on the PPO side, we are in 2025 moving to this new construct. I think I've talked a little bit about here before, but it includes a population health management firm called Included Health that is reaching out to our members with complex health conditions and working with them to get the right care at the right time, but also to get all of these secondary services that are sometimes necessary to facilitate that. So we're doing it with our basic PPO population as well. But those are the ones that we're leaning into. If there are other ones that we should be leaning into, I would love to hear more.
If I could just make one final comment. Jessica mentioned billed charge-based contracts. And clearly, there's not a sicker population. The quality of care is not necessarily better here. There's definitely more consolidation here. It seems to me that from a policy point of view, a tool that looks at how we deter billed charge-based contracts ought to be something that we ought to collectively be thinking about. I don't know that's necessarily within our charge, but we have many advocates and policy folks that have helped us with Covered California and CalPERS and OCA. And it does seem like it's very difficult to unconsolidate a market. But looking at other policy tools that get at these kinds of contracts that we heard about this morning, even in the testimony, I think would be high on our agenda.
As we go to Rick, I will just echo that we shared that point of view quietly here. I think that it's an important point to hone in on and see what we broadly, not just this group in our charge, but broader than that, can do. Go for Rick.
Following on Sandra's comments, I mean, we've heard sort of 3/4 of the outrageous statistics that we will hear. And I do look forward to Chris's presentation, but I do look forward even more to our final discussion of what can we do? I mean, the double-digit annual rate of increase in Region 9 that Jessica showed, and thanks both Jessica and Don for really excellent presentations, is outrageous. I mean, over many, many, many years. And, Don showed, you both showed, very high prices in this area. We're going to hear more of this from Chris Whaley in a little bit. And yeah, I look forward to us moving to the discussion of what can we do. The one question or the only other comment is that while that, greater than 10% annual rate of increase in premium in Region 9 that you showed, Jessica, is outrageous, I am also struck by the 7.9% average rate of increase over the period of Covered California. And some of that, I assume, is our hope is that the 2014 premiums that we started out with were really low, and some of it is sort of catching up from that. But even with that, very high rate. And Don, I do wonder whether you have a similar kind of over some longer period of time, what the increases have been averaging in CalPERS.
We have that. I don't have that on the tip of my tongue. I will say that we have since 21 seen, per your earlier comment, significantly higher annual increases. We were in the sort of 4 to 6% range for a number of years up until 2020, or actually into 2020, and have seen closer to or double-digit rate increases over the last few years.
Yeah, and thank you. It's a great question. I want to highlight a few things that have sort of the tale of marketplaces that are unique to Covered California. And one you touched on, which is, we were brand new. I mean, the idea of a marketplace was brand new in 2014, and there were sort of adjustments to be priced correctly that happened across the country. Actually, less so in California. We did a better job than many states in terms of pricing accurately, but there was sort of a realization that we had generally priced for a healthier population than the population that is on the marketplace. The other is that there have been quite a few federal policy decisions, the largest of which was a decision made under the Trump administration to pull federal funding from a program that lowers out-of-pocket costs, and that resulted in the funding for that program being built into premium. So that year saw a really big jump in premiums that had nothing to do with underlying healthcare costs in the state. I can tell you that over the last 5 years, our average is 5% per year. That does include some of the COVID years that had very low, and then we're seeing, as Elizabeth said earlier, some higher increases in sort of the today years, if you will. So even that is a complicated story over a 5-year period. What I will say is even 5% is not 3%.
Just, you know, we are here in Monterey. We're seeing these Monterey numbers. We need to see what, if anything, what we can do to make that better. But the broader story is still there. Monterey is sort of the tip of the iceberg part, but still the rest of it.
One thing I appreciated more in the presentations by both, but particularly you, Don, what happens in Monterey has ripples, right? And so the targeted focus does maybe have something to say about the broader opportunity, if you will, but appreciate, Rick, the point. Don, do I have permission to skip over you and
Please.
go to David?
Yes.
Okay, David.
I want to thank my friends and colleagues for 2 excellent presentations. Thank you very much. I had 2 questions, really, one for Jessica and perhaps Don as well, and another one more for Don. For Jessica, well, first of all, thank you for running Cover California, the best exchange in the country. Thank you very much for what you all do for the state of California, especially people that would not otherwise have access to health insurance. In focusing on the Monterey situation, but also some of the regional variation that you showed, you didn't really specifically say, and I think I know the answer to the question, but what role does variation in utilization play here, especially looking at Monterey? You've said that people are not sicker in Monterey, but we know the prices are higher. Is there a utilization difference in Monterey?
Data that we did not pull, but we certainly can take a look at that and come back. I'll just say in general, I found the most shocking slides of everyone's presentations today, the slides that show California is the lowest on utilization and the highest on prices, right? And we can talk about the RAND study and what it means, right? That if healthcare costs less, people will use more of it, necessary and unnecessary. Well, that tells me there's a lot of necessary utilization that isn't happening in our state, and that's a place we need to focus while we also rein in costs. So I think I would say though, risk score is highly correlated with utilization. These are chronic conditions. These are people who are using a lot of healthcare. So while I don't have a clean data point for you on utilization, I would be surprised if we did that analysis and found that risk score is 15% lower in Monterey, but inpatient utilization is much higher, for example. But we'll take that back and see if we can do a better look. And OCA may have data that touches on that on more the statewide perspective.
Thank you. And my question more for Don. I want to contrast slide 79 here, hospital outpatient cost, and slide 80 and 81 on professional services, and just ask you to elaborate on that. I mean, when you think about outpatient services or and you think about hospital services, if you take those off the table, you're kind of left with everything else, physician charges and things like that. Are physicians and others on the outpatient sector really not driving up cost in Monterey relative to, say, hospital outpatient services?
That's what our data says. And I think I've seen it in the data. I mean, we see it also in the data that Vishal presented. It's not that they're wildly inexpensive, they're normal. So it's normal and outlier, not, yeah. But yeah, that's what we see.
Okay, thank you very much. Great presentations.
Thank you, David. Okay, Richard.
Thank you so very much. And again, really appreciate the presentations from both you, Ms. Altman and Don as well. I guess one of the questions I had, so for example, actually, I guess it's Region 1, right? Fairly rural as well. And as you're looking at Northern California, and you showed, Don, you showed us sort of price for different particular services. Now, I think, certainly consolidation seems to be a high correlation between consolidation and prices. But of course, I guess in less densely populated areas, right? The population is not able to support a whole lot of providers, right? Just the amount of work and so forth. Telehealth may help mitigate some of that because it basically allows a particular provider to actually hopefully get a large area if you're particularly, let's say, you're a physician or other health professional. I'm not sure how much it does for a hospital as well. So for example, let's even take deliveries. I would say that there's a certain level, or emergency room, there's a certain level of fixed cost to just having one, right? You can't say, well, I'm a hospital, I have a delivery service, but we decide to close every time at 8 p.m. and reopen, at midnight and reopen at 8, right? You have to, so if you can have a volume that fills it up and and even beyond that, and you can hire a few more people, et cetera. But you could also have a situation, I think we're struggling with this actually in a lot of areas in the state where, frankly, you know what, they may have on average, let's say 3 or 4 deliveries, but they're the only one in 150 miles. So you said, well, we should keep them open. But the price to maintain, because you're going to still have to have a nurse, delivery nurses, you're still going to, so aside from professional fees, you just need to, and the infrastructure that's available 24/7. And of course, and of course, the average is always the average, right? You can end up with 5 deliveries 1 month, well, you can none the next week, but you still have to keep all those people around, right? And same with an emergency room. To what degree? So there's the price part where it's like, okay, you know what, the hospital's going to, or whatever's paying, jacking up the price as much as possible, but I guess what I call the fixed cost of maintaining a facility and staffing it for certain types of services. The MRI is a little trickier in the sense that it's a capital cost, and you can run it all the time, or you maybe doesn't. We tried certificate of needs that never turned out to be very effective in lowering costs, things like that. But especially when it comes to basically these less densely populated areas, and let's say like Region 1 or those areas, and even in parts of, if you look at, I see which slide was it, there's part of Monterey area where it's highly it looks like densely, but there's parts that's very lowly densely populated. And then people only were willing to go let's put it this way, I should say only willing, but would prefer not to go certain distance, right? I mean, and it's not unreasonable to say, if the closest place you can go, I'm going to offer you is 2 or 3 hours away. No, try to get me something closer. So how do we deal with that, right? And how do we incorporate that into the calculation of, okay, well, someone's going to charge me this much because they're maintaining a certain level of infrastructure. Now, you can argue that, well, maybe it's profit, other types of things, but I mean, especially when you're talking about places with lower density population, and maybe that also touches a little bit about when you mentioned, Kaiser. Well, Kaiser is a single system. They don't, well, I guess some places they may contract with their hospital, but essentially they would prefer to have their own hospital and own doctors, right? All within the system. So if they're really moving to Monterey, if they're going to do it seriously, they got to build their own hospital eventually. So if their model is going to work, otherwise they're just being another typical health plan in the area. So, but maybe that's sort of a comment you can touch on. But I guess that central question for both of you as purchasers, because you're not the one who's actually going to build the hospitals and stuff like that. But I mean, someone who's operating, who you're negotiating with, who's operating at the other end, has to struggle with this issue, right? Like, do I keep delivery services or not? And if I shut down and I'm the only one in 100 miles, well, people scream and shout, and then they're going to come to you or to me formerly or whatever and say, do something about it.
So I'll start. I'm sure Don has great to add, and maybe I'll start by saying I delivered a baby this year, and telemedicine is not the solution.
Right.
Okay. Very happy to have done it in a hospital.
As a pediatrician who has to resuscitate the newborns, I think I have to actually be there.
Yeah. You know, I'm going to say something that might be a little bit controversial, which is I think when you're in these really rural areas, one thing that may not be the answer that we always think is the answer is competition. And the reason that I say that is in my presentation at the beginning, I said, we standardize a lot of things. What you are competing on as a health plan,
Right.
and I mean health plan competition when I say that, right? Is what network can you bring? How can you use your enrollment and your market power to get better rates? Well, guess what? If there's only one hospital in town and we're not even sure there's enough population to fill that one hospital in town,
Right.
there's no network that you can't have two different networks. It's just the same because those are the doctors that are there, right? And so I think they're in those rural hospital situations in these truly rural communities. There needs to be a different discussion about what does it really take to keep a hospital open here? What are the services that are really necessary here? When we have referral models, how do we get people where they need to go in a way that's timely and supportive, right? And how do we do that in a way that keeps the hospital in a community that desperately needs it, but doesn't rein costs up higher than they need to go? So you can think about whether that's unique payment models or other ways of looking at hospital financing at a different level. That's what's going to address a rural community. It's not going to be, oh, we need 2 more health plans up there. It's not going to change anything.
I'll just agree with what you said. We don't lose. So one, it's not, some of these aren't choices because they're DMHC time and distance standards and we just have to, and it's the right thing to do, right? You need the services within a reasonable proximity to get the outcomes that we want to see. We don't lose a lot of sleep over MODOC in Alpine County. For many of the reasons that Jessica alluded to, we're not going to bring another health plan in or a second hospital and do anything good. We have tried to make HMOs available in every county in California so that people have that choice, because one of the things that we believe in is integrated care, and we think that HMOs do a better job of delivering integrated care. They're also lower out-of-pocket costs, and so the concerns about the relation between affordability, out-of-pocket costs, and quality are there. But the other thing is that they're just, because there are so few people, and particularly for us, we have hundreds of thousands of people in Sacramento County, hundreds of thousands of people in San Diego and Los Angeles. We have a handful in MODOC and Alpine. So, it's just going to be more costly to deliver care there. And it doesn't make a proportional difference to our overall costs.
So just to follow up on that, so appreciate your answers. Sort of going back to the what do we do about this, right? I think, and I appreciate your comment about the numbers, right? I mean, I think it's good to know to what degree, as we're hearing and we look at these numbers, and again, this is about the nuance part. There's obviously things to do. I'm not saying that there isn't a problem, but I think it's good to be sure we capture how much of this is, stuff because you're in a situation where basically, look, this is what we got to pay to maintain a hospital, et cetera. And we're not going to cut that unless we're planning to close the hospital, right? And so that's off the table. And then this is how much more we're working on to solve the problem we're trying to address, right? So I appreciate in the presentation, you sort of have to present these broader numbers, but there's also the piece of like what part of that slice in some particular areas, and that this is the situation, and you know what? And actually, it may be more expensive than the average because to maintain certain, but that is the right thing to do. And when we talk about small area variations and stuff, there are Dartmouth, Atlas, all this other stuff. I mean, just keeping in mind that there are places, yes, where people are just driving up costs, unnecessary care, et cetera. And then there are situations where, yes, it's above average because it needs to be, because that's what it takes to provide the service, right? And so figuring out how to parse that out, I think, is important, because that way we don't spend our effort and outrage on, oh my God, look at this. But actually in this area, that's not the problem, right? This area there is. So I just I appreciate the presentation on that. Yeah.
Since you asked no questions, Don, I'll let you make the final comment before I
Yes.
interject.
Yeah, I would just wanted to make one important clarification, which is I'm looking at this from the CalPERS perspective, where we're offering a similarly priced product in that area. If you're, I would be careful about extrapolating from what I said and what Jessica said to more broadly for OCA, because there's still the same affordability challenges and more acute affordability challenges in these areas. And for folks who are buying coverage off of the exchange and outside of CalPERS through employers and so forth, there are profound challenges in these areas. So I agree it's a harder nut to crack, but I also think it's important that we think about how to deal with it innovatively to keep those costs more comparable to what you see in the rest of the state.
And sorry,
Go ahead.
and I fully agree with you, Don. And that's what, but the policy solutions are different because the policy solution there is not on that end. It's going to be on how do we help the consumer, which is why I'm proud to have authored legislation to actually increase subsidies for covered California and other types of things, because yes, we need to address the affordability question. So the question is, in certain areas, the target's going to be more like how we help, and people say, hey, maybe that's a subsidy for the provider, but you know what, that's in order to keep access. And other places like, no, we're going to be trying to put pressure on the provider, like, hey, you're charging too much, and back to the prices and and we need to get that more in line.
Yeah. Okay. All right. Others are itching to jump in. I have one question, but I'll let you all go briefly first. Go ahead, Elizabeth.
Promise this is very brief. For future, talking about the consolidation issue, I think it would be worth looking at the injunctive relief provisions from the Sutter case on anti-competitive practices. I think it could be informative for going forward.
You looked like you wanted to jump in.
Just
Rick, please.
really quickly, I think Dr. Pan's comments highlight the importance of being sensitive to local conditions and to be clear. The conversation between Richard and Don was about kind of sparse rural areas and not about areas like Monterey that are not sparse or rural. Right? Yeah.
Yeah, I was going to just add before my question that I believe the population of the county we're in is 430,000, maybe a little bit more, which is, if you were a state on your own, you would be running for one of the smallest, but you would be right in there, right? So there's some states that are almost as small as this county from a population perspective, and certainly much more spread out than you are here. My question sort of blends a little bit about Richard's comments and the network adequacy provisions. I have the privilege of thinking about a lot across a lot of different departments. And it is striking that the northern part of the county seems to have more opportunity. And I wonder if that is, and I'm going to answer the question and see if it's right, and if it's wrong, correct me. But my sense is it's because you can build an adequate network with providers outside of the borders of the county more effectively in the northern part of this county than if you're in the middle and the south. And that just sort of highlights how the impact, if that's the case, then it does highlight the impact of, yeah, we draw lines around land masses to design counties, but it's really sort of the market dynamics around the places where people live. And obviously, there's a lot of world-class, wonderful institutions in the counties just north of here that it sound like help build those adequate networks.
Yes, and I'll just use Kaiser and their expansion as an example. They're anchored through hospitals out of Santa Cruz, able through network adequacy to then come into the northern part of Monterey. But without the Monterey hospitals, can't provide an adequate network in the southern part of the region.
Yeah, and Don just nodding. So I mean, underscores again that I'm glad we have network adequacy provisions across all of our sort of respective, those who oversee purchasers and those who are direct purchasers, that we have a chance to touch base with. But I do think this is a unique place, and it struck me as we looked at where people are struggling, the plans struggling to create competition or competitive pricing and premiums. There's opportunity in the north, and it feels like the southern part of the county is a very different story.
I'll just
Okay.
give brief credit to our partner, our regulator at the Department of Managed Healthcare, who oversees network adequacy, and they do approve exceptions to recognize some of the unique dynamics. But there are also times when if you need an ER, you need an ER in your community, right? And so I think there are also times where that can only go so far.
Exactly. So, okay. Terrific discussion here. I want to, on behalf of the board, thank Jessica and Don for great presentations. The board may on occasion want to fire me as chair. You may this time because our sort of internal budgeting of time, I'm terrible today. We're a bit behind, but we are going to have the main event, why we came down, have this conversation, share some data, share some remarks, but really listen to the public now. And Karen, I think you're going to keep us mostly get us a little bit back on track. So let's go juggle the room and no, the team's saying, no, we're not going to get you back on track. But this is why we're here. So please, we're looking forward to hearing the comments.
Thank you. We'll now take public comment, both from individuals in the room and those online using the raised hand feature, and we'll move back and forth between public comment here and online. Again, if you could keep your comments to 3 minutes or less, that will allow more individuals to speak during public comment, and we'd appreciate it. I'll make a gentle reminder once you hit that 3-minute mark. And with that, we'll turn to the individual at the podium. Please go ahead.
Thank you very much. I'm former State Senator Bill Monning. I represented Monterey County for 12 years and the broader region, including San Luis Obispo, Santa Cruz counties. I want to thank Secretary Galley and all of you for coming to Monterey today. It's a significant show of recognition of the work that workers in this area have been doing to bring attention to these cost differentials where Monterey unfortunately leads the state as the #1 outlier. I also want to acknowledge former colleague Dr. Pan. We worked together in the Assembly and the Senate. Also, when Dr. Carlisle worked in Sacramento, we had the opportunity to work together. And also Ms. Landsberg and all of you, we thank you for coming to Monterey County. Y quisiera decir gracias a todos por su presencia aquí este día. Y gracias por su trabajo cada día en apoyo de todos los residentes del condado de Monterey. Gracias. I also want to acknowledge the healthcare workers at Chomp, at Salinas Valley, at Natividad, and at the other hospitals in the region, the frontline healthcare workers who stepped up at great risk to themselves during the COVID crisis. We acknowledge their work and their ongoing day-to-day work of putting the health of people in Monterey County ahead of their own health and safety at times. I also want to acknowledge when Secretary Galley led the state at the time of the COVID crisis, we were able to get Asilomar as the first refuge center for COVID positive patients coming off cruise ships in San Francisco. And that was with the work and the support of the hospitality workers represented by Unite HERE, who at risk again to themselves accepted COVID positive patients when very little was known about the contagious nature of that disease. So once again, Monterey County, not only does it lead in these exorbitant costs, it also leads the state in the commitment of our healthcare workforce and our organized workers. So Monterey County is a unique county. It's interesting that the slides show lower risk in terms of need for utilization, but we're a county that's very divided. We have one of the older populations on the peninsula who use higher than normal healthcare needs at the end of life. And then we have a younger population many of them immigrant workers who are healthier and require less emergency or long-term hospital care. Our three biggest employers in Monterey County are agriculture, hospitality, which is restaurant, hotel workers, and education, our teachers at all levels of education. 30% of the children who live in this county live in poverty. I see my time is up. I'm just going to cut to the end right here. I appreciate the opportunity to just conclude. You have the power and the authority, you show it by your presence here today, to cap increase in healthcare costs throughout the state and in this county of Monterey. I understand from my research, the data that everyone is sharing, there's no doubt about us being an outlier. That's proven. The question is, what can you and what can the state of California do to cap the rate increases and to protect workers who are deciding between a wage increase to pay their rent and feed their families and their contract negotiations being derailed by all the increase in compensation from an employer going to increased healthcare costs. We need to bring it down. I read that you have until 2028. I urge you to accelerate your authority to reduce increase in rates in Monterey County. Thank you very much.
Thank you. Thank you. Now turning to a member of the public online, Caesar Lara. We're unmuting you on our end. Please unmute and go ahead. Caesar Lara online, we've unmuted you. Please go ahead and unmute on your end and go ahead. Okay, Mr. Lara, we're not hearing you unmute on your end, so we're going to move on for now to the next individual online, Marielle Reataza. We've unmuted you. Please unmute and go ahead. Marielle, can you unmute on your end, please, and go ahead. Okay. Let's come back to the individuals in the room while we look into why that has happened. Individual at the podium, please go ahead.
Members of the board, what was this? Check, check. Members of the board, thank you for coming to Monterey County. Much appreciated and duly noted. Staff as well. I'm still Steve McDougall. I'm still president of CFT's Division Council of Early Childhood through 12th Grade Locals. I've been a longtime leader, a union leader and activist throughout Monterey County. And I'm still president of MCSIG, the JPA that provides healthcare benefits to mostly education employees and other public sectors folks as well. Looking at the presentation earlier, and I saw the slide about the Bakersfield situation being so much cheaper than here, I was worried that my members would take off for Bakersfield and resign their positions. But then I remembered it's Bakersfield. If the Kern County Chamber of Commerce is listening, it's 2 L's in McDougall, McDougal. And I've often joked, but also somewhat serious, that if MCSIG had purchased a charter jet service out of Salinas Municipal Airport and we just take our folks to Omaha, Nebraska or somewhere, we could afford and still maybe come out ahead with what we're paying. And CalPERS in 2016, we called them when we were shutting down our trust. They must have not thought we were in Bakersfield because they never called us back. But we ended up going to MCSIG. MCSIG for 2025. I know I told you earlier this year that we're looking at a 17% rate increase for next year. Well, we put a subcommittee together of our leadership team comprised of management and labor, and they were able to get it down to 12.46% for 2025 across our plans. But you know what we had to do it, don't you? We had to find that bubble and push it in somewhere else. So don't play in traffic, don't get sick, don't get cancer, and don't have a baby, because you're going to pay more when you go to get your service, period. That's what we had to do to get it from 17 to 12.456. Cover California, it's always been a struggle since the beginning. We have vanilla and chocolate now, and we're going down to vanilla. That's got to be an indicator of something. And Monterey County is not in the middle of nowhere. Was that a double negative? I'm a teacher, for crying out loud. All right. We have 4 hospitals inside this county. San Jose is an hour away. It's SJC to my front door is 1 hour without traffic. Palo Alto, Stanford, although not in the network with my carrier right now, don't get me started on that.
That's 3 minutes.
Yep. Is just a little bit farther than that. And I got to tell you, we're not so isolated that CHOMP is able to funnel people, public employees from Alaska, to come to CHOMP to do their surgeries, bypassing SeaTac, bypassing the Bay Area. That's got to tell you something too. Why are they coming here? Why is there a deal with Alaska employees? And I got to tell you, the impact of Monterey County, if I was a member of the Hospitals Association outside of this county, I'd be looking at the hospitals in this county and saying, knock it off. Get over it already. Let's figure something out. Thank you.
Thank you. Next, we'll turn to members of the public online. We've unmuted SB. Oh, sorry, they've just dropped. We're going to move to Nathan Kaufman. We're unmuting you. Please go ahead and unmute on your end and go ahead.
Yes, thank you. I noticed in the first presentation, they talked about Porterville as having some of the lowest rate increases. The hospital in Porterville is actually has a negative 12% operating margin. And one of the reasons for that is their extremely high percentage of Medicare, Medicaid, or I'm sorry, Medi-Cal, which actually hasn't really had a material increase in the state in about 10 years. So I would disagree with the next presentation that says there's no cost shifting. If you reduce rates in some of the high Medi-Cal hospitals by 5 or 10%, these hospitals will have massive deficits, and already 50% of our hospitals are losing money in our state. Another economist, Tom Sowell, said there are no solutions, they're just trade-offs. And while I agree as a 70-year-old patient and healthcare expert that our healthcare system is a mess, I'm curious of what the panels think will happen when you try to cap rate increases when nursing salaries and supplies are increasing at astronomical rates. What will be the trade-offs? 60% of the cost of a hospital happens to be personnel. So I would assume if it's like any other place, they will start reducing services, eliminating services, small hospitals will close, and there'll be massive layoffs. That's not to say that we don't have abuses in terms of pricing. We just haven't talked at all today about the trade-offs associated with payment caps or reducing prices at hospitals. So I just would appreciate knowing what the panel thinks about that. Thank you.
Thank you. We'll now turn to the individual at the podium. Please go ahead.
Good morning, OCA board. Don, Jessica, thank you so much for your presentations. Pictures are worth 1,000 words. And my name is Doug Cheshire. I'm a field representative for the NorCal Carpenters Union, where I represent over 37,000 members here in Northern California, many of which would live here in Monterey County. I myself am a lifetime resident of Monterey County, born at CHOMP myself. Today, I want to highlight a pressing issue that affects members I represent and all of us here in Monterey County: the need for increased competition in our healthcare industry. Currently, our healthcare market is dominated by few major providers, resulting in limited choices for patients and higher costs for services. This lack of competition reduces the quality of care and places a significant financial burden on families and individuals. To help address this, I ask that the OCA board Commission a comprehensive cost and market impact review of our local healthcare market. This review will likely reveal just how uncompetitive the market is, pinpointing areas where new providers can enter and thrive. By identifying these gaps, we can encourage new healthcare providers to establish themselves in our community, fostering a more competitive environment. Increased competition will lead to several benefits: lower healthcare costs, improved quality of care, and greater access to a variety of medical services. Patients will have the freedom to choose providers that best meet their needs, driving existing providers to enhance their services and prices to remain competitive. In conclusion, a thorough review by the OCA board is essential to uncover a true state of our healthcare market and pave the way for new providers. By doing so, we can ensure that the residents of Monterey County receive the high quality, affordable healthcare they deserve. Thank you.
Thank you. We'll now turn to the member of the public online, Steve Shortell. We've unmuted you on our end. Please go ahead and unmute and begin. Steve Shortell, you're unmuted on our end. Please go ahead. Okay, we'll move on to Dee Dahlman. Dee Dahlman, we're unmuting you. Please unmute on your end and go ahead. Dee Dahlman, please unmute on your end. Okay, moving to next online, Anonymous. We've unmuted you on our end. Please go ahead and unmute. All right, we're going to turn back to members of the public here in the room. The individual at the podium, please go ahead.
Thank you, OCA board, all my brothers and sisters who are in the room. My name is Alicia Metters. I am a lifelong resident of Monterey County. I was born in San Francisco and raised right here on the Monterey Peninsula. And I am proud to be from Monterey County, or to live in Monterey County. However, I know that to live in Monterey County, sometimes, again, as I think I heard the statement already, there's a great divide. There's the haves, the have-nots, the workers who are struggling to make ends meet in this economy, those who should not have to choose between whether or not they're going to get appropriate health care or whether or not they're going to be able to pay rent. I go back to my mother. I am the daughter of Alice Metters. She was a healthcare worker. She was a certified nurse's assistant. She was a home health aide who worked at Canterbury Woods in Pacific Grove for 33 years. She retired because she was diagnosed with multiple myeloma cancer. At that time, we know home health aides, certified nurses were not making a lot of money because most of them took on private duty patients in order to make ends meet. But Mom, she said, I'm gonna stay with Canterbury Woods, even though she wasn't making, I don't even know how much, but I know she wasn't rich in money, but she was rich. Because she worked at Canterbury Woods, she was able to have health care that covered her. So even though she was not rich in money, she had the trade-off of health care. What I'm saying to you is that we should not have to choose between health care and being able to survive in this economy. We should not have to choose. It is every person's right in this country, in this world, to be able to receive dignity, respect, and health care, no matter what their economic status is. Working for Monterey County for 27 years, I always say I started when I was 5. We know that at this particular time, SEIU, who I am proud to serve, we are at the table because we are, again, bargaining over wages, health care, all of those things. And most often, we will settle for being able to cover our health care costs. And again, I've heard numbers, I've heard all of the theories, the statistics, but it's time to do something. And we have to do something for the working people of this county to be able to live here comfortably, to be able
3
to go
minutes.
to the doctor, and just to be able to thrive in Monterey County. Thank you.
We'll now turn to a member of the public who's online, Dr. Anna Malinow. We're unmuting you on our end. Please unmute and go ahead. Dr. Anna Malinow. Please unmute and go ahead. Go ahead and speak, please. We see that you're unmuted. Oop, you just muted again.
Okay, can you hear me now? Sorry.
Yes, we can. Thank you.
Okay, perfect. Thank you and good morning. My name is Dr. Anna Malinow, retired pediatrician in San Francisco and lead organizer of the movement to end privatization of Medicare. We're an organization with a mission to protect Medicare as a public good, which must not be surrendered to value-based payment schemes that incentivize providers to withhold medical care in pursuit of profit. We are concerned about OCA's effort to control healthcare spending in California by imposing a cap on per capita healthcare spending using risk adjustment that, even if good, and this is a big if, still incentivizes gaming the system. Because OCA has no method of accurately adjusting entity expenditures to reflect the health of the entity's enrollees or assignees, OCA will not be able to determine whether an entity exceeded its cap because of factors within or outside the entity's control. To test our hypothesis, we propose that OCA first run a pilot test utilizing expenditure data in California's all-payer claims database on half dozen healthcare entities over the course of 2 years, a base year and a performance year, before rolling out the cap on over 700 healthcare entities in California. And using this past expenditure data, the pilot test could test 2 scenarios, one using only age and sex and another adding diagnoses. And we are confident this pilot test will reveal how difficult it will be to set caps at levels that accurately reflect factors outside entity control, and the high probability that inaccurately risk-adjusted caps will punish entities that insure or treat a disproportionate share of the sick and the poor, and reward entities that game the system by insuring or treating a disproportionate share of healthy and the well-off. And even if a risk adjuster with diagnosis will be unacceptably crude and result in a worsening of disparities. In summary, the movement to end privatization of Medicare urges you to conduct a pilot test using past expenditures. Results will shed light on whether OCA's proposal is feasible without forcing hundreds of entities to waste time and resources that at best might achieve spending targets and at the expense of the poor and the sick. Thank you.
Thank you. We'll now turn to the individual at the front of the line in the room. Please step to the podium and go ahead.
Bueno, yo soy Ramón Maldonado, trabajo para el Highlands Inn por 27 años.
My name is Ramon Maldonado, and I work at the Highlands Inn for 27 years.
Okay. Una vez fui al hospital Salinas por 2 horas, me cobraron $9,000. No me dieron más que una botella de suero.
So I went to the hospital in Salinas for 2 hours, and they charged me $9,000, and I just went home with a bottle of Pedialyte suero. Yeah.
Después fui a una cirugía a San José de mis ojos y nada más pagué $700.
When I went to a surgery in San Jose for my eyes, I only ended up paying $700.
El año pasado fui a hacerme un chequeo a Salinas del Corazón. Por eso cobraron $44,000.
So last year in Salinas, I just went to a checkup for my heart, and I was charged $40,004.
Esto. Gracias.
Thank you.
Thank you. We'll We'll now turn to a member of the public who is online, SB. SB, we've unmuted you. Please unmute on your end to begin speaking.
Thank you. I'm a local physician. I'm very proud to serve our community, but it's obviously incredibly frustrating and angry when you see the cost of care. There's no costs that our care are very high. Trust me, as somebody who has a family with kids, every month I pay my health insurance costs. It makes me angry. And a big part of that, and really the number one reason that I haven't heard addressed, is the payer mix, combined with the very high cost of living locally. We have billionaires who live in Pebble Beach, who have more money than all of us put together, but they walk into the hospital holding their Medicare card high. And at the same time, we have our poor farm workers who come in with Medi-Cal, and we are happy and very proud to care for all of those people equally. We work as part of the community and we want to care for everybody. But the problem is both of those folks, neither of them and neither of their insurers are paying the full cost of care. The folks on Medicare or Medi-Cal with their health statistics don't show up in the health statistics that were listed previously from Covered California or CalPERS, but their expensive care lands all on all of our shoulders. When 75% of our patients are paying with government insurance, we have no ability to negotiate and we have no ability to pay for the full cost of care. Good care, whether at CHOMP or Salinas Valley or anywhere else, costs a lot of money. And the problem is that cost shift falls on our commercially insured payers. Every year, Medicare keeps cutting physician rates, and so the only way anyone can keep doors open is to shift the costs. But it's not fair that all of us with commercial insurance have to pay for those insured by the government. A speaker earlier talked about pushing on the bubble, where you push on one side, it comes out the other. The problem is the more that bubble's getting pushed on one side, it's going to pop. And until we're able to get adequately reimbursed from the government payers, the cost of commercial insurance is going to keep going up because there's no way to keep the doors open any other way. Thanks. I appreciate the opportunity to speak.
Thank you. All right, we'll turn to the individual at the podium. Please go ahead.
Hello. First, I want to say thank you for this opportunity to have the forum to speak. I'm going to just share a little bit of my medical background and my journey. I am starting my 14th year as an administrator here in work for Monterey Peninsula Unified School District. And probably my greatest accomplishment is being a mother. And I have wonderful children. My son Tyler, who is 16 years old at 4 months, caught strep pneumococcal meningitis, which is covered now. At that time, it had an 85% mortality rate. So as a first-time mother, not knowing if my kid's going to make it through the night is very difficult. He had to be emergency transported to Lucille Packard. He was put in a medical coma. He ended up with third nerve palsy. The type of meningitis he has calcifies the cochlea for strep pneumococcal. Unfortunately, I'm kind of a medical expert as well. So we opted to do bilateral cochlear implants. He was 7 months old. At the time, medical, it was not approved for under 1 year of age. So Stanford had to fight that. At that time, there was a $1 million maximum lifetime for insurance. So I had to apply for CCHS. I had to apply for the financial, although I made too much money. We had to apply for disability. They offered me $1.25 a month based on my income. I'm now currently, he is a junior. He's learned, we do sign language at home. He's in an independent living. His primary disability is intellectually delayed with a secondary of DHH and OHI. He had epilepsy for many years, which we had to work with Stanford. No one in Monterey County will work with my son. They don't know enough about his condition. Stanford is no longer in our covered network. So my next task is finding doctors who will help my son. I also have a daughter that needed an emergency C-section. I also had a son that I lost at 8 months. And turns out I had IC, and had an emergency cerclage with my last and was on bed rest for 6 months with her. She now has autism. No one will see her. Due to all of this, I now have 9 payments left of medical bankruptcy. I do not own a home. I can't get things that my family needs to survive. And I'm one of the working poor. But right now, my situation is getting through what I can. As we're ending our medical bankruptcy, we already are in collections for everything else because of the medical costs that we have. So anything you can do to help our county and help our children and the people that need it most, I would just be forever grateful. Thank you for this time.
Thank you. We're going to turn to our online members of the public. Steve Shortell. We've unmuted you on, just checking that we're unmuting you. Yes. And now, Steve, if you could unmute on your end to begin speaking. Steve Shortell, if you can unmute on your end to begin speaking. Okay, let's move down to Bruce Hector, MD. Bruce Hector, we've unmuted you on our end. Please unmute on your end to begin speaking. Bruce Hector, please unmute. Okay, we will turn back to individuals in the room, and the individual at the podium, please begin.
Good afternoon. My name is Nikki Long. I'm the president of the Monterey Bay Teachers Association, representing around 600 certificated staff here in MPUSD. I'm not from this county originally. I'm from a country with, I think, a much more civilized healthcare situation, but we're just going to leave that aside for now. I'm very excited today to get to share with you a story from a dear friend of mine who's teaching today and one of our members. Hello, my name is Rosalind Book. I've been an educator for 22 years and truly love what I do. Coming from teaching in Fremont to Seaside was quite an adjustment. I took a $20,000 pay cut, but still believed it was worth it for the beautiful weather, incredible schools, and wonderful students in Monterey Unified. However, I never imagined how much more I would have to sacrifice by moving here. My husband lost his job during COVID. Up until the year he lost his job, we'd been okay having 2 incomes, and with myself being on his insurance plan. At first, I wasn't too worried. 22 years of teaching, I thought I should be able to manage our bills with being frugal enough for us to be able to survive. But boy, was I wrong. After cutting down on our expenses, I was hit with one very unexpected problem, our healthcare. I could only take the lowest healthcare, and even doing so meant that adding my husband would withdraw another $740 from my paycheck, more than the cost of all of our monthly bills combined. To top it off, we soon learned that getting sick was not an option, even with our plan. We could not use any nearby hospital, and getting appointments for even the most mundane checkups was so difficult it was easier just to suffer and see if things would improve on their own. But it really struck home one night last year. One night I woke up to my husband yelling my name, like screaming my name. I didn't know what had happened, but I was on our bedroom floor, face down in a pool of my own blood. My husband was scared to touch me and just kept yelling that we needed to go to the hospital. It took me a while to realize that I had been unconscious and that there was a huge gash under my chin, possibly from hitting the hardwood floor, possibly from the glass table next to me. It took me a minute with my husband screaming that we needed to go to a hospital for me to come to my senses. And that's when I told him we could not. We absolutely could not go to the hospital. We could not go to the ER. Call Teladoc, I told him. Look up the hours for urgent care. Nope, too late. All were closed. Get my purse so I can look up the number. Find my insurance card. These are the things I said. These are the things I said while I was bleeding out. All I kept muttering was, I can't go to the hospital. It's not going to be covered. We can't go. We can't afford it. I felt lightheaded. It hurt, but I still had to continue convincing him. If we go to the hospital, it's not going to be covered. In the end, with me bleeding out and him frantic, we went. I was still reeling, and he was in too much of a panic to find Teladoc and do the things I wasn't even sure would help. 3 hours and 10 stitches later, we went home. I felt more ill from the thought of a hospital bill than anything else. The next month, the bill I worried about came, $15,000+. One bad night where I was lightheaded. I can't even imagine if I actually get sick. As a side note, I wondered if a hospital with such stunning modern buildings that continue to be built was really putting its money in the right place. When I received a check from them for $1,000 earlier this year, I wondered how out of touch they might actually be. Last year, I spent a majority of the year considering my options, and that's where I am now, 1 foot in, 1 foot out. Thank you very much.
Thank you. In a moment, we're going to turn to the Steve Shortell that's at the bottom of the list, number 5, and unmute you on our end, Steve, and ask you to unmute. But we do want to note, if you've been able to unmute as an online member of the public trying to speak, please leave the meeting and rejoin it. If that does not work, you can join via phone using the information provided in the agenda. We also accept written public comment sent to oka@hchi.ca.gov as it is shown in the slide above. Okay, Steve Shortell, we're going to unmute you and ask you to unmute on your end. And if this doesn't work, please leave the meeting and rejoin. Steve Shortell, if you can unmute on your end. Okay, that does not appear to be the case.
Can you hear me now?
Yes, we can. Please go ahead.
Okay, I apologize. I had problems getting in today as well. Just a couple brief comments. First of all, thanks to everyone and all the great data that's been pulled together. This may have already been covered, but there's slides that show the trend data, prices, spending, et cetera, compared to the nation and so on. It would be interesting to also just look at it compared to the other states that have had spending caps over the last number of years, Massachusetts and others. So that's easily done and might be instructive. The other thing that would be interesting is we know that California has among the lowest utilization. Spending, of course, is prices times utilization. A lot of talk about prices and legitimately so. But it'd be interesting to see the utilization data broken out by inpatient, outpatient, professional, et cetera, post-hospital care. And then overlaid on that, statewide and within the regions, the supply data on hospital beds per capita, clinicians per capita, primary care, specialists, nurse practitioners, physician assistants, post-acute beds per capita. I think Mark or Dr. Galley hinted at this a little bit in looking at the Monterey County situation in terms of looking at the provider networks and so forth, but overlaying some of that on the utilization data in addition to the price data, which might provide some insights for positive interventions. Thank you. I apologize for the problem getting in.
Thank you. All right, to the individual at the podium, please go ahead.
Thank you for taking the time to hear from real people today with real stories. And I wanted to thank you, sir, when you said my jaw dropped. I was waiting for more gasps and, oh my goodness, when those 162% of whatever all those slides were. Thank you for just acknowledging, oh my goodness. But my name is Greta Wong. I'm a proud kindergarten teacher within Monterey Peninsula Unified School District. This is my 19th year teaching. I'm a single mom to one son, Luke. He's 8 years old. Time and time again, I've delayed and deferred care because I can't always afford it. As a kindergarten teacher, my job is to be surrounded by 23 of my closest 5-year-old friends. And I don't know how many 5-year-old friends you have, but you can imagine how many germs. I just got a text message from my sub. Someone was sick. Who was it? No, she was already sick last week. It can't be her, but she wants to go home. Last year, my son and I got the La Mesa cough. They kept us coughing for a couple months. I delayed going to the doctor because I didn't want to pay the copay of $45 just to have them tell me it will go away. So all that to say, it's important they have access to affordable health care, as I need to be healthy and successful for my students who one day may be doctors, maybe my doctor, and to provide for my family. Living on a teacher salary within a single income household has helped me master the skill of budgeting. I did the math, and 13.9% of my paycheck every month goes only paying monthly healthcare insurance, just the monthly fee before doctors and any medicine, fees, labs. It would cost $1,300. It would cost a lot more for my son and myself to be on mixed sig. And so my son is on Covered California, and I paid $369 a month for him. I got a $1 discount, which doesn't really do much of anything. My employer also pays an additional $8,372 per year per employee. Wow, that amounts to over $12,000 a year just to pay insurance costs for one person before any doctor fees, any labs, any prescriptions. I would much rather have the $8,372 go to my pocket. In 2022, I was diagnosed with Barrett's esophagus and a paralyzed stomach. And after many years of being sick, I finally went to the doctor. My doctor told me Barrett's esophagus is pretty common. 1 in 100 people will be diagnosed with that every year. I'm not special. The doctor told me that I will eventually get cancer, but I'll just have it laser out. No big deal. It requires yearly visits to a special doctor, requires higher cost procedures. I was also diagnosed the same year I had an insurance plan with a high deductible. My first, I had had 2 endoscopies. My first one cost $7,868 in shop fees, one procedure. My insurance plan covered $2,512.78. It left me to pay $5,355
3
for
minutes.
one procedure. Did you catch that? $5,355 out of my deductible. I hate to admit this, but it's stressed out. I haven't gone back to that doctor. I'm waiting 3 years to go again to go get it because I'm not going to go to a specialized doctor to have them say, "You're fine, good job, keep on the medicine." I had a rash on my neck last year. I called Teladoc because I didn't want to pay $45 to give me some cream. They told me I had a fungus. I got fungus medicine, and 3 weeks later, it was still there. I went finally to go in to Mogo, deferred care. It wasn't a fungus, it was eczema. And Teladoc, it's hit and miss. You can call back again and maybe get a different prescription. Sorry, really fast. My son was diagnosed with ADHD in October and autism this summer. He was put on a waiting list. Every time we go to see that doctor, it costs $95. Last May, my son was in a biking accident at the pump track. He sliced his upper thigh. I was calling friends, can I just put some Neosporin on it? Be good. I went to urgent care. They said, absolutely not, go to ER. And it cost $400 or $45. And I looked and I just cried and I prayed, what do I do? Now he needs surgery in San Francisco at UCSF, which I'm gonna have to pay out of cost. I schedule it for January, even though he needs it now, because then it will reset for the New Year's treatment deductible. All these stories, Barrett's esophagus is common. ADHD and autism are sadly on the rise. And I'm not special. This is just one household, one common thing. Kids get injured, kids get hurt, and it's so expensive. So thank you for your consideration and remembering me and all these stories as you work towards helping us be more affordable.
Thank you. We're going to keep taking testimony from in the room, and at the end of the line, we'll go to our individuals online and see if they're able to unmute successfully. So we'll continue here in the room. Please go ahead.
Is the mic on? Okay. My name is Celine Ogden, and I am a Monterey County resident. I was born at Chomp. It is my honor to say that this is my 26th year of teaching. 20 of those years have been with MPUSD. I teach right here in Seaside. When I started teaching at MPUSD, I paid $140 a month for health insurance for my husband and myself, with a maximum out-of-pocket of $3,500. Currently, for similar health insurance, I would have to pay over $1,600 a month with a maximum out-of-pocket of $6,350. Just this monthly premium has gone up more than 10 times the price. This, as you can guess, is not affordable. As you can imagine, my paycheck has not increased at the same rate. I am 51 years old, so since I was 18, so for 33 years, I have been able to follow my doctor's recommendation for my health until this year. I am a cancer survivor. When I was 23, I was diagnosed with cancer. Luckily, I was able to have surgery and I am cancer-free. For the past 28 years, I've had to have just basic care to ensure that I'm cancer-free. This year, my doctor has ordered an outpatient procedure. However, I do not have access to my local hospital or any hospitals in my county due to the extreme cost of health insurance. I will have to have this procedure performed by a doctor I do not know outside the county, and instead of losing 1 day of work to have the procedure, both my husband and I will have to lose multiple days of work. It blows my mind that as I have progressed with my career health insurance has become unaffordable. This seems backwards to me. When I tell my friends and family about the state of my health insurance, they inevitably say, yeah, but you're a teacher. This happens over and over. What that tells me is that most people still think teaching is a job that will pay for good quality of life with good health benefits. This promise, which was a main incentive to pursue this career for myself and many others, has become a false promise. Our health insurance needs to be affordable and allow us to use our local resources. I should not have to go to an unknown doctor and travel outside the county for a basic procedure. I should be able to go down the road to my local hospital and have my doctor do my procedure. I cannot even explain how stressful, scary, and even upsetting this is for me. I stand here today to plead with you to please take action to make our healthcare affordable and allow us to use our local resources. I appreciate this opportunity to make my voice heard because I know I'm not speaking for myself, but for many of my colleagues. Thank you.
Thank you. Please step up to the podium and go ahead.
Thank you. I'm here to share my personal experience with the high cost of healthcare in our community. My name is Haikui Demarian. I'm an educator with Monterey Peninsula Unified School District. My journey with exorbitant healthcare costs began 10 years ago when I suffered a stroke at the age of 33. Initially misdiagnosed by the emergency room and having an atypical migraine, I was sent home. It wasn't until I returned later that evening and underwent additional MRI tests that the stroke was confirmed. This misdiagnosis set off a cascade of hospital and medical bills as I was required to stay in a hospital for over 2 weeks and undergo months of speech and cognitive therapy treatments that could have potentially been avoided had I received a clot-busting drug. Given my medical history, I'm now enrolled in our district PPO plan, which allows me access care at any of the 3 major local hospitals. However, this comes at a steep cost. I pay nearly $700 monthly for my individual premium. If I were to insure my family, the cost would rise to $2,886 monthly, my cost, an amount we simply cannot afford, even with the district's contribution. Last year, I was rushed to the emergency room by my husband due to excruciating abdominal pains. After a 4-hour evaluation, I was discharged without any procedure or treatment. The visit, along with the subsequent MRI, was billed at over $16,000 to my insurance, resulting in an out-of-pocket cost of $4,500. Despite not requiring an ambulance transportation, an overnight stay, or any procedure, the financial burden was significant. We managed to pay this bill through a payment plan only to find ourselves enrolling in another payment plan for our child's mental health evaluation under my husband's insurance. The one-time evaluation at a local adolescent behavioral center for 1 hour in April 2024 has already cost us nearly $1,700 out of pocket. And this does not even include the therapy or services we have yet to receive, as we have been on a wait list since April. My story is just one of many, if not hundreds, in our area. While we consider ourselves fortunate to have a dual income household to barely manage these costs, many of my colleagues are not as fortunate. Thank you for providing me the opportunity to share our ongoing struggles with the rising cost of healthcare, and I urge the board to consider the profound impact these costs have on educators like myself and countless others in our community. Thank you.
Thank you.
Good afternoon. My name is PK Diffenbaugh. I'm the superintendent of Monterey Peninsula Unified School District. I want to thank you for the opportunity to speak today and to hear from so many of our staff and teachers and from all over the county. I know that healthcare is a complex system, and having something to know, knowing a little something about complex systems, I know that there's no easy solution. But we can make progress, and I'm here to ask for your help. The current situation is unsustainable, and it's impacting our employees, as you've heard so passionately them tell their stories. And as they said, they are representative of literally hundreds of our employees across our district. But what I will also want to make sure you understand is that the situation is impacting our students. MPUSD's population students is overcoming tremendous challenges. 20% of our students are experiencing housing insecurity and are defined as homeless under the McKinney-Vento Act. That's 1 in every 5 students you see in our classroom. Because of the high cost of living, including healthcare, every year MPUSD loses 80 to 100 certificated staff, representing nearly 20% of certificated staff turning over every single year. What this does is it creates tremendous instability in the classroom. The best thing we can do for our students who are already overcoming a lot of challenges is to create the stability where they are seeing their teachers every single day, and their teachers are allowed to grow in their profession and stay here in the community. Currently, that is not possible. So what we're doing is having our most vulnerable students subjected to some of the highest turnover in the state. And that's impacting their future and their well-being. So I just leave you by asking for your help. We know, and it was extremely clear, that we have analyzed this problem and we have come to some root causes. I don't pretend to know exactly regulatorily how you can do something, but I ask you to do something. There's an urgent situation here, and we can spend another 3 or 4 years talking about the same data. I assure you it will stay the same 3 years from now, or we can take action. You have the authority to do so, and I hope that you do. Thank you so much.
Thank you.
Good afternoon. I'm Laura Lucia. I'm the director of the healthcare program at the UC Berkeley Labor Center. The Labor Center does research on healthcare affordability for California workers and their families. And over the last year and a half, the situation here in Monterey has been one focus of our research. We published a blog post last year on this and also submitted some written comments leading up to this meeting. I appreciate OCA hosting this meeting here today after so many Monterey County workers have traveled to Sacramento over the last year and a half to share their really concerning stories. And their stories are very consistent with what we saw in the data today and what we've been seeing in the data as we've looked at done our research. The prices are extremely high. And I appreciate Dr. Carlisle's references earlier to the large body of research that shows that it's prices, not utilization, that are the driver of why we pay so much for healthcare in the United States. And as today's slides showed really well, California has higher prices than the US, and then Monterey is among the highest cost regions in this state. And the large price difference we see here in this county cannot be explained by wages or by payer mix or cost shifting or by demographics or health status, as a lot of the data today shows. But a number of research studies have shown that lack of competition is correlated with high prices. And this includes research that we'll hear later today from Professor Chris Whaley. The hospitals set their prices so high because they can. OCA has an opportunity to make an impact here by reining in spending growth for the high-cost hospital outliers in this region, so things don't get worse than they already are for the many workers who've shared their concerning stories today and over the last year and a half, and the many like them all around the county. Thank you.
Thank you.
Hi, Ben Johnson from the California Hospital Association. Thank you for the opportunity to comment on this important issue. CHA and its 400-member hospitals welcome the evaluation of regional variation in spending as an important opportunity to understand what really drives differences in healthcare spending. And we submitted a comment letter to the board in advance of this meeting showing how regional variance in hospital spending across the state shows that differences in population health needs, like aging particularly, as well as differences in expenses are very closely associated with the differences in hospital costs across the state. And underscoring one finding is that actually hospital financial performance tends to degrade as reimbursement levels indeed go up, showing that expense is really an important part of this equation. So we ask OCA to carefully consider the full complexity of what drives variation in healthcare spending and listen to a diversity of voices and perspectives as it continues this important work. Thank you.
Thank you.
Good afternoon. I'm Dan Burns, superintendent of the Salinas Union High School District, just north of us here. We employ roughly 2,000 employees. We're one of the larger employment agencies here in the county. So I want to thank you for hosting this here in the county while you're talking about our county. It's very important that you did that. It is a crisis here in our county. It's been a crisis for a long time. One slide that I noticed was missing is the hospital's profit margins. It might be nice to see that slide as well, because that takes into account some of this balance. So part of the question I have is, what can we really do about it? So I'm really interested to hear that discussion that you have later today, because just shining a flashlight on data doesn't really do much about it, because we do that in education all the time. My colleague, Dr. Diffenbaugh, we shine flashlights on data all the time. But what are we doing about that? Because this is outcome data. What's the process? What leads to the data being the way it is? So I'm really interested to hear how you're going to look at trying to help contain cost here. I want to tell you that I heard some interesting things today. So when we've seen data like this in the past, we might hear a gasp or two, and we might even hear the word outrageous, which I heard earlier today. Today's the first day I heard the word incriminating. So maybe we need to keep that in our thought, because it can potentially be incriminating when we look at, there's probably another meeting happening somewhere in the county where doctors and networks are getting together to say, how do we address what you're trying to address today on the opposite side of that? So I want to address this as well from the educator standpoint. You've heard some stories from local teachers. You know, our educators in our county are at a pivotal time trying to afford the cost of living. If you look up the cost of living here in the county, it's like the second highest or so in the state. And then you add into that healthcare cost on top of it, it makes it even worse. And so why is that important? Because the educators are the ones educating our kids. They're the ones that are promoting all of the growth opportunities and learning opportunities that will seed the future of not just our county, but our nation and across the world as well. So how does this impact that? Well, it impacts that because when a teacher has to make a decision about living in the county and they take into it healthcare cost, that's an important decision-making factor for them. But it's also important because the teachers that do live here now have to make choices. Do I have an illness? Do I come here and get care in the county where it's very expensive, or do I drive to Santa Cruz County? And now I have to plan for that time, which takes me out of the classroom. Now I'm out of the classroom, and instead of planning to help my kids and support my kids, I'm planning on how to get my own health care. It creates an ongoing loop of stress, which then results in an impact negatively on students in the classroom. So keep that in mind while we're having these discussions. That loss of learning is impacted by healthcare of our educators. So once again, I'm highly interested in that discussion, and that simple question of that I ask a lot in the public is, if we don't have teachers teach our kids in our county, who will teach our kids? So thank you very much for your time.
You.
Morning, Oka board members. It might even be this afternoon. Might even be an afternoon by now. My name is Tony Uzzel, Senior Field Rep for Carpers Union Local 605, located in Marina, service in Monterey County. Many of our members are Latino, and a lot of times I talk to my members, and a lot of times they go back down to Mexico or South America for healthcare, because the healthcare here is so expensive. It costs so much. You gotta ask yourself why. Why does it cost so much? Got to be more than just paying for a view out here in the Monterey County. If we can go down to the mechanic and say last month I got just say I got my tires changed on my car. We know the price of what that's going to cost. We know that it's a set amount. Why can't we know that for health care? Why can't I go down to the doctor and says, hey, you know what? I need a physical. I go down and take a physical. I'm going to get blood work, a urinalysis, get my temperature checked, get my weight and blood pressure. It's fixed. Why can't it be a fixed price for that? Not everything going to change. Not everything's the same that way. We can't go down if you got cancer. All cancer is different. So we can't have a set price on cancer, but can we have a set price on, sorry, a physical? Is that feasible? I envy you. Well, I don't envy you. What you have to do is kind of monumental. It's not just a task. It's not going to, it didn't happen overnight. You're not going to fix it overnight. For certain things you can change overnight. A set price of some of the services that the hospital is supposed to provide for us. Why can't we have a set price for it? Why can't that change overnight? Okay. If I go go to the doctor for a dental or root canal, I know what that root canal is going to cost me. It's a fixed price. Why can't we have fixed price in the medical field? This is some of the simple things that help out down here in Monterey County in California for our citizens, for our children. So we'll know what that price is going to be before we go in and not get a bill at the end and say, okay, here's your bill, $10,000, $15,000. That's ridiculous. We should know those prices. And that's all I'm asking for. We get a pay raise. We get an extra couple of dollars on our paycheck coming in the front door, but yet it's being taken out the back door because of healthcare. That's a change. That keeps us in the same situation we was in yesterday. You have that power and that authority to make those changes. We ask that you do it. It's not going to be easy. We're going to have some naysayers, going to have pushback, but the simple things can be done. One step at a time. Thank you for your time.
You.
My name is Alicia. I'm a local nurse. I used to work with CHOMP, and now I'm working with a school district, Salinas Union High School District, Mr. Burns' district. And, you know, our district of 15,000 students, we have 2, at best, 3 nurses. And our goal is to keep those students out of the hospital, to keep them in school. And then those with chronic illnesses, to keep them as healthy as possible. Luckily, the majority of our students, I'd say, are covered by Medi-Cal, probably somewhere between 60 and 80%. Can't quite get the data. But those students that aren't, so the students that are, access to care is still a problem, of course. But for that 20 to 40%, let's say, that aren't covered by Medi-Cal, they do have an extremely difficult time accessing care at an affordable rate. And then from a personal perspective, I just want to throw some numbers out there. We are a family of 4. We're both in school districts. And we pay about $15,000 a year out of pocket for our monthly premium. And then we do reach our out-of-pocket max every year. So we're spending about $30,000 a year out of our money, $30,000 a year, not including prescriptions. Of course, that is with 2 people with chronic illnesses. I understand that that makes it different, but still $30,000 is a huge chunk of what we make. And so my option, when I hear Steve talking earlier about how McSig is going to have to raise rates about 12% this next year, I have to look and say, is it time for me to go back to a hospital system where I no longer can help on the prevention side and I have to then switch over to the response, which, as we all know, right? Prevention is where it's less glamorous, but it is where we can make the big changes. So whatever you can do to help keep our costs under control, both for the students and for the staff. Thank you.
You.
Buenas tardes a todos. Mi nombre es Mi nombre es Marisela Ramírez. Trabajo con la organización Centro Binacional para el Desarrollo Indígena Oaxaqueño en Salinas y estamos trabajando con las comunidades indígenas y hemos escuchado muchos casos injustos hacia la comunidad indígena y a la comunidad en general sobre el trato que dan y el costo de la salud. En los hospitales de Salinas han habido casos que por ir solo a emergencias les han llegado facturas de más de $81,000. Además de eso, tengo entendido que tienen fondos de apoyo financiero, pero muchas de las veces esto no se comparte con la comunidad. Entonces, la comunidad se ven en la necesidad de pagar todos estos gastos y en otros casos los mandan a colección y no les dan alternativas. Y he escuchado de la misma comunidad que no han ido a atenderse por miedo a pagar miles de dólares en salud, aparte de estar pagando altos costos de las viviendas. Aunque hayan seguros médicos como Medical, ellos no califican supuestamente por su alto porcentaje de ingresos y solo calificarían si ganan menos de $400 a la semana o en definitivo que estén desempleados. Solo para recordar que la mayoría de la comunidad que vive en Salinas son trabajadores agrícolas y trabajan por temporadas, y lo máximo que pueden llegar a ganar sería $18,000 anualmente. Gracias.
She says, good afternoon. My name is Marcela Martinez. I work with the organization of the CBDIO in Salinas, Monterey. We are working closely with the indigenous communities, and we have heard many cases of injustices within the indigenous community and the community in general when it comes to the cost for health insurance and health coverages. In the hospitals in Salinas, there have been cases where they've gone to go to an emergency and they've been billed a total of $81,000. And that's on top of, that's what one person has to pay. And that's on top of getting funding from the government, and it's still not enough. And sometimes they deny they don't want to go get treated, go to any hospital because they don't want to be billed that much. I have heard in my own community that they haven't been able to get any medical treatment, and they'd have to go for miles to go to another healthcare provider and to go to another hospital outside of their community. And they don't even qualify for Medi-Cal because it says that you have to make a monthly amount of $400 to qualify for Medi-Cal or just be unemployed altogether. And I want you to remember that the majority of the community that lives in Salinas are agricultural workers and that work in seasonally. And the most that they can make would be $1,800 annually is how much they make. Thank you.
Thank you. I think we have two more people in the room who will be speaking, and after those two individuals are finished, we'll turn to the individuals online with raised hands to see if they're able to successfully unmute and speak. So turning back to the room here, please go ahead.
Okay. Hi, my name's Jen Villa. I'm a special education teacher at Rancho San Juan High School. I'm also honored to have been named the Teacher of the Year for this county in 2022. However, I'm also that teacher that's a perfect example of everything we just gone over today. I'm that teacher that was the feature in the Bloomberg article. I had to drive almost an hour to have my son. I literally had him as they were registering me in. They called me the stop and drop mom. I live literally maybe a couple blocks away from a hospital. It does not serve me, but I serve the children in the community that it serves. I didn't have that accessibility that we speak of today. I'm also that teacher that was in a newscast, or I was in the local news with Aaron Clark with a story about how I'm that teacher who 11 years ago was paying about $60 a month in premiums. Single mom, I can make it. 11 years later, I'm that same teacher that spends over $500 a month now, still as a single mother. I don't know what else has changed in price that much. It's almost 1,000% more expensive. What else do we spend that much more in a matter of 11 years? I'm also that teacher that was quoted in the governor's press office with my quote, I think when I was speaking to you, Bunch, last time, about my budget. I cannot afford this anymore. I cannot not feel disrespected when we're thinking about profits of a hospital when I'm already at my bottom line. So now I'm this teacher, that teacher, asking you to not allow a 3% cap growth raise. It's inconceivable. You could charge us an extra 0.5%, and I guarantee you, you'll still be making profits. And I guarantee you, you will still be squeezing us past our red line into our budgets. I'm with this gentleman that spoke before me. It is up to you, and it's such an important position to be in, to decide for the people. People before profit. Please, in healthcare, people before profit. Thank you.
Thank you.
Beth Capel on behalf of Health Access, and I know we have other speakers, so not quite last. You know, you've had a lot of learned presentations and you have more to come. We summarize them very simply. Welcome to Monterey County, home of the highest healthcare costs in California. So that's the first point I want to make. The second point, and you had some earlier discussion about deductibles, it's not just that the amount has gone up. It used to be that deductibles for employer coverage in California were uncommon. Now 80% of Californians have deductibles. So it's not just the amount, it's the prevalence. It's really shifted, it's really changed the dynamic. And that's because that's an effort to control premiums by shifting costs so that people don't get the care they need. And Dr. Pan cited back to the RAND study, which showed clearly it was both inappropriate and appropriate care. So, and worse for those in median and lower incomes. The final point I'll make, and we'll come back again this afternoon for longer discussion about what you can do. The state of California has rate review for the market that is regulated by the state of California. Health Access has asked that rates not increase more than the target that you have set. And we look forward to working with the Department of Managed Healthcare and the Department of Insurance to make that a reality. The law already provides connection between OCA's work and the state regulators. And so we think we have opportunity to do that and working with the other large purchasers who are not subject to rate review. Thank you.
Thank you. Okay, we'll take one more individual in the room at the podium, and after that point, we will turn to the individuals online. Please go ahead.
Thank you. I'm Patrick Pine, administrator of the Robert F. Kennedy Medical Plan, which is the plan that serves the United Farm Workers. Thank you for traveling here today and hearing us out. I do want to interject a comment, especially for Dr. Pan. The plan is named in honor of Robert F. Kennedy Sr., not Jr. I have previously testified to you, and so my comments today will be brief. While I have been hearing principally from advocates who identify themselves with the union side of the table, I think it's important to mention a couple of things. The other thing is a lot of the folks here that you're hearing from are from Teachers Unite here. You don't see very many farm workers. That does not mean the farm workers aren't just as equally agitated. But right now is peak harvest season in this area. For a lot of them, they can't afford to give up a day of work, or their employer won't let them take a day off to do that. So that's why they're not here. Don't think that they are not just as concerned as their fellow union advocates that are here today. Second thing I wanted to bring up is while you're hearing a lot from people who are described as union advocates, I serve a board of trustees that's half employer representatives and half union leaders. And I can tell you that some of the employers that are my trustees and some of the employers that I serve have major operations in this area. And not only in this area, but they have operations in other parts of the state and other parts of the country. These are substantial organizations. So they have some idea of what healthcare costs, not only here, but in other areas. And universally, they all know that no place is more expensive than hospital care in Monterey County. And they're not happy about that because as much as it affects the employees, it affects their bottom line too. It also affects the whole bargaining relationship, as you've already heard. But I can tell you that my trustees and the employer trustees have authorized me to represent that, whereas a lot of the times business executives, quite frankly, are reluctant to make comments at hearings like this. In this case, they feel very strongly, and what I would basically say on this issue, the labor side of the table and the management side of the table are united in their frustration with the high prices in Monterey County. I could go on about a lot of the comments that were earlier today. So the last thing I want to close with, I sort of feel like Don Quixote. 10 years ago, when I started in this plan, I've been battling with Salinas Valley and Chomp the entire time. I probably spend more time dealing with them than anything else I do in my job. And I have explored all kinds of issues about it. But the universal thing is they have been more expensive by any measure you want to any place else in the state, most anywhere else in the country, with minor exceptions. Now, there are some high-priced hospitals elsewhere. There are some in Santa Clara County. The hospital in Santa Cruz is probably just as expensive as the ones here in Monterey County you're hearing about. But the reason Monterey County is important is because there's not a lot of easy alternatives for the people who live here. It's not that easy to go travel up to San Jose. It's not that easy to go south. And it's not just because they don't all live in Salinas or Monterey. They live in Soledad or King City. So you live in King City and you need to go to a hospital. It's an awful long trip to get all the way up to San Jose. We've tried other things like transportation. We'll cover your cost of transportation to get you up to a lower. Most of them don't want to do it because I don't know how long I'm going to be in the hospital. Will my family be able to visit me? There's a lot of reasons. The other transportation hurdle that we've run into, and it happens to telehealth, is there's a big language barrier. If you're Spanish speaking, but it's colloquial Spanish, I have vendors call me all the time. Well, we'll use the translation service. And I go, that's not going to work. They need to be able to, but the other issue, and it's the elephant in the room, is the immigration issue. If you're undocumented, or even if you're documented, but somebody else in your household is undocumented, or maybe your coworker or your friend is, you're not going to get in a vehicle with somebody you don't know. You're not going to get on the phone with somebody you don't know. We have tried those alternatives with our members, and they are scared to death to do that, and for good reason. And so those are some of the practical reasons that inhibit some of the uses that we've talked about and explored with it. But I am excited, and I mentioned I feel like Don Quixote. I got a call a couple of years ago from some of the folks at Unite here saying, we heard you've been fighting with Salinas Valley and been fighting with Chomp. And I said, yeah, finally somebody else is hearing me. And it's led to today where I'm getting a lot of affirmation of the things that I've been fighting about for at least a decade now. So I'm happy to hear these presentations today. I feel like I've been a little bit vindicated. So thank you for your time.
Thank you. Okay, now we're going to turn to members of the public who are online. Just to preview, when I call your name and let you know we've unmuted on our end, you'll still need to unmute on your end, and then please go ahead and speak. So here we go. We're going to start with Caesar Lara. Please go ahead.
Yes, are you able to hear me?
Yes.
Oh, it's about time. So Cesar Lara with the California Labor Federation. We represent 2.1 million members across the state. And been joined you before in Sacramento. Unfortunately, I have COVID today and can't join you in person. But thank you so much for Dr. Galley and the rest of the board for coming to Monterey County. And just to give you guys a quick overview of Monterey County, 65% of all workers work in hospitality and ag. The average salary of a farm worker and a hospitality housekeeper is $28,000 a year. Immigration is a major factor. Thank you, Patrick, for bringing that up. Per capita, Monterey County has the most undocumented individuals, more than any county in California. And today you heard it clearly spelled out that Monterey County is in crisis over healthcare. The utilization rate is low, not because of youth, but because of cost. Healthcare costs are holding back our economy in that county. And I want to bring to the board, here is your opportunity to address the problem statewide. if you look at Monterey County and are able to solve the problems there, you could solve many of the problems across the states. We, as a labor community, work really well with employers across the state, including those in Monterey County. And as you could show today, we've presented a cross section of those workers, but also it's clear to understand that many employers that I've spoken to in Monterey County are fearful to speak up because the fear of retaliation from these healthcare providers. And in Monterey County, we could show that there is some collusion happening between two of our largest hospitals in Chomp and Salinas Valley Health. And so many of that is being affected by working families. So thank you for coming to Monterey County. And now it's time to address the problem. You've made a major step forward with capping costs at 3% soon, but you have to look at the variations in costs county by county. And Monterey County clearly shows that there's a problem here that needs to be more focused on, and we need to investigate. Thank you.
Thank you. Next, we're going to turn to Walter Wagner. We've unmuted you on our end. Please go ahead and unmute. Walter Wagner, please go ahead and unmute. Mr. Wagner, you're not unmuting on your end, so we are going to move to the next member online who is anonymous, named Anonymous online. Please go ahead. We're going to unmute you on our end. And please go ahead and unmute on your end.
Hi, thank you.
Yes.
I'm a resident of Seaside in Monterey County, and I have Blue Shield health insurance, and the main provider available to me is the Montage Medical Group. I'm a healthy person in my 30s, so the personal experiences with healthcare in Monterey County that I'm sharing today are for simple, non-emergency services. Last year, I had an abnormal pap smear. The typical follow-up and what my doctor recommended is a colposcopy, where abnormal cells are biopsied and screened for cervical cancer. Despite being routine and the recommended course of action, colposcopies are not considered preventative. I had the colposcopy. It wasn't covered by my insurance, and Montage billed for a total of $1,246, $338 for the procedure, and $908 for the lab screening of 4 samples. After $255 of in-network savings, I paid a total of $990 out of pocket. This year, I had another abnormal pap smear. For some context, a family friend died young from cervical cancer. Although she had the abnormal pap warning sign, there was no follow-up, and 3 years later at her next pap smear, it was too late. So with this possible early sign of cervical cancer, my doctor's recommendation, and fortunately the means to do so, I got the colposcopy again. This time, Montage billed $999. And after $180 of in-network savings, I paid $819 out of pocket. It was less expensive because there were 3 biopsied samples instead of 4. Paying approximately $1,000 unexpectedly for a basic outpatient service with no complications does not feel affordable. And also based on the data presented earlier, I could get 2 MRIs for the same cost, so that's interesting. I don't have time to go into the details of other concerns, but will mention that the lack of doctors and appointment availability is also alarming in Monterey County. As a new patient, it took 8 months to be able to see a primary care provider for a 20-minute appointment for an annual physical. After multiple cancellations, 2 on the doctor's side and 1 on his, my partner is coming up on a 15-month wait for an annual physical. Ironically, I just received a mailer from Blue Shield stating that for preventative care appointments, you can expect to have access within 30 calendar days of your request, but that's just not the case in Monterey County. Thank you for your time.
Thank you. Next, we've unmuted Bruce Hector. Bruce, you can unmute on your end now. Please go ahead.
Can you hear me?
Yes, sir.
Excellent, thank you. Terrible trouble with that mute button. My name is Bruce Hector. I was a private practice family physician in the San Fernando Valley of Southern California from 1976 to 2020. I cannot address any of the issues in Monterey County. I would like to talk about some of the OCA recommendations. OCA recommends a value-based payment system for providers. Doing so requires adoption of some risk assessment for each patient. Last September, the California Hospital Association warned OCA that per capita spending limits on spending growth without adequate risk adjustment will punish providers who treat a disproportionate share of the sick and the poor. Research has demonstrated the risk adjustment using age and sex alone, as OCA has proposed, is virtually useless. Additionally, value-based payment presumes financial gain as a provider's primary motivation. While true for corporations, I and most of my colleagues find such a premise insulting. We took a Hippocratic oath to serve our fellow citizens. Most of us need no additional incentive. I attended many of the Healthy California Commission Zoom meetings. They noted advantages of a unified finance system, a slippery euphemism that could include single payer. The Commission noted that single payer would provide sufficient funds to cover all California residents and provide dental, vision, mental health, and long-term care without additional cost. Reading through the OCA website now, one no longer finds any mention of this. What happened? Did the legislature eliminate the best way to achieve equity and cost control? Instead, we see recommendations to arbitrarily cap cost growth at 3% with no limit on corporate profit. Since the mid-1990s, HMOs have promised to control costs and improve quality by managing care, based on the false assumption that providers overutilize services. This is not true. We've clearly learned that today with presentations. 40-plus years of HMO participation has demonstrated that corporate management has only resulted in immense corporate profits, gross abuse, and billion-dollar fines, and a reduction in U.S. global healthcare rankings over the last 15 years from number 39 to number 69 today. How much more evidence does OCA need to see that this market system is not working? The best way to save money is to eliminate greedy corporate involvement. One last comment. Since we've proved that utilization is not the issue, HMOs, from the provider perspective, HMOs control utilization. If utilization is no longer the issue, please remove the burden of utilization review, treatment authorization, and all of that expense from both the provider and the carrier end. Thank you. My time is up.
Thank you. Next, we're going to turn online to Dee Dahlman. Dee Dahlman, we've unmuted you on our end. Please unmute and go ahead. Dee Dahlman, if you're able to unmute on your end, please. Okay, we'll move on to next.
Mention that the microphone is in the upper right-hand corner that we have to use to unmute, please.
Okay, yes, you should see your microphone in your Zoom Teams upper right-hand corner. Thank you. But with that, we're going to turn to Dr. Manny Nunez. You've been unmuted on our end. Unmute on your end, please. Go ahead.
Thank you. Good afternoon. My name is Dr. Manny Nunez, and I serve as the Assistant Superintendent of Human Resources here for the Monterey Peninsula Unified School District. Our district is home to 1,200 employees roughly. That includes teachers, classified staff, and managers. I want to thank you for hosting the meeting here in our county and allowing us to share the perspective of the people that really live here and, of course, of this critical issue that impacts all of us. The issue of benefits is one that we, I like to say in our department, Human Resources, approach with a sense of dread each year due to the significant impact it has on our ability to recruit and retain employees that are needed to serve our students. As you've already heard from some of our teachers, their personal experiences really underscore the challenges we face. It's not common as my team and I travel across the state to recruit. We find that people are really naturally drawn to our community and they want to come here and work. They love what Monterey does. They fall in love with the weather, the beauty that surrounds us, and just the overall appeal of living here. However, after discussions with our benefits department, some candidates begin to have second thoughts, and in some cases, they ultimately decide to decline the offer. Unfortunately, this happens quite a bit in our system and ultimately impacts our ability to fill vacancies. It's a huge critical issue for us when it comes to recruitment. In my leadership journey, I've learned that addressing difficult issues is not something that I've done alone. It's always taken a group of committed individuals to start creating change and start creating that ripple movement. So we're here to ask for your support and help to advocate for the resources and changes that we need in order to make sure that we are able to retain and recruit the teachers, the classified staff, and the leaders that need to make this community what it is and a great place to live, but also that they can afford the benefits so that they can survive. Thank you for your time and consideration.
Thank you. Next, we're turning to Corinne Frugoni. We've unmuted you on our end. Please go ahead and unmute. Go ahead.
Can you hear me?
Yes.
Famous last words. Thank you. My name is Corinne Frugoni. I'm a family physician up in Humboldt County, and I'm also co-chair of the local Physicians for a National Health Program, Healthcare for All chapter, and a member of the privatization to end the, a member of the movement to end the privatization of Medicare. First of all, I would like to reinforce what Dr. Anna Malinow suggested. The suggestion was sent in a letter that is in the public record, along with a very eloquent, elegant letter by Dr. Bruce Hector, who just spoke. We are recommending that an experiment or a demonstration project be set up to really understand and analyze what risk adjustment does. So far, it's proven to do nothing in terms of trying to set spending caps fairly. If you look at any scientific experiment, even pharmaceuticals, they all have a demonstration project before they implement an entire program. So please consider setting up a demonstration project. I do appreciate all the data that has been collected. Some of it has already been done. It's been well researched. Some of it may be new, but I'm concerned because the data is all looking at prices. I'm wondering, where is the money going? Well, I have an idea. The true driver of cost, and I'm not alone in this, are the excess administrative costs that are intrinsic to our multi-payer system. And that relies on the pursuit of profit that is perpetuated by private health insurance and excessive drug and medical device equipment prices. There's a lot of talk about competition, but in our we need competition. We need a competition in terms of providing quality. And there's lots of ways to determine that. Much of it done by patients who decide what works. But competition in terms of prices and setting up managed care, competition can only set up a system where the biggest, baddest, most ruthless companies win. That is our economic system. It requires that. That is why United Healthcare is taking billions out of our healthcare system that is not going into direct healthcare. We need to focus on access to care, eliminating medical debt and bankruptcy that you heard some very heart-wrenching stories, and eliminate inequities in our underserved population. What I'm wondering, many of you have sat on the Healthy California for All Commission. Dr. Gailey, you ran it beautifully. What happened to the recommendations of this commission? It concluded that unified financing of healthcare, it has to be nonprofit. Unified financing of healthcare would provide statewide universal access to care and improve population health.
3 minutes.
For cost. And when I say unified financing, I don't mean United Healthcare financing. I mean a government-run unified finance system, such as single payer, where people have much more choice in where they can go, no networks. I also encourage the board to look at Connecticut that got rid of managed care for Medicaid and has lowered costs. Please look at that program. Thank you.
Thank you. Next, we will turn to Kelly Haro online. Kelly, we've unmuted on our end. If you can unmute on your end, please. Please go ahead. Oh, Kelly, you just remuted yourself. You were unmuted there for a moment. You want to try one more time? Please go ahead.
I've got it. Thank you. Sorry about that. Kelly LaRue, representing the California Urgent Care Association. We have about 1,300 urgent care settings in California that provide quality healthcare in urban and rural communities. With a median patient volume of about 56 patients per day, over all our facilities, we serve about 500,000 Californians each week. The urgent care community appreciates the office's efforts to highlight the work public payers and their participating health plans do to maintain networks for their members at an affordable price given the challenging market conditions. The uninsured rate in California is the lowest it has ever been, but utilization is down given how difficult it is to access care at times. Urgent care centers prevent around 24.5 million emergency room visits annually, which not only reduces the burden on emergency rooms, but also saves patients and the healthcare system valuable time and money. The 2021 study found that the average cost of an emergency room visit is about $1,646, while the average urgent care visit cost is only $171. When contracted with Medi-Cal or employer-sponsored plans or on exchange plans, urgent cares are a valuable resource when crowded emergency rooms and primary care setting appointment wait times are long. Payers have only begun to realize the value of a more easily accessible and affordable healthcare setting that includes urgent cares in the network and information on when to use which setting. The urgent care community stands ready to support the ongoing work of the office and their payer partners to make healthcare more accessible and affordable. Thank you so much.
Thank you. Next, we'll turn to Bianca Blomquist. Bianca, we've unmuted on our end. Please unmute on yours and begin. Bianca, you're still unmuted on your end. If you could unmute. All right, I'm so sorry, but you're not unmuting on your end. We're going to move to the next member of the public who we're going to drop down to 805 area code. Sorry, they just lowered their hand. So excuse me, we're going to turn to Walter Wagner. We've unmuted on our end. Walter, if you could unmute on yours.
Can you hear me?
Yes, sir.
Okay, so sorry, I'm not sure. It didn't register before, so I logged out and logged back in again, and now it does. I was born and raised in Monterey County. I'm very familiar with the medical system. I've visited with the main hospitals. I work remotely in Monterey County these days, and I've worked in the Medicare system for many years. So I'm going to speak only as to the medical costs for Medicare. My experience is that when you have lots of different insurance companies having policies available, the prices are much better and affordable for the people on Medicare. The competition works. In Monterey County, currently there are 2 Medicare plans available. Most people think there's only one, Aspire. Effectively, there's only one. The other company moved into the county 2 years ago called Imperial. And they do have quite a few doctors and clinics signed up with them. However, they do not have a local in-network hospital in Monterey County. People who want to go to the hospital have to go over to Hollister to use their network hospital. So it's effectively not available, leaving Aspire with a monopoly. And while I would like to see a single payer system of some sort that actually works well, until that happens, I think the better choice is to try to get more competition. And one of the ways is to make the insurance companies that do have service in the county make certain that they have access to all of the hospitals. I'm not quite certain how to go about doing that. That's probably antitrust law, and I'm not certain how well that would work. But the end result should be, if you have the other hospitals signing up with the insurance companies, you should be able to develop the competition that should be helped to drive the price down. So that's my 2 cents. I really liked Corrine, her comments, that it'd be better to have not to have a system where you're having insurance companies trying to fight against each other and giving shoddy service instead to bring the price down. But right now, we aren't anywhere close to the kind of system that needs to be in place. Thank you.
Thank you. Next, we'll turn to Harry Baker. We have unmuted on our end. Harry Baker, if you could unmute on yours and begin speaking. Harry Baker, if you could unmute on your end. I'm sorry, we don't see that you're able to unmute. We're going to try one more time with Bianca Blomquist before we adjourn for lunch. Bianca Blomquist, we've unmuted on our end. If you could unmute on yours.
Hi there.
Please go
Hopefully
ahead.
this works. Friendly reminder for other folks on the phone that the unmute option is to the right-hand corner of the screen. Thank you so much for taking the time and your patience to allow me to speak to you today. My name is Bianca Blomquist. I am the California Director for Small Business Majority. I would like to read a testimonial on behalf of a small business owner from the area that is unable to be there in person today. Her name is Lisa Kazmarzik. She says, good morning, everyone. Well, in this case, good afternoon, everyone. When I first started my business, my income was low enough that I qualified for subsidies through Covered California, but now with the business more successful, the cost of my own healthcare has become a huge concern. I no longer qualify for those subsidies, and my monthly healthcare premiums are approaching the cost of my monthly mortgage payment. Each year, my healthcare premiums increase significantly while my mortgage stays the same. I currently have one employee and periodically use contractors. Unfortunately, I can't afford to provide healthcare to my employees. This weighs on me because I want to support the people who work for me in all the ways I would want to be supported as an employee myself. My current employee works part-time, and I'd love to bring her on full-time as the business grows. But I worry about the implications if I can't afford benefits like healthcare. Would she find another job? Would I be required by law to provide insurance I simply can't afford? These are the questions that keep me up at night, distracting me from focusing on what's best for all of us. I also consider bringing one of my favorite contractors on as an employee, but again, I can't afford to pay for their healthcare. My healthcare costs already consume a significant portion of the business's disposable income. This is one reason I haven't broached the subject of employment with them. In the past 2 years, I've had 3 surgeries. The total bill to insurance was around $210,000, but fortunately, I paid a fraction of that only, plus numerous copays for follow-up visits. These surgeries weren't for life-threatening issues, so I put them off for as long as possible, but eventually I had to prioritize my own quality of life. Every few years, I look for alternatives to purchase insurance for myself and any employees I have. I never find anything suitable for micro businesses like ours. I'm grateful for the ACA because I at least know that my coverage can't be denied. But small businesses like ours are caught between a rock and a hard place. We're treated as individuals when it comes to healthcare, bearing all of the costs of being individuals and the costs of running a business. And reflecting on this, I realize that it's a critical point running through my experience. Small business owners are treated as individuals when it comes to healthcare. However, we bear the costs of being individuals and the burdens of running a business. Thank you so much for allowing me to share this testimonial. I'll lower my hand and raise it again as new testimonies come in. Thank you.
Thank you so much. Before I turn it back to the chair, we're going to try one more time with Harry Baker, who's lowered his hand. Okay, there are no more individuals up at the podium, no more raised hands online. I'll turn it back to the chair.
Thank you, and just thanks to all of the public who came and spoke. We aren't able to respond as part of our responsibility on the board, but I can promise you, you were heard. So let's come back in 30 minutes. Let's be start promptly at 2, if possible. We have a hard stop between 4:30 and 4:45 because we have to vacate the room. Oops, sorry, 5. We have to be out of here by 5. So we're going to, I'm going to try to be the good teacher that many of you could probably do better job than me and keep us on track. So we will see you back here in 30 minutes. Okay, I see, right. I'll model that now. We're going to take roll and then get right back into it. I might, right after roll, make an announcement or two and then get us into it.
Okay, starting with roll call. Mark Galley.
Present.
David Carlisle.
Present.
Sandra Hernandez.
Here.
Rick Cronick.
Here.
Ian Lewis.
Present.
Elizabeth Mitchell.
Here.
Richard Pan.
Present.
Don Molds. Don Molds said he's here.
Okay, so first off, thank you all for just participating in a great morning. We have 2 final presentations. The agenda, at least that I was planning, was a small break between the next 2 items, which we will forego. For the sake of timing and managing all of the public comment, we're going to limit public comment to 2 minutes instead of 3, so that we can get through everybody, because it's so important. I know I love to hear everyone's full comment, but hearing from everyone is a priority of ours. So we're going to put that in place. So if you're preparing your public comments now, go ahead and adjust them accordingly. Okay, so let's jump right in. Vishal, I'll turn it to you.
Thank you, Dr. Galley. So in this next agenda item, we'll be presenting a case study on hospitals in Monterey County and state options to address high costs. In this section, OCA staff, using publicly available HCI data, developed a case study analysis of the hospitals in Monterey. Following this study, Dr. Christopher Whaley, I'll introduce him, will provide an examination of Monterey County hospital prices and potential state options. Next slide. Our analysis depended on 2 publicly available HCI data sets. The first is HCI's hospital annual financial data. For background, on an annual basis, individual hospitals and health hospital systems report detailed facility level data to HCI on numerous measures. HCI houses data for 2012 through 2022, and we've included the link to the data for all interested. The second is HCI's healthcare utilization, patient level administrative data. For some background information on this, HCI publishes aggregated patient characteristics at the statewide, county, and facility level to provide a calendar year overview of patients in general acute care hospital settings in California. And HCI also provides data visualizations for patient characteristics from 2017 through 2022, and we've included the link to this webpage. Next slide. So shown here is a broad overview of the hospitals in Monterey County. For reference, we've provided the latest information from HCI data about each hospital's bed count, inpatient discharges, and outpatient visits. First up, we have Community Hospital of the Monterey Peninsula, also known as CHOMP. CHOMP is a nonprofit hospital located in Monterey that provides general and acute care. It is managed by Montage Health, a locally based and owned nonprofit healthcare network. Next is Salinas Valley Memorial Health, a district hospital located in Salinas that provides general and acute care. Then there is Natividad Medical Center, a public hospital also located in Salinas. Of note, Natividad provides specialty care and has a level 2 trauma center. The last hospital, Me Memorial, is excluded from our case study due to its geographic distance. It is 45 minutes away from Salinas and 75 minutes away from Monterey. Next slide. To drill deeper and gain a detailed understanding of who these hospitals serve, OCA used HCI's patient-level administrative data to develop patient profiles for each hospital. Next slide. Our review of the various hospital profiles finds CHOMP's patient population differs from the patient populations in the Salinas area hospitals. In terms of patient race and ethnicity, CHOMP has a predominantly white patient population, while the Salinas area hospitals have a predominantly Hispanic patient population. In terms of patient age group, CHOMP's patients skew older, while the patients of the Salinas area hospitals skew younger. In terms of patient setting type, the Salinas area hospitals manage a larger share of ED visits. And in terms of patient payer type, Medicare is the dominant payer for CHOMP, while Medi-Cal is the dominant payer for the Salinas area hospitals. I'd also like to note that what is going on with Medi-Cal is much different than what is going on with the commercial space. Medi-Cal, in terms of its payment structures, sets and negotiates prices, while it administratively sets prices, while in the commercial market, it's a negotiation. And then just a flag about supplemental payments and from Medi-Cal and these amounts, as well as the timing of these payments, also may explain some of the differences between these hospitals as I covered the different patient payer types. And then going on to the next slide, the chart shown here breaks down patient race and ethnicity by Monterey County hospitals in 2022. So this is kind of going, providing a more specific numbers to what I discussed earlier. So we see that more than half of the patients who receive care at CHOMP, about 55% are white, whereas for Salinas Valley Health and Natividad Medical Center, more than 3/4 of their respective patients are Hispanic, represented by the gray color. Next slide. So a similar chart to the previous slide. However, here we show patient age group broken out. So looking at the first two sets of color bars in the chart, on the left-hand side, we see that at least half of the patients served by Salinas Valley Health and Natividad are younger patients, those that are less than 35 years old. Meanwhile, CHOMP sees a higher level of elderly patients or those 65 years or older. Next slide. Next, we'll compare each hospital's patient profile to statewide averages and to gain greater context, starting with CHOMP. For readability purposes, the blue signifies the statewide average, and the orange denotes CHOMP. In terms of patient setting type, as shown in the left, CHOMP sees a lower share of ED-only visits compared to the statewide average. Specifically, their share of ED-only visits is 4 percentage points below the statewide average. In terms of patient payer type, as shown on the right, CHOMP sees a lower share of Medi-Cal patients, 9 percentage points below the statewide average, but a higher share of Medicare patients, 10 points above the statewide average. And then there's a bucket of coverage known as other/unknown coverage. This would include various niche programs like workers' compensation, county and indigent programs, and any other third-party payments not included in the others. So the chart shows that those, in terms of patient payer type, CHOMP's other unknown coverage category is 5 percentage points above the statewide average. So as we'll see, this higher share of Medicare patients for CHOMP stands in contrast to the Salinas area hospitals. Next slide. So moving on to the profile of Salinas Valley Health. Again, the statewide average is shown in blue. The purple signifies Salinas Valley Health. When we look at patient setting type, Salinas Valley sees a higher share of ED-only visits, specifically 10 points above the statewide average, which is a clear difference from CHOMP. In terms of patient payer type, on the right, Salinas Valley sees a higher share of Medi-Cal patients, 13 points above the statewide average, and a lower share of Medicare patients, 5 points below the statewide average. Of note, more than half of Salinas Valley's patients are those with Medi-Cal coverage, another clear difference from CHOMP. And then going on to the next slide. Again, blue is the statewide average, and green is Natividad on these two figures. In terms of patient setting type, Natividad mirrors Salinas Valley in that it sees a higher share of ED-only visits. Specifically, their share of ED-only visits is 11 percentage points above the statewide average. In terms of patient payer type, on the right, although similar to Salinas Valley, Natividad sees the highest share of Medi-Cal patients in Monterey County, as nearly 70% of their patients are those with Medi-Cal coverage. Natividad also sees the lowest share of privately insured and those with Medicare coverage in the county. Next slide. So in this short section, we'll review Monterey County hospital pricing through relevant publicly available HCI data. And Dr. Whaley will provide even greater detail on the topic of prices later in his presentation. So going on to the next slide, for an understanding of hospital pricing in Monterey County, we track net patient revenues per adjusted discharge within HCI's hospital annual financial data for the years 2016 through 2022. For some more context on NPR, which we've presented on at prior board meetings, this refers to the amounts or payments received by hospitals from payers and patients for the delivery of care. Our review found the NPR per adjusted discharge for CHOMP and Salinas are consistently higher than the statewide average. And then in the next slide, we'll provide a data visualization. So this chart shown here is the net patient revenue per adjusted discharge in thousands of dollars for this period between 2016 through 2022. The statewide average in net patient revenue per adjusted discharge was consistently lower than that of CHOMP and Salinas Valley, indicating these two hospitals received consistently higher payments than the average California hospital. Whereas the net patient revenue per adjusted discharge for Natividad was lower than the statewide average in 2016, but has been above the average for the last 5 years on record. And then I'm going to transition to CJ Howard to cover some other metrics.
All right. Next, we're going to walk through a few hospital financial metrics, operating margin, charity care cost, and bad debt to help us better understand the operations of the area hospitals. So we provided definitions for each metric. Operating margin is the net income from operations divided by total operating revenue. This ratio indicates the percentage of net patient revenue which remains as income after operating expenses have been deducted. Charity care costs refers to the difference between costs incurred by the hospital for services provided to patients who are unable to pay for all or part of the services provided and the amount paid by or on behalf of the patient. Bad debt is the amount of care that was owed by the patient but not paid. It could be used. It could be due to uninsured care or part of the patient's unpaid deductible and copay. Next slide. To gain insight into the financial profile of these various Monterey County hospitals, OCA evaluated these discussed metrics. A review of HCI financial data finds Monterey County hospitals have positive operating margins indicating profitability. From 2018 to 2022, Chomp and Salinas Valley had significantly higher operating margins than the statewide average. These profits are not associated with larger amounts of charity care provided. Natividad and Salinas Valley have higher levels of bad debt. Chomp has a similar level of bad debt compared to the statewide average, but a lower level of charity care provided. So next slide. Here is a trend line chart. Here's a trend line chart of operating margin by the statewide average and amongst the Monterey County hospitals from 2018 to 2022. The dashed blue line is the statewide average and shows the operating margin for the average California hospital to lie between 0 and 5%. Chomp and Salinas Valley have operating margins that are more than 2 or 4 times the statewide average, indicating profitability. Moving on to the next slide regarding charity care. As a percentage of operating expenses by the statewide average and amongst the Monterey County hospitals from 2018 to 2022, the share of charity care provided by the average California hospital is consistently higher than the share provided by the Monterey County hospitals. On the next slide, we have the chart of bad debt as a percentage of operating expenses by the statewide average and amongst the Monterey County hospitals from 2018 to 2022. Natividad and Salinas Valley Health have higher levels of bad debt compared to the average California hospital. Chomp's level of bad debt is comparable to the average California hospital. In this next section and final section of our case study, we explore hourly wages for 3 hospital cost centers: registered nurses, nursing administrators, and hospital administrators. To gain insight into the employment profile of these Monterey County hospitals, OCA examined 3 cost centers using average hourly wage and productive hours data available in our HCI hospital annual financial data. For clarity, productive hours are paid time spent on tasks that support patient care. So for registered nurses are currently licensed from the California Board of Registered Nursing and employed in the performance of direct nursing care to patients. Hours accounted for in the daily hospital services cost centers and does not include contracted nurses. Nursing administrators are trained registered nurses who supervise nurses in the hospital, including scheduling the transfer of nurses among the services and units, evaluation, and discipline. Hours accounted for in the nursing administration cost center. For hospital administrators, it's to plan, direct, and coordinate all hospital services and manage supervisory staff. So we can move on to the next slide. So findings from this analysis for 2021, the most recently available fiscal year of data include the hourly wage for registered nurses for all 3 hospitals was above the statewide average and below the Bay Area average. The hourly wage for nursing administrators for all 3 hospitals was above the statewide average. Chomp and Salinas Valley Health also exceeded the Bay Area average. The hourly wage for hospital administrators for Chomp Salinas Valley Memorial Hospital was the statewide average. Chomp paid hospital administrators $183 per hour, a rate that is greater than the statewide and Bay Area average of $75 and $67 per hour, respectively. Next slide. This slide shows the hourly wage for registered nurses in Monterey hospitals from 2018 to 2021 and compares these hourly wages to the statewide averages and the Bay Area average. In this time period, we see that the hourly wage for registered nurses for all 3 hospitals was above the statewide average, but never above the Bay Area average. Next slide. This shows the hourly wage for nursing administration cost center in Monterey hospitals from 2018 to 2021 and compares these wages to the statewide average and the Bay Area average. In this time period, the hourly wage for nursing administrators for all 3 hospitals was above the statewide average. CHOMP also exceeded the Bay Area average in each of the 4 years studied. Natividad exceeded the Bay Area average, but only in 2021. And in this next slide, shares the hourly wage for hospital administration cost center in Monterey hospitals from 2018 to 2021 and compares these hourly wages to the statewide average and the Bay Area average. Findings include that the hourly wage for hospital administrators for CHOMP in Salinas Valley was above the statewide average and the Bay Area average for all but 1 year, as Salinas Valley had a sharp dip in hourly wage in 2021. Of note, CHOMP paid hospital administrators $183 per hour, and as already indicated, this is above the statewide and Bay Area averages of $75 and $67 respectively.
Now I'd like to introduce Dr. Christopher Whaley from Brown University of Public Health. Christopher Whaley is an associate professor in the Department of Health Services, Policy and Practice at the Brown University School of Public Health. He received his PhD in health economics from UC Berkeley. Chris's research focuses on healthcare price transparency and market structure, and he has been published in clinical health policy and economics journals. He has presented research results to state and federal policymakers, including the U.S. Congress, California State Assembly, Texas House Select Committee on Healthcare Reform, Executive Office of the President, Congressional Budget Office, and the Federal Trade Commission. I'll now hand it off to Dr. Whaley.
Great. Thank you. And I'm going to extend a thanks to the Office of Healthcare Affordability for inviting me, and a special thanks to Vishal and team for all the hard work that I'm sure went on behind the scenes. I'm Chris Whaley, and I'm excited to talk about hospital prices in the state of California, as well as in particular focusing on Monterey prices. Next slide, please. So why is this such an important issue, and why are we so invested in learning more about hospital prices? And that really comes from the nature in which hospital prices are funded. So there's not a healthcare magic money tree that when healthcare costs go up, we can go out and shake that tree and use that to spend money and to afford our hospital and healthcare bills. Instead, what we spend on healthcare comes directly out of worker wages and other types of benefits. And if we go back in the last 2 decades, we really see where this is manifested and where that money has come from. And so if we just focus on the last 2 decades of a typical individual with employer-sponsored insurance, their wages have basically kept up with inflation, but healthcare dollars and the amount that the workers get paid in healthcare dollars has drastically increased. So over this period, there's been a huge explosion in deductibles. There's been this huge growth in high deductible plans. And if we look nationally, there's been almost a 500% growth in typical deductibles. Employer wage premiums have also increased drastically, increased by almost 300 and a little over 350%. It now costs over $24,000 to provide health insurance for a typical family in the United States. And so I think there's a growing concern that I certainly share, that we're financing healthcare costs and the growth in healthcare costs out of worker wages. And so if we look over the last 2 decades, worker pay increases have come not in the form of take-home dollars that they can use to pay rent, buy groceries, and enjoy life, but rather in the form of healthcare dollars. And if we look at what's actually driven this increase, the largest area of healthcare cost growth has been in private insurance prices for hospital care. Next slide, please. And so this is a opaque market where, despite the importance of hospital care, we don't actually really have a good understanding of what hospitals cost more than other hospitals and how much hospitals compare across the country and within a given market. And so for a number of years, I've led a series of studies that have actually looked at hospital prices and collected data from across the country to focus on hospital prices that commercially insured individuals are paying. And just a few steps in how we've done this study. First, we started out by collecting data from across the country. We started the study very in a handful of states, but have expanded nationally and have a pretty robust sample of national data. We collect data mainly from self-funded employers, some of which are represented in the room today. We also collect data from many state EPCDs. In our latest round of the study, we had data from 12 all-payer claims databases, which I think is the largest collection of state APCDs in the country. And then in a handful of states, we've actually been able to get data directly from health plans themselves. Once we've collected this national data, we pool it and standardize across all the different data contributors, and then we measure hospital prices in two different ways. The first, and the one I'm going to focus on today, and is I think the most interpretable, is comparing hospital prices relative to what Medicare pays. So essentially what we're doing is we're saying, how much does Medicare pay for a given hospital service? And how does that compare to how much a given commercial plan paid? And so essentially we're saying, relative to what a commercial plan pays, how much would Medicare paid for the exact same service at the exact same provider in the exact same time period? And then if we compare those two ratios, that provides, I think, a pretty interpretable way of understanding hospital prices. So if we see that one hospital is priced at, say, 300% of Medicare and another hospital is 200% of Medicare, that's a pretty clear indication of which hospital is more expensive than the other. The other advantage of using Medicare is that Medicare adjusts for many of the things that are maybe reasonable reasons for why one hospital might be more expensive than the other. So we heard earlier today, differences in cost of living, differences in the cost of providing care across different markets and different providers. Those are all incorporated in Medicare payments. Now, some employers may say, look, it's great that, and purchasers as well may say it's great that Medicare has all these types of adjustments, but we just want to compare prices on a dollars amount and not worry about everything that's baked into the Medicare payment system. And so there we have a secondary measure, which we call a standardized price, that is essentially comparing dollars to dollars hospital price differences. Once we've collected this data, we have a public report that kind of goes through our main findings. But I think the piece that's maybe resonated the most is we actually release a database that has hospital prices for about 4,000 hospitals across the country. And unique to many other sources of hospitals, we can actually identify individual providers by name. And so that's the data that I'm going to talk about today, where we really kind of slice and dice hospital prices across the vast kind of dimensions at which prices vary. And then we also have an online tool called the Sage Transparency Dashboard that actually allows individuals to go through and see prices in a kind of more user-friendly way. And so I mentioned earlier, we're using percent of Medicare as our main price comparison. I just want to point out that I don't know what the right price is for hospital care, and we're not saying that Medicare is the price endpoint or that we want to be paying commercial payers should be paying what Medicare pays. We're just using this as a common denominator that allows us to compare hospital prices across the country. And I think this is actually a pretty advantageous way to compare prices. One, Medicare is the largest purchaser of healthcare services in the world. Medicare prices are also developed over several decades with lots of input from industry and other stakeholders, and they're also transparent. So anyone in this room can go to the Medicare website and download Medicare prices and actually see how Medicare makes payments. And so rather than having some kind of black box that no one can understand, this is something that is transparent and interpretable. I think the other advantage is that Medicare prices are designed to be roughly the break-even rate for efficient hospitals. And so Medicare rates are intentionally set at the way that if you're a hospital that's well managed, you're probably going to be able to break even or maybe even have a small margin. Next slide, please. And so we heard earlier what operating margins look like. Before going into our price results, we have something relatively similar that just compares what's the distribution of hospital operating profit margin across the United States, as well as in the state of California. And so what we see is that both in California and in the broader United States, there is a pretty wide distribution. So some hospitals have negative profit margins, which means they operate at a loss, and other hospitals have positive operating margins, which in some cases relatively high, which means they operate at a profit. And just to be clear, this is using data collected by Medicare from 2022. And we also exclude critical access hospitals from this analysis. And if we just look at the average, we see that in the United States, hospital operating margins are about 13% on average, at least in 2022. And in California, they're a little bit lower, but relatively comparable at 11.1%. Next slide, please. And so what did we find when we looked at prices? So the first point that really stands out is that nationally, commercial payers are paying prices that are 254% of what Medicare pays. So what that means is that if you're a typical employer or individual with commercial insurance, the prices that you're paying, either out of pocket or in the form of premium dollars, are set at what Medicare pays, plus an additional 150% on top of that. The other thing that really sticks out is just the wide degree of variation in hospital prices. And so we see in some states like Arkansas, Iowa, and Michigan, commercial payers are paying prices that are less than 200% of Medicare. At the other end, we see in some states like West Virginia, Florida, and Georgia, hospital prices are above 300% of Medicare. Commercial insurance for hospitals is roughly a $500 billion industry, and yet we're seeing almost a 2x variation in hospital prices across states. It's hard to think of another comparable industry with this level of variation. It's also important to think in mind, what does this actually get us? And we'll have some slides later on what does this link to and what actually contributes to the source of price variation. We see also highlighted that California is among the highest at prices just around 300% of Medicare. Next slide, please. We also see this if we just look at the map, and here it really stands out how much prices are all over the map in the United States. We see some regions that are high priced, bordering another region that's low priced, and there's not a clear pattern on what region or what part of the country has high prices versus another part, and it doesn't seem like there's a clear rhyme or reason for why prices vary across the country. If we look at California, we see that prices are high relative to the rest of the country, as well as the highest relative to our neighboring states. And as we have also talked about today, if we were to draw a line through the middle of California and compare Northern versus Southern California, we would again have a tale of two different states. And that variation really comes out if we look across the several hundred hospitals in the state of California. And what we see there is that it's not just the average of 300% of Medicare that individuals are paying for hospital care in the state of California. There's just a tremendous amount of variation. So across California hospitals, there's almost a 5x range in hospital prices, with some hospitals around 100% of Medicare, and so they're getting about what Medicare pays on the commercial side, to some hospitals that are above 500% of Medicare. Again, there's not a clear rhyme or reason why some hospitals are so high priced relative to other hospitals, but there's a tremendous amount of variation in California hospital prices that we probably don't see in other industries in the state of California. And so that's a relatively high and broad view of hospital pricing, both in across the country as well as in the state of California. And so for today, really wanted to focus on how do Monterey hospital prices compare. And so what I did is I took the three Monterey hospitals that are located here that we've heard before, Salinas, Natividad Community Hospital, Monterey Peninsula, and compared them both to the rest of California, as well as a peer set of hospitals from the Bay Area from the following markets. And so what we see here is that the California average is again around 300% of Medicare. This is from 2020 to 2022, and so pooling across the 3 years. And so the Bay Area is just a little bit above what the rest of the California is paying. But what we see for the three Monterey hospitals that they are quite a bit more expensive than the rest of the state and also the Bay Area. So relative to the 320% of what the hospital prices are in the Bay Area, Salinas prices are 340% of Medicare. Natividad is 420% of Medicare. And the Community Hospital of Monterey Peninsula, or CHOMP, is 466% of Medicare. So again, just to put that in context, what that means at CHOMP, individuals are paying either out of their co-insurance or co-pays or premium dollars, what Medicare pays, which again is designed to be the efficient payment rate for well-managed and well-run hospitals, plus almost 500% of Medicare on top of that is margin. We also separated what happens on the inpatient and outpatient side. And what we see here is that on the inpatient side, prices are actually considerably stronger and quite a bit different, especially on the inpatient side, relative to the previous slide, which is both inpatient and outpatient combined. And if we focus just on inpatient services, California is a little bit higher at 298% of Medicare. The Bay Area is a little bit higher than that at 311. And Salinas Valley is higher, again, relative to the 340 we saw earlier, 378%. Natividad is 465, and CHOMP is almost 600% of what Medicare pays. And so again, if you are receiving inpatient care from CHOMP, what this means is that prices are set at Medicare plus an additional 500% of Medicare on top of that. And if we look at outpatient prices, we find a relatively similar story where prices overall for outpatient services are higher than inpatient services on average. And so the California and Bay average prices come up. But even despite that larger increase for California and the Bay Area, the three Monterey hospitals are, again, leading the state in outliers relative to the rest of the state, as well as the Bay Area. And so for outpatient service, Salinas hospitals are 468% of Medicare. Natividad is 444, and CHOMP is 452% of Medicare. Where we actually don't find higher prices is when we look at professional fees. And so if you go to the hospital, you get a bill for what's called the facility fee. And so this is the amount that goes to the hospital to provide the service, provide your stay overnight, provide your device, et cetera. And there's also what's called the professional fee, which goes to the doctor who provides your care. And here we actually find that relative to the rest of the state in the Bay Area, professional fees are quite a bit lower for the three Monterey hospitals, which is in strong contrast to what we saw on the other portions where prices were quite a bit higher. So in California, physicians who work at a hospital get about 185% of Medicare. That's a little bit higher in the Bay Area, about 215%. But among Salinas, it's 137%, so pretty close to Medicare rates. Natividad, 212, and CHOMP, 167%. And so I think the main conclusion here is that the high prices that we see for the three Monterey hospitals aren't being driven by high physician prices, and at least it doesn't appear that physicians are financially benefiting from the high prices that we see in Monterey. So that's a fairly high view of what of prices and description of prices in Monterey, as well as the state of California. And I think it's important to take a step back and try and understand what drives prices. And so as we've been doing this work, there are really three stories that come up. And so the first that really comes up is cost shifting. And so this is the idea that we as a hospital have to charge high prices to offset losses in our other patient populations. I'll provide some evidence on that, but it doesn't really seem like that's the case. And as we heard from the previous presentation, it's not clear that that's actually a strong driver of what we see in the Monterey hospital market. We also don't really find a strong relationship between price and quality, but where we do find a pretty strong relationship is when we look at market power. And so for the first story, and this is the cost shifting story, that we as a hospital have to charge high prices to offset our losses among public payers, and especially on Medi-Cal patients. We don't really see a strong evidence of that. And so to look at that, what we did is we looked at each hospital in California. We looked at their share of patients that came from anywhere else besides private insurance, whether that's Medicare, Medi-Cal, they're uninsured, or providing charity care, and looked at the correlation between that patient mix and the hospital price. And so if it is the story that a hospital does have lots of public or Medi-Cal patients and has to charge high prices, then we should see that the hospitals with the most non-privately insured patients have the highest prices. Instead, we actually see the opposite, where the hospitals that have the most publicly insured, whether it's Medi-Cal or Medicaid patients, have the lowest prices, and the hospitals that have very few non-private patients, and so almost exclusively rely on privately insured patients, actually have the highest prices. And if we, do all the statistical tests, that this holds up. And so at least in our data, and I think if you look at other data sources, it doesn't seem like cost shifting is the reason that explains high privately insured prices. Instead, I think a much more common explanation is that if you're in a market that's desirable for high income patients and privately insured patients, then that just allows you as a hospital to charge much higher prices and to command higher negotiation power with payers and insurers. The other story that really comes up a lot is the relationship between price and quality. And, look, if we're getting better quality for higher prices, then actually maybe we want to be paying higher prices and getting better quality. But again, if we look at our data, that's not really the case or what seems to be true. And so what we did is we took the several hundred hospitals that I had in the earlier slide and then binned them according to what their star rating is if we use Medicare hospital stars. And so this is like Yelp stars, where 1 star is the worst and 5 stars is the highest quality hospital. And so what we see when we do that analysis is that there are many hospitals that have 1 star and have low prices, and many 5-star hospitals that have low prices as well. And so if we look across the distribution between price and quality, there's no, when we look at California, relationship between hospital price and hospital quality. Instead, there's a pretty random distribution of prices within each quality grouping. And if we focus specifically on the 3 Monterey hospitals, we see roughly the same story, where despite having higher prices, the Monterey hospitals actually have lower quality than both the state of California as well as their Bay Area comparisons. And so if we look at the average quality across California hospitals, on average, hospitals have 3.2 stars. And so that's kind of, again, Yelp stars about average. The Bay Area is slightly higher at 3.5. Salinas has 4 stars, while Natividad and Community Hospital of Monterey have 3 stars in hospitals. And so again, despite the higher prices that we saw in the previous slide, that doesn't seem to be translating to higher quality. And in another study, we actually looked at this nationally and looked more to test differences between correlation and causation. And what we found there is that if hospitals increase their prices, and if we look at some of the kind of pretty granular measures of quality, so not just star ratings, but things like readmissions, COPD, heart failure, stroke, knee replacement, revisions, et cetera, we find no relationship between hospital price increases and improvements in quality. And that's a national study where we looked over several years of hospital data. And so instead, where we do actually find a relationship is with market share. And so this slide does something very similar, where we look at what's the market share that a given hospital has within its market, and what's the correlation between hospital market share and hospital prices. And what we find here is that as hospitals obtain higher market share, they're able to increase their price relative to Medicare. And so the hospitals with the highest market share, maybe not surprisingly, have the highest prices within the state of California. And hospitals that are in much more competitive environments and have less market share tend to actually have the lowest prices. And so again, if we do all the statistical tests, this holds up and is shown up as true. And there have been numerous studies that have looked at both California and national data and have found this exact same relationship, where hospitals with higher market share have higher prices. And I think that's important because if we take a step back and focus on what's happened over the last several years in California, what we've seen is that across a variety of dimensions, markets have become much more concentrated in California. And so if we focus on a measure called the Herfindahl-Hirschman Index, or HHI, which is used by the Department of Justice, the FTC, and others to measure concentrated markets or measure market concentration, we see that relative to a HHI of 1800, which FTC or DOJ would consider a highly concentrated market, hospital markets in the state of California have an HHI of 7,000 average. And so that's a incredibly high level of market concentration, which if we were to be in any other environment or market, we would demand federal action to have more competition and more less concentration, less market dominance. I think it's also important to focus on what's happened with hospital acquisition of physicians. And so this is a practice commonly referred to as vertical integration. And what we've seen in California is that there's just really been an explosion in hospitals acquiring physician groups. And we know from several studies that that leads to both higher prices without clear improvements in quality. And we've heard a lot about what the differences are between Northern and Southern California in terms of prices. If we look at these same measures, again, what the FTC or DOJ would use to diagnose a market that's either competitive, concentrated, or highly concentrated, we see that many Northern California markets are highly concentrated, in particular Monterey, versus Southern California, where we know that prices are lower despite still relatively high cost of living and high cost of hiring doctors and nurses. We see much more competition and healthy competition in Southern California versus Northern California. And we know that that's linked to higher prices in Northern California. So again, that's a lot on just kind of, what's the state of California look like in terms of the landscape. But I think it's important to, take a step back and focus on what are the policy options ahead, and also what are some of the innovations that other states and other groups are doing. So we know kind of the main takeaway is that high prices are high and variable, not linked to quality, but instead are driven by market concentration. Policy and regulators, I think, across the country have been relatively slow to act, but I think there's lots of really, important things happening both at the state and federal level. So in our neighbor in Oregon, there's pretty robust disclosures of ownership. And so if you're in the state of Oregon and want to acquire another practice, whether that's hospitals merging or private equity companies acquiring other practices, you actually have to disclose that information to the state, and in some cases actually get approval. This is not just a blue state phenomenon. In Texas, we've seen anti-competitive contract provision bans. I think this has actually been really motivated by what we saw in the Sutter case and some of the anti-competitive contracts that were, I think, at the core of that case. We've also seen lots of action from both the FTC and Department of Justice on both non-competes, provider consolidation, and I think importantly, private equity. And then we've also heard, as we heard earlier today, action on the Medicare side on site-neutral payment policies. And so what are some examples of things that have worked? So one, we heard earlier just how CalPERS recognized that prices were high, variable, and not linked to quality, particularly in hospitals. And so what CalPERS decided, I think roughly a decade or so ago, was to implement a reference pricing program where patients have pretty strong financial incentives to go outside the hospital, particularly for outpatient surgery and to get care at an ambulatory surgical center. And in a number of studies, we've actually documented that this one leads to pretty substantial increases in the use of ASCs. So relative to what we see in a non-CalPERS Anthem comparison group, the share of individuals in the CalPERS population who use an ASC to get outpatient surgery is now above 90% for many outpatient surgeries. And that's led to really strong improvements in both financial outcomes, both for patients, the CalPERS systems, and improvements in quality. And so we've documented that for a range of shoppable services, this program leads to about a 20% savings for both patients and the CalPERS system. Another example actually comes from the state of Oregon, where they recognized for their state employee plan, prices were high, variable, and not linked to quality. And so what they decided to do is put in place a program that caps hospital prices at 200% Medicare. Again, 100% Medicare is designed to be an efficient price, which efficient hospitals are able to break even and have a small profit. And so that's an additional 100% margin on top of that. And so after capping prices at 200% Medicare, what they found is that there was about a 25% reduction in outpatient prices and a 3% reduction in inpatient prices. And to be clear, this is both the Oregon state and public employees system as well as teachers in the state of Oregon. And after adding up all these states or all these savings, these groups saved about $54 million per year. In an ongoing analysis, we estimate if the state of California public employees would do this, they would save about $983 million per year, and obviously quite a bit larger if that was expanded to the rest of the population in California. And then finally, several years ago, Rhode Island was facing similar issues. And so they took a slightly different approach. And so rather than the state coming in and setting prices, they actually had affordability standards for insurers. And so this is kind of an indirect way to monitor prices. And what we see here is that once this program went into effect in 2010, Rhode Island prices went from being above, or spending per capita rather, went from being above comparison states in New England to actually going below, and the curve actually flattened, especially relative to the control group, which continued to increase. And so if we add up all these savings, there's about 8% reduction in spending in the state of Rhode Island. I think it's important to keep in mind that this actually applies to everyone in the state. And so it's not just a public employees or a single employee group that benefits. And we also found that there's no impact in quality or access to care through this program. And so just to wrap up, rising healthcare costs place a tremendous amount of pressure on employees and worker wages. And I think especially as we come out of the COVID pandemic, we're likely to see further increases in hospital and healthcare prices, and that's going to further strain worker wages. The glass, half empty view of this is that there's lots of variation that's not linked to quality or access to care. But the glass half full, if you will, is that there's lots of savings opportunities where we can actually do something without disrupting how people get access to care and improve the efficiency of healthcare markets. I think it's important that we actually have information on prices and, more importantly, use it. And if we're providing healthcare as a benefit, then it's critical that both employers, purchasers, and state agencies monitor and ensure that prices are efficient and markets are competitive. And then finally, I think that many purchasers and individuals and states have, frankly, been left behind due to how markets have concentrated over the last several years. And so I think it's very important for state agencies as well as the federal government to make sure that the playing field is level. Thank you, and happy to answer questions.
Chris, thank you so much. Very important slides, important information for this group to hear. CJ and Vishal, similarly, thank you for the case study and walking through some of the details here. We're going to go, as we usually do, around. I'm going to start with you, Sandra, and then end with you, Rick. So Sandra, go ahead.
Well, thank you, Chris. Super helpful data and an analysis of it. I wonder if you know a little bit more about the anti-competitive contract provisions that Texas put in place and how those work.
Yeah, so I'm not an expert in Texas, legal policy, but I believe, that at a very high level, they were modeled off after what came out of the Sutter case and essentially designed to prevent those exact same practices.
Great. Elizabeth.
Actually, on that question, we had some involvement in that, and it is the sort of Sutter provisions about no all or nothing contracting, no, prohibitions on tiering. So I really do think we have a roadmap here for some of that policy, which is great. That was a great presentation. Thank you. And as I understand it, the evidence shows that every hospital should be able to be financially healthy at 160% of Medicare max. Like there is no sort of rational cost inputs on commercial pricing, unlike Medicare pricing, where they actually take into account wages, as you said, regionality, all the things, but that it is actually a matter of efficiency and effective management. And that's why you see the consistent performance even it underscores why cost shifting isn't really the issue. So can you just speak to what is a reasonable price? Is it 200% or where do you, based on the evidence, where does it show that all hospitals should be able to succeed financially?
Yeah, so that's a tricky question. So I think if you take it given hospital reported losses on Medicare, Medicaid, and just take that at word and not argue that, well, some of that might, if you operate more efficiently, maybe you'd have fewer losses, but just take that as given and add those up and then compare that to what a privately insured patient would have to pay for the hospital break even and add in a little bit of margin. You do get in the roughly 150% or 200% of what Medicare pays. And I think the, evidence that would be in the state of Michigan, for example, where hospital prices are, or commercial insurers are paying hospital prices that are about 180 or so % of what Medicare pays. You can still go to the hospital in Ann Arbor or elsewhere in Michigan, but it's just that purchasers and employers in the state of Michigan know that hospital care and healthcare prices come out of worker paychecks, and so have been very proactive for a long time on making sure that they don't spiral out of control. And so that's roughly kind of price range that seems that you could still have access to care.
Ian.
Thanks, Chris, and I want to echo comments. Really tremendous presentation. Thank you especially for putting this payer mix story to bed. I have a couple questions I'm hesitant to put out there with economists and maybe math teachers in the room, but we now have a 3.5 phasing down to 3% spending target, understanding that that isn't necessarily price target. The hospitals here could theoretically meet that spending target, and hospitals in the rest of the state could theoretically meet that target on their prices. And if they did so, these hospitals could still generate the 3 to 4 plus times operating profit margins that they are today compared to the rest of the state.
Yeah. So if as we talked about earlier, the efficient, a manageable price were to be in, say, the 200% Medicare range, and we see that hospitals here are charging 500% or 4 to 5 times what Medicare is paying, then yes, it's likely you could drop down some and still have a healthy margin.
And is it a fair takeaway, just given everything you said about market power, that they could comply with the spending target and we should still not assume that they would pass on the equivalent amount to purchasers, that unless the competitive market or the regulations change, they still are able to command the prices that they're able to command given the market?
Yes. So what economists worry a lot about is that if you, a agent or a provider with lots of market power is able to use that market power to extract high prices, then if you were able to limit the impacts of that market power based extraction, then the business can still perform.
Okay. And then one other thing that keeps returning to my mind, this county right next door to this county in San Benito, there is a hospital that has been losing money or struggling to break even. I'm sure there are others not too far away. It really is a tale of two cities in some way. And to the point of the conversation Dr. Pan and Jessica were having earlier, it strikes me that global budgets would be one approach to solving both problems, outlier costs like we have here in Monterey, and hospitals that are unable, given their market conditions, to pay the bills. So if the state were to set the appropriate budget to pay for the salaries of the workforce and the facilities and so forth, have you looked at global budget models and how would those relate to the kind of spending target, or sorry, the price caps that you're describing here in Oregon?
Yeah, so I guess the way I kind of look at the hospital industry is that they're the haves and the have-nots, and there are certainly many hospitals that are financially struggling, and that's a concern to both those hospitals and the patients who rely on those hospitals. I think where that have versus have-not also becomes more impactful is due to provider consolidation, especially when the have hospitals, if you will, acquire the physician community in a market and essentially have the physicians not send their privately insured patients to the rest of the community hospitals, but back to the mothership system hospital. And so that just exacerbates this problem. And so if we were to have, whether it's, global budgets or, some sort of, cap on prices for highly concentrated hospitals or hospitals with outlier prices, and use that to support some of the have-nots, if you will, then I think that would be beneficial to both those providers and again also the communities that rely on those providers and who tend to be more socially and medically and economically vulnerable.
Thank you. And I guess just one last question. This might be for CJ and Vishal, or maybe you have some insight, but year after year after year of 9-10+% operating margins, where's the money gone? And I don't ask that facetiously. That's a lot of money. Do we know where the money's gone?
Yeah. I'm not a finance person, but I do suspect it'd be reserves. And then, nonprofit hospitals, do invest it back into their system is what I hear. Yeah, that's something we could circle back on.
Yeah,
thank you.
Just add, if you look at many, nonprofit and particular hospitals, it's not uncommon for many hospitals to have multi-billion-dollar endowments. And so, I think, I believe it's the Ascension system, which literally has a private equity arm. And so certainly if we're thinking, what are we getting for we're paying? That's an important question to ask.
Thank you.
Yeah, just obviously, I don't want to overlook some slides that we did have in CJ and Vishal's presentation that showed sort of where some of those prices, where it goes among staff, administrators, other things. So obviously, there's some of the information to answer that question there, Ian, but maybe we can dig a little deeper and understand it better.
Although I appreciate that. I just want to point out for the public that the operating profit numbers are after they pay their executive and administrator salaries.
Go ahead, Richard.
Yeah, well, maybe just briefly sort of follow up to what Ian. So, you did show for the nurses and the nurse supervisors and so forth, exactly what portion of their expenses is driving that. You have an average, but how much are they spending on administrators? So maybe to get a little bit back at the question of where's the money going? Is it going to how much is administrator salaries, even though yes, they are being paid a lot more, actually affecting the entire hospital budget versus, so that might be interesting to look at. We'll see whether it's worth exploring further after first cut at it. The other question I have actually is that and appreciate the presentation. So there's slides showing that prices are higher in California, right? And you said there's no cost shifting, okay? But also you indicated, well, you said it was similar. I mean, it's a whole 2% less. The average revenue margin for California hospitals is less than the national average. So can you reconcile the higher, is it just, I mean, we talked about higher cost of living, cost of doing things, et cetera, but maybe you can try to explain why the margins in California hospitals on average are less than the national average by more than 2% compared to, while all the prices are higher?
Yeah, I mean, so I haven't looked specifically why the margins are different. But, if, for example, Medi-Cal rates were lower and prices are higher, I mean, that's not necessarily evidence of cost shifting, and so the two are still compatible.
Okay, that doesn't sort of seem like
Rick is itching to help jump in and clarify. So, Rick, go for it.
Okay.
Really, on this point, I mean,
One reason that the margins would be different is that expenses are different, right? That it's more expensive in California. But I think this margin question that you raise, and Chris, many thanks to you and Vishal and CJ, it is clarification is needed because the margin data that, or the operating margin data that Chris showed from the CMS cost reports is quite different from the operating margin data that CJ showed from the California annual financial disclosure reports. That the HCI data is showing operating margins averaging about 3% in California. I mean, it varies by year. And the data that Chris had was showing 11%. Since margins are kind of in, clearly a hot button issue as well as just important, it would be good to try to figure out why the HCI data are so different from the CMS data, or I would say differently, why the CMS data are so different from the HCI data. Having worked with both data sets, I trust the HCI data much more than CMS data on this point, but there could be problems on either side. But if I could then, Richard, I do think it would be, I mean, we heard, eloquently earlier, the plea to do something. And I'm reminded of the First Lady's comments in the Democratic National Convention last week. So, eloquently do something. And I agree with that. Although I do think that Richard raises an important question, and despite the excellent information that we've been presented, there is still the costs are prices are way higher at Monterey hospitals, particularly CHOP, than statewide and then in the nation. We've heard that eloquently. We've seen in the HCI data that operating margins are higher at CHOP than statewide, and that may account for a small part of why prices are higher. But even when you take out operating margins, the expenses are still higher. And we saw, and I appreciate the information that, some of that is that the compensation per hour for hospital administrators are higher at CHOP. My guess is that accounts for a very small part of the total difference in expenses per case mix adjusted admission, or the kind of expenses that either CalPERS or Cover California are paying. And I do think it would be useful, not to keep us from doing something, but useful to have a better understanding of, other than, higher operating margins and higher payment per hour for hospital administrators, what does account for the higher costs at CHOP than the statewide average? And some of that will be labor costs. We've seen some of that, but that's not going to be the whole story. And I think moving forward, we would be, well served with some understanding of that. And Chris, I don't know if that's something that you looked at. I mean, not for CHOP, but sort of for hospitals in general. What accounts for differences in the cost structure across?
So I apologize for saying this, but the economists, we would say that costs are endogenous, which means that they don't follow the sky. And I think this kind of gets back to what Elizabeth was mentioning, that if you're in a lucrative payment environment, potentially due to your market structure or not, and know that you have a high price and steady revenue flow, then that is maybe a incentive or an organizational feature that just allows you to be less cost conscious.
And let me try to clarify. Yes, certainly we know that costs are higher at CHOP. And my question, though, is at an accounting level, not at a sort of explanation level of, costs are higher because they can get the money to cover it and still have actually higher than average operating margin. But what parts of costs are higher? Is it more administrative staff? Is it more nursing staff? Is it difference in wages, which we've seen not very much, but maybe a little bit. But at a sort of industrial operations level.
My guess is it's not a single point. It's going to be a mixture of everything. So, administrative load or, higher hiring, et cetera, wages, also facility expenses, and just kind of everything across the board.
And then if I can just wrap up, because since we, well, certainly it looks like one of the places it's not going to is professionals, healthcare professionals like physicians, because actually the expenses are lower than they are for the state. That's slide number 122, if you want to go back to that. So, and in fact, actually, one of the interesting questions is that I don't realize that hospitals and facilities are very different than the professional fees, but I mean, part of this exploration about where the money is going is is it just because the professionals have less market power? I understand, we have a network, right, a montage, et cetera. So, or they just decide not to negotiate for the professional end of things or whatever else. But so we see some of these disparities. We talk about the margin, et cetera. I'm not saying that the docs need to be paid more. I'm just recognizing that the question is, what's the structure going on, right? What is the financial structure? And therefore, as we try to do something, pose a cap or whatever, exactly what will be behavioral response and what will be the impact on the people, literally the people who are receiving healthcare in the community. So that's, so we should at least have some understanding of that.
I'll say it maybe just even because I was puzzled by it too, or one would think that outliers would sort of track with one another, and here it didn't. And it's not just that the professional fees were below where the hospitals are, they're actually below even the state average, right? So it is pretty peculiar. And I think to underscore both Rick and Richard's point, I do think there's an opportunity to dig in a little bit more. Today has been terrific in terms of the presentations, but it's not by any stretch exhaustive. The next layer of the proverbial onion can be peeled away and some questions asked. I know engagement with these facilities and the provider, the doctor, to understand what some of the dynamics are, not just in the data that has happened historically, but what do those negotiations look like? I mean, we heard a little bit earlier about some of the techniques that are used in contracting here that maybe aren't used somewhere else. Is that what it's all about, or is there some other explanation? I think we'll be able to follow up again. You don't come to Monterey for just 8 hours and expect to solve it all. We know that there's more to do in this space. David, go ahead.
Christopher, thank you. Great presentation. As a Brown Medical School graduate, I enjoy seeing the university featured very prominently. I know during the COVID pandemic, there was another spokesperson from Brown who was often in the national news as well. I'm kind of confused. I think there's a lot of there's an opportunity for some additional significant analysis here. I know in terms of additional cost, I don't often speak for the hospital industry myself, but I know in California, we have some other standards or regulations that the industry has often spoken to. And we have nurse staffing ratios. We have seismic safety standards. These things can all drive up our cost relative to other states. But my question is actually, and I assume that you're here because you're somewhat in sync with our overall rate setting or cost setting strategy. Are there other things that you, with your background, might recommend that this board take into consideration, or the office take into consideration in terms of attenuating healthcare cost increases?
Thank you. So I guess on the first point, yes, there are unique features of the California environment that impact costs. But those impact the Bay Area, they impact the rest of California, and so we see that even without those with those cost structures, rather, Monterey hospitals are a pricing outlier. In terms of what needs to be, or what could be rather further studied, I mean, we know that healthcare spending is driven by market power and market concentration. And so if I were to advise or recommend what areas to go really into detail, it would be to understand, especially among the larger providers systems in California, what impacts their market structure and how do they use that market structure to get higher prices.
I mean, to follow that, it does kind of imply that California could be even more aggressive in terms of rate setting for California hospitals if we want to pursue a strategy like that overtly.
Potentially, I mean, if it becomes a reality that if we think that markets are driven by concentration and it is hard to reverse decades of consolidation, then rate setting or something that deals with the pricing consequences of concentration consolidation may be appropriate.
Thanks, David. Don?
So just a question about your slide referencing the Oregon 200% cap for state employee benefits. That was statute. But it sounds like you see similar or maybe even better prices relative to Medicare and some other states. You mentioned Michigan. So the question is, how plausible is it for a purchaser, a large public purchaser, to just do that unilaterally? Have you seen that, or in the states where it hasn't been done through legislation, is it just that they've been able to slow the growth over time?
So I think Oregon is certainly a innovator. We've seen this also happen in the state of Montana, but that's obviously a very different environment, probably the most different environment than California. And so this is, Oregon implemented their policy in, I believe, 2019 or 2020. And so I think this is a model that more and more states are interested in and are still thinking about developing.
But you haven't seen it happen without enabling legislation.
Outside of Montana. So
Okay.
Montana and Oregon are the two states that have done this, and Montana was through the plan benefit design and negotiations, and Oregon was by statute.
Okay.
Thanks, Don. Rick, anything else?
Just on Don's last point, Washington State has also got, a policy for state employees where they're trying to limit as what the state employee plans are paying as a percent of Medicare. It is, as you'd expect, tricky. There's some sort of legislation and then negotiation, and doesn't really work. I think not known yet.
So Washington is, in progress. I think Nevada as well. North Carolina tried to, but ended up not being successful. And so there are a handful of states that are kind of in progress of developing this type of policy.
Okay, Elizabeth, go ahead.
Just on that particular point, we actually also have some private employer members even in Florida, which was the one state worse than California, saying that they will not sign a contract over 200% of Medicare unless they can justify it. Like if the hospital comes forward with some, really compelling data set, they'll consider it, but otherwise it's 200%. So they're actually just doing it through contracting. The other thing that I think could be explored through contracting is site neutral payments. Just not wait for federal policy, just insist through some of the purchasing levers. So I think we could explore some of those contractual levers as well. And then my last question, have you done any studies on governance, like the boards or the leadership? Because having worked for a hospital-based health system and seen how they approach this, some of it really is just the orientation of the leadership.
I've not personally done any studies, but there have been other studies that have found that hospital boards, especially when they are compromised or have members of the large employers that are presumably negotiating those prices, that certainly seems to complicate those negotiations and result in higher prices.
Okay, appreciate the robust conversation. I'm going to limit my comment and just thank you, Chris, for the terrific, very widely applicable presentation to all of California. I just want to highlight, because we are here for a reason, really appreciate Vishal, CJ, and the team that put that together, the very specific information about what's going on in this backyard. And it is appropriate now with that context. We're going to spend, they assured me, 10 minutes on the next discussion item, or next presentation on what we can do, because obviously there's some ideas that have come up, but maybe more specific things we can do as a body. And then because I know you share this goal of mine to hear from the public fully, I'm going to limit our discussion to just about 10 minutes because we can bring this back as a next meeting discussion agenda item and maybe even hear some of the follow-up that might guide what we do specifically here in Monterey. So 20 minutes away from public comment from all of you here and online. So Vishal, take it away.
So now we'll shift the focus to what tools are available in the OCA statute to address high costs. So on the next slide that's shown here, these are the legislative findings from the OCA statute that declare affordability has reached a crisis point as healthcare costs continue to grow. Today, we have looked at data from federal and state sources, including from HCI, covered California, and CalPERS, highlighting an affordability crisis in Monterey County. As OCA continues to develop and collect data on spending, we'll dive deeper into variation and drivers of spending. Dr. Whaley presented earlier on broader policies the state can adopt and that this board and office can recommend to policymakers, including capping prices and enhance state responses to anti-competitive behavior and consolidation. We'd note that these are not the full suite of policies to address high costs. More broadly, OCA is supportive of policies to reduce outlier prices and increase affordability for consumers as outlined by our mission. In this section, we'll review the levers in OCA's statute to address this crisis of affordability through sector targets and our responsibilities for market failures. And now I'll be tag teaming this presentation with CJ Howard, who will cover the requirements related to sector targets.
And in the spirit of doing this really quickly and with haste, I'm going to definitely truncate the amount of detail that I get into here, because I think this is going to be an ongoing discussion for many months to come. So the key highlights or takeaways, though, is that on or before October 1, 2027, the board shall define the initial healthcare sectors, which may include geographic regions and individual healthcare entities. And then not later than June 1, 2028, the board shall establish specific targets by healthcare sector. And then once we've defined the sectors and regulation, the office and the board would follow the statutory requirements for setting sector targets, and as it would the statewide target on or before June 1, 2028. I'm gonna have you skip 2 slides to really kind of get through this with haste, because the next couple slides are about the process for how we would get to setting the targets and more of the requirements around how the target, or the factors that the board needs to consider. And so if we can get to the timeline. So the timeline for establishing the sector targets, just to give us a visual of what encapsulates the last few slides, is that OCA recommends definitions of specific healthcare sectors at a board meeting. So on or before October 1, 2027, and I think we've heard lots of let's do it before October 1, 2027, but the board shall define initial healthcare sectors, excluding FIDs, and that's because FIDs are already defined. Then OCA would promulgate regulations based on the board's definitions. On or before March 1st of 2028, OCA shall publish its proposed recommendations for sector targets for the board's review. And then between March and April of 2028, the board shall receive and consider public comments. And then on or before June 1, 2028, the board shall establish sector-specific targets, including FID, so there can be a separate sector or target for FIDs. Fully integrated delivery system, for those that aren't in the know. And I believe the only fully integrated delivery system that meets the requirements for statute is Kaiser. So that, I'll hand this back to Vishal.
So I'll cover some high-level options and considerations for defining and setting sector targets. So defining sectors is a board decision, and options the board could consider include geographic regions, categories of provider organizations, categories of payer markets, and individual healthcare entities. And as we mentioned, fully integrated delivery systems is already defined. The other factors to consider for defining sectors include delivery system characteristics. And lastly, sectors can be defined further over time. Next slide. So delving a little more into what we mean by geographic regions, these could be either the regions defined in the statute, which cross-references to a health and safety code definition for the covered California 19 rating regions. Another option could be other regions as otherwise defined by the board. So OCA is already planning to collect spending data by the 19 rating regions. With the exception of LA County, we just have a different approach for that region. Next slide. The OCA statute defines healthcare entities as a payer, provider, or fully integrated delivery system. So fully integrated delivery system is already defined as a sector. So the options for individual healthcare entity sectors could apply to payer or provider entities, which we've listed here. Next slide. So shifting gears to what the statute lays out regarding the methodology for setting a sector target for an individual healthcare entity. So the methodology shall, one, allow for the setting of cost targets based on an entity's status as a high cost outlier. And I'll be providing more specifics on that term in the subsequent slide. Two, allow for the setting of cost targets that encourage an individual healthcare entity to serve populations with greater healthcare risks, and incorporating all of the following: a risk factor adjustment, an equity adjustment, and a geographic cost adjustment. Next slide. So now I return to more specifics about what we mean by high cost outlier. The OCA statute does have a definition for high cost outlier, but that definition is for the purpose of subjecting organizations with less than 25 physicians to the spending target. So the definition is stated here, which is a high cost outlier and is an entity whose costs for the same services provided in a geographic region are substantially higher compared to the statewide average, as identified through several data sources, and a few examples are listed. To determine an individual healthcare entity's status as a high cost outlier, OCA could leverage the same definition that applies to expanding the spending target to organizations with less than 25 physicians, or it could adopt a new approach for high cost outlier. Next slide. So we've included the law's definition of a fully integrated delivery system in the first bullet point. Kaiser is the only system that meets that definition. For the data submission for total healthcare spending, we've instructed submitters to attribute member spending to Kaiser's two physician organizations and the respective organizations in Northern and Southern California. And the statewide spending target will be measured against each of these systems, Kaiser North and Kaiser South. Next slide. So now we turn to requirements pertaining to the methodology for sector targets as they pertain to fully integrated delivery systems. So until a sector target is set for a fully integrated delivery system, the statewide target applies to Kaiser. Targets, there's some language here about what the targets encompass, and it would include all healthcare costs, services, lines of business, et cetera, with respect to the geographic service areas of the fully integrated delivery system. It'll also include payer administrative costs and profits. Just lastly, there are some additional data collection requirements where OCA can collect more information from a fully integrated delivery system to enable that analysis to unintegrated payers and providers. And then after the board approves sector targets for AFIDs, the fully integrated delivery system shall be subject to a target for each of its geographic service areas, which would be, Northern California Kaiser and Southern California Kaiser. So now I'll close out with OCA's responsibilities as they pertain to market failures. So kind of focusing on that first table, the OCA statute requires that the office monitor cost trends, and this includes conducting research and studies on the healthcare market. Such studies may involve review of the impact of consolidation, market power, and other market failures on competition, access, and quality. The office must also review, and moving on to the second table, the office must also review and evaluate consolidation, market power, and other market failures through cost and market impact reviews, or CMIRs, of mergers, acquisitions, or corporate affiliations. Moving on to the third table, additionally, the director shall, there's statutory provisions where the director shall present to the board for discussion methods of addressing consolidation, market power, and other market failures. And then finally, the statutory provisions in that last table, when reviewing data submitted by healthcare entities, if data indicates adverse impacts, including market failure, the director may require that a CMIR or cost and market impact review be performed. And that wraps up our overview, and I pass it to the chair.
Great, thank you for that. Quick overview, helpful reminder. I heard, at least in some of the comments, a desire to, do this and. So let's spend a few minutes just hearing about maybe what some of those ands are, what you think of these opportunities, and what else we should address. I'm going to try to keep this, like I said, to 10 minutes so we can jump into public comment. You're first this time, Rick, if anything. Don't.
I wonder if Vishal or Elizabeth could talk a little more about the last slide and the kind of what opportunities there might be to do something. I think the sector setting targets by sector seems like something that we're required to do and something that we should do, and certainly be moving towards. I suspect that will be a longer term, or not. It's going to take a while to do something there, and I don't have a good understanding of what might come out of a CMAR, or what the possibilities might be of doing something after that work was done. We have heard eloquently today, both from the public and from the presentations that you've arranged, the problem, and then we're, I think, all struggling with what can we do. So kind of having a little better understanding of that from your side, where I know you've been thinking about this, would be really helpful.
Yeah, we, the sector targets, while there is flexibility to do them sooner, there are some requirements that need to be followed. But another option that could happen sooner is for the study to investigate high prices and cost of healthcare services in the region, and evaluate whether that's related to consolidation and anti-competitive prices or practices, or the presence of a market failure.
So our role would be primarily investigative with the experts that we've brought on to do the cost of market impact reviews. So to do a deep dive into the Monterey market. So that is an important analytical tool, an investigative tool, and transparency tool. We could also make a referral to the Attorney General's office of that information.
So can I just, so to do a market review, we would need to do additional study? And if so, what information would we obtain for that review that we don't already have?
I think it's really doing the deeper dive in terms of the market consolidation, right? So we've given you the data that we have about the prices, but less about the competition.
And this referral to the AG would require that a CMR is done in advance of referring it to the AG's office?
I think we'd really want a helpful body of data to provide to them.
Yeah, I think it's just thinking about how it all pieces together. With haste, we want to be, solid, right? And we want to make sure we have what we need. So it's, in no way to slow down where we ultimately want to go. It's how do we get that information? I think there is clearly at least one level down. Shouldn't take, I think as a board, we should urge the team to get to it, if you will, and then be prepared to think about it very, very soon. But I appreciate the sort of question conversation. I want to go, well, Rick, you want to do one and then we'll go to
Very
Don.
quickly, I jumped right to the last slide. I skipped over the, I would support, as I suspect many of my colleagues would, but I won't speak for them, in your free time, moving the dates, the statutory dates forward as quickly as we can around setting the sector targets.
Okay. Thank Rick for chewing up 7 of our 10 minutes. I'm just kidding. I'm joking. Don, go ahead.
I mean, I'll pass it along.
Okay, thanks, David.
Well, I think I would echo some of the sentiments that I'm hearing now. I had a quick procedural question. I'm noting in the box about CMRIs, if I'm reading this correctly, are there certain trigger events that initiate a CMRI? And do we have the authority to kind of proceed in this direction without a trigger event? If so, it would be very interesting to explore the region in more detail.
Yeah, so the usual cost of market impact review is triggered when we get the notice of a proposed merger acquisition. So we've started to get those notices. But as Vishal indicated, the statute also allows us as an office to decide. So we could decide now to do investigative study on the Monterey market.
I think it would be very informative, if not anything more than knowing about the process involved in CMRIs.
Thank you. First of all, I want to acknowledge that Senator Monning testified earlier. He actually authored a bill, actually sponsored by the AG then, was AG Becerra, to address consolidation. And I was proud to have helped as chair of the Committee on Health to get it out of the Senate. Unfortunately, it died in the Assembly. But I do think that, in terms of our work in investigating, doing a market review, would probably be helpful to the AG's office. There's different capacities. And so I think, some people say, well, certainly, let's put it this way, I don't think it's any big secret to the AG that, but someone would need to dig in more deeply if you're actually going to make a case, right? If you want the AG to do something. And I think we need to see if there's any opportunities there. Quick question. You spent several slides talking about the fully integrated delivery system sector. As you pointed out, it's mainly Kaiser North and South. Was there some thought among the staff to actually include anything else aside from Kaiser in the near future?
We were just going over the statute. So I
Okay.
think we most wanted the board to understand that there are a number of steps that have to go on. You all have to
Yes.
decide what the sectors are. We have to adopt regulations, and we don't, and we're still developing the methodology for measuring hospital costs.
Okay, I just wanted to clarify whether part of the reason for the explanation was you found that you were thinking about using that as a tool, as a sector to apply to maybe montage or something. So I don't know.
So, I mean, just to be clear, I'm so grateful and you were there, Richard, with me and Dr. Wood and the crafting this. It is pretty broad what can define a sector. So if there is an interest to, as a group, define a sector a certain way, that can happen. It is on a timeline right now that will not be immediate, but it is, I think when you ask, can you include, are we thinking to include or use this? I think the definition allows us a lot of flexibility.
Yeah, and I think the intent was the deadlines were not to actually say you can do it faster. It was more to like, don't put it off way too long.
Okay, good. Ian?
Yes to a speedy market failure analysis, and at least with regard to outlier hospital prices, the sectoral definitions, I don't know that that means we have to decide what any other potential sectors are at that time, but certainly on that. I would also appreciate coming back to a deeper discussion about some of these options that aren't within our authority, but that the state might pursue with regard to global budgets and rate caps.
Yeah, I'll address that too at the very end, but thanks for the flag, Elizabeth. Okay, Sandra, anything else?
I would also just be curious to know whether any of the public agencies through their plans are in negotiation currently or will be in negotiation with some of the hospitals in this market. And if so, if that is not a temporal opportunity likewise for some kind of intervention. So I just want to put a pin in that.
So very rich discussion. By way of wrapping up, just want to be clear within the authority of the office. So this body does not have to make a motion and vote to do this. They can do it. I just want to say that for the record. And I think they heard our interest in getting that done. So we will see that market analysis done. And then I too, and we don't have time now, but I'm interested. We heard a little bit about what some other states are doing, both legislatively and through maybe the equivalent of their Department of Managed Healthcare and other opportunities to affect contracting. It'd be nice to have a presentation at a future meeting at what some of those levers could be, just so we could consider them, even if it lies outside of the sort of strict statutory purview. I think this body having a conversation about some of those things and the importance will be heard much broader than even within this room. So I think it's an effective strategy on our part as well. So those two things at a minimum, or three things, really dig into the sector, the responsibility around sector targets. Richard's point, that is a end date, not a we can do it sooner or push it sooner. Secondly, immediate action on the market impact review. And then third, presentation next meeting, if you all agree, to set what some of those other levers are. We heard about some of them today and directly as they might apply to this county. Okay. So I failed again. It's a few minutes later than I'd hoped. We are going to start public comment. I, for one, may have to leave before it's all done. I'm going to stay here as long as I can. But I want to say, because I don't want to interrupt public comment, on behalf of the board and to my fellow board members, thank you for coming, making the trip. It took us a while to get here, but I feel like it was worth the wait. I feel like it was a very important meeting to have here in this place. And I'm just grateful to the presenters, all the hard work, literally months of work to get these presentations to the place where they could be shared today. And most importantly, thank you to the public who showed up, not just now, but months and months and months, taking days off, coming up to beautiful Sacramento The view isn't quite as good, but we're higher up there. That is true. But really just a lot of gratitude for your effort. And I'm always reminded that your own personal stories and impact is what forces this to happen. It doesn't happen because you read about it or your neighbor experienced it. It happened because you experienced it. And that's how the change starts and occurs. So we're very grateful that you shared your experiences with us, and we'll hear a little bit more about those now.
All right, we'll now begin public comment for both agenda item 5 and for general public comment. We'll be hearing from individuals here in the room who have traveled to come here today to give them that opportunity, and then we'll look to our online members of the public who have used the raised hand feature after we are finished with those in the room. As mentioned earlier, we ask that you keep your comments to 2 minutes or less so that we can hear from everyone before we have to vacate the room. And with that, please go ahead.
Beth Capel, on behalf of Health Access California, our letter to you this month began the discussion of sectors, but I want to loop back to where Senator Monning started the public comment this morning. He asked that you set a cost target for these hospitals for high cost outliers at a lower level than the statewide growth target. That is where we should be going, and where, with all the requirements of the law, we can be going, and much sooner than 2027 or 2028. A point I want to emphasize is that the law allows you to first define sectors, and as Dr. Galley said, it's very broad, the law is very broad, but second, to evolve that definition over time. So you could literally set targets for the Monterey hospitals without fully defining sectors in every other respect. And the law was premised on the reality of high cost outliers. And all of the presentation you've heard today has demonstrated that these hospitals meet that standard. And I want to just at a very high level review some of what you've heard today. It's not health status. Monterey is not sicker. It's not cost shifting. The evidence is clear on that. It's not better quality or improved equity. Again, the evidence is clear on that. And having reviewed all of the comments in the presentations, we would assert the consolidation accounts for part of the difference, but not all, which means there's only one factor left. So we don't usually talk about greed. It's not sort of a publicly appropriate thing to say, but we have a health system here that has $1 billion in reserve. That is the sort of thing that precipitates the request that we set targets for these hospitals and then continue to evolve the definition of sectors over time. Thank you.
Hi, good afternoon, everyone. My name is Anate Millers, Director of Regulatory Affairs at the California Association of Health Plans, which represents 42 Knox-Keene licensed health plans in California that collectively provide coverage to 28 million people. CAP and its member health plans are pleased to see that the OCA board is commencing this important discussion around sector targets. As evidenced by today's presentations, hospital spending continues to be one of the biggest cost drivers of healthcare in California. And while it will take time to address this complex issue of rising healthcare costs in the state, we believe that defining sector targets will be a step in the right direction, and we do support starting that discussion as soon as possible. We understand that OCA's process of defining sectors is in its initial stages, and there is more information needed regarding geographic regions and entity categorization before any decisions can be made, but we look forward to participating in that process as it moves forward. Thank you.
Yeah.
Thank you, Robbie Franceschini with Blue Shield of California. I really want to thank the board and the staff for coming to Monterey today and really, I think, highlighting a key issue often for plans and purchasers alike too, which is some of the high cost spending in certain parts of our state, and really highlighting, I think, too, the affordability crisis, especially for our members. So we're really excited by the kickoff today when it comes to really starting to talk about sectors and what those could be and helping to define and identify those. So thank you so much.
Thank you.
Hi, my name is Angela Riley. I'm a pediatrician and the National Medical Director for Unite Here Health. We are the Taft-Hartley plan for over 200,000 hospitality workers across the country. And we have members in over 45 states and we hold our own data. So I've had the luxury of being able to examine prices across the entire country. We have members that live and receive health care in very expensive areas of the country, including New York City, Boston, Seattle, Chicago, Seattle. And they also have received cancer care at very prestigious hospitals such as Memorial Sloan Kettering, University of Pennsylvania, MD Anderson, and so forth. And so one of the areas of focus has been cancer for us because we've seen such a large increase in cancer medications and costs across the country. And as we look at our data, Monterey area hospitals stand out as by and away the most expensive hospital for cancer drugs. In fact, we are seeing sometimes an 800% differential between the costs of cancer drugs in Monterey area hospitals versus the rest of the country. But our members also receive care from some of the independent oncology practices here. And we also see that the Monterey hospitals may charge about 800% Medicare, where the independent practices here in the same area, only a couple miles away, only charge about 100 to 150% Medicare. So the location is not the primary factor that is impacting cost. So I really implore that this is a step in the right direction. We have a very small plan here, only 2,200 members, and hundreds of thousands of dollars on a single cancer drug makes a big impact on our bottom line. So I thank you for this hearing. I came all the way from Chicago to attend, so this has been a very excellent experience and excellent presentations. Thank you.
Thank you.
Good afternoon. Thank you for being here today. We're really grateful to have this focus put on our hospitals and the Montage Health Group. My name is Lisa Brazil. I'm the president of the Carmel Unified School District CSEA staff. And I want to make this a little more personal. You guys are talking at a very high level that I'm not used to, frankly. You mentioned cancer. So an instructional aide at one of the schools in our school district was diagnosed with cancer a few years ago, and it has driven her to near bankruptcy because she can't travel out of the area to receive her treatments. She's spending thousands and thousands of dollars a month, far more than she makes. Very personally, in 2017, I was diagnosed with meningitis and was told to be transported to the nearest hospital. I couldn't go to Watsonville. I couldn't go to Salinas. I had to go to Chomp. And while I was laying in the bed just after a spinal tap on some pretty heavy drugs, they came into the room and demanded payment on site that minute and wouldn't leave. So I directed her to my purse and she took $1,000. And that was just the start of what I ended up paying over months. My husband, who is a teacher in our school district, has specialty doctors. And recently we received a notice that one of his doctors has left Montage. And when we called to ask him if we could follow him wherever he was going, which gratefully we could, we asked him why he left. And he said, because I got tired of being told I could spend only 15 minutes with my patients, and it was all about the money and not about the people. So there are I have many stories like this here on my computer. I implore you, please hold these hospitals accountable. When you live in the shadow of Chomp, and that's the only place you can go, you shouldn't have to choose between your health and whether or not you can afford it. And that's what's happening to all of us. Thank you.
Thank you.
Hi, my name is Brian. I was born at Chomp, lived most of my life here in Seaside. Earlier this year, I ended up in the hospital in the middle of the night. I was there for a few hours. It cost me a few $1,000s, the vast majority of that time, I was sitting in a bed by myself with an IV hooked up, and that was it. I only pay 20% because of my insurance. So that's 4,000 is only 20% of what they charge me. And I think I have better insurance and better pay than most healthcare and most hospitality and workers in the area. And it cost me over a month pay just for a few hours. Thanks.
Thank you.
Good afternoon. My name is Miria Gutierrez, and I am here to represent several people. I'm a Salinas Valley Federation union member. I'm a teacher in Salinas. My parents are both agriculture workers, and I have people in my family who need insulin. As a mother who is also trying to expand my family, the data that was provided is an eye-opening experience, but also it's something that I've been living. Last time I spoke to you, it was in Sacramento. And last time I spoke about how I was paying off a hospital bill when I took my 3-year-old daughter to the hospital. I was doing payments, and that month was the second to last month I had to pay. And then suddenly I ended up having to go to the hospital, and I ended up getting a bill for like $2,500. So I finished the other bill, and now I'm currently paying another bill. So it's like constantly something happens, right? We don't expect it. In my case, I mean, 5,000 in total seems like a lot, and it is a lot for me, even if I'm doing payments. But as you can see, a lot of people have it worse. A lot of people behind me have had medical emergencies that they're still paying off, or it's a huge amount. I am lucky that I am able to have insurance, but even then, living in uncertainty is something that no one should deal with. Healthcare for me, I consider it a basic right. And it's a shame that hospitals are making huge profits at the cost of many lives. I urge you to consider less than 3% growth cap on Monterey hospitals, but also with a shorter time and implementation. As we can see from 2020, like prices grew really fast. And
2 minutes.
I can't imagine what's going to happen in three years from now. Thank you.
Thank you.
Good afternoon, board. My name is Rosalind Dixon, and I am a teacher in the Salinas Valley Federation of Teachers and a resident of North Monterey County. I'd like to share with you a recent experience of mine. Earlier this year, I took my husband to urgent care, labeled Montage, and located in Marina. I called ahead of time to confirm our insurance was accepted and that his medical needs could be addressed at that location rather than the emergency room. Because I know my employer-subsidized insurance plan does not cover any of the hospitals in my county. This was confirmed over the phone and we headed over. He received great care and we received no bill at all. 2 months later, I went into the same urgent care facility for my own care. I received an invoice indicating 0% of my bill would be covered. I called thinking this was some kind of mistake. What I was told was shocking. This standalone urgent care building located in Marina is a part of CHOMP, a hospital located 10 miles away in Monterey. I was told my husband's care being covered was the mistake, and that I did, in fact, owe several $100s. I chose to go to a non-hospital location and avoid the ER to avoid the associated costs, and I was rewarded for this with a totally and a completely unexpected and unsubsidized bill despite having double coverage. I hope my story and the others you've heard today help you understand the many reasons for our disproportionately high costs for healthcare in Monterey County. Thank you.
Thank you.
Thank you. I'm Enrique Fernandez, Business Manager of Unite Here Local 19 and Vice President of the California Labor Federation. I'd like to start thanking the board for traveling to Monterey and taking the time to listen. And I hope take with you the anger of the community towards these 3 hospitals. I know we talk a lot about CHOMP, but 3 hospitals that are taking advantage of our community. My anger comes from the fact that while I represent bartenders, servers, room attendants, cooks. They have the ability to bargain for their wages through collective bargaining. We have been for years putting money to pay for these hospitals, to pay for the abuse that these hospitals are day by day bringing to the community with the overpricing. It is an anger. Today I was ready to go very technical on all of you in addition to what you heard today, but my anger is so high, especially when I negotiate for low-wage workers and I see $183 an hour to pay for administrators. When I see that our money through the Taft-Hartley funds go to pay for a service that is not being at the levels of other counties. So that's the anger of the community. I hope you take that with you, and I hope that in my book, that is greed. It's not market, it is not competition, it's true greed from the hospitals in this community. So we need to stop that, and we are asking for your help. We talk about what you have done until now, and I thank you for that, but I think in the future, what we need, and we request from you, is that sector target as close as zero as possible, if not zero, forever. I know it's a big ask, but I think this community deserves that. They've been abused for years, and that's about to stop.
Thank you.
Thank you. My name is Francisco Rodriguez. I'm Secretary Treasurer with the Monterey Bay Central Labor Council. And first of all, I just want to welcome you here to Monterey County, the county with the highest hospital cost in the state of California. I also want to thank you for all the reports and discussions that you had, and also for being attentive when given our members gave testimony to you. I think that we all can agree on the facts, right? Monterey County hospitals, hospital costs are too high. It doesn't have to be this way. As we heard, our hospitals are profitable, far more profitable than the state average. And we all need to recognize that they can afford to charge significantly lower commercial rates and still make higher profits than statewide average. As a simple thought process or thought exercise, we looked at what their net income would be if they reduced what they charge for care to patients with commercial insurance by 15%. And guess what? A 15% reduction would have meant savings of $138 million for those covered by commercial insurance last year alone. Now, of course, we would need to make sure that the insurance companies or the savings went to the actual payers, not the insurance companies. And the affiliated unions of our Labor Council are ready to do whatever is necessary to make sure that happens. But our main point is this: lowering the rate of increases is not enough. We need lower prices, and we need them now. Thank you.
Thank you.
Good afternoon. As I sat here reflecting on the past 14 months that I have shared space with you for a few hours, it was May 2023 when I first went to Sacramento. And I thought, what is this board, and are they really going to listen? And what I thought about today was the quote by Margaret Mead that said, never underestimate, never doubt that a small group of thoughtful citizens, committed citizens, can change the world. Indeed, it's the only thing that ever has. And the folks sitting in the room today have taken the entire day. My members from their classroom, the superintendent from our district, from Monterey Peninsula, Unite Here workers. And it's because we are exhausted. We are exhausted at making decisions about the uncertainty. So thank you for coming today. I wanted to share with you, and Steve McDougall mentioned it earlier, that our rates starting for 2025 are going up more than 12%. And what that equates to is the plan that carves out CHOMP and carves out Natividad will be an increase of nearly $3,000 for the year. If they have a plan that includes CHOMP, it will be close to $4,000, and that's with a deductible that is almost $9,000, or excuse me, an out-of-pocket max that's $9,000. Recently, we just learned that our percentage of screening, compliance with screening for cancers in our group is abysmal. And there is a correlation between the fear of going to the doctor and having a bill and getting the screening. So the low utilization in California, I think, is equated. That went quickly. We ask that you shorten the timeline. We need help now. We needed it 10 years ago. And we also believe that the cap for Monterey County needs to be lower than that 3%. Thank you so much for making the drive.
Thank you.
Still Steve McDougall, still same titles and hats, and jack of a lot of trades. I have here, there was a question of, earlier about where's the money going? Where is it at? Well, CHOMP has a $1 billion reserve. They took 1/2 of 1% and tried to give $5 million to the teachers to shut us up, thinking we'd be foolish enough to not know the problem is much bigger than $5 million. They even got someone gullible at the County Office of Education to buy into this scheme and try to, basically, I'm going to paraphrase, tell the superintendents, just take the money, shut up. That's our community partner right there. What a leader. We have leaders in our community, people of status, that sit on Montage's boards, a couple of them, including their charity nonprofit one, which from my understand is not really getting it done. If I was a community member of status and I sit on a board for Montage's CHOMP's nonprofit, I'd be putting distance between myself and my reputation and them immediately. We know who you are because they put you on their website. Little levity, the doctors at these hospitals need to form a union, and I'll be their chief negotiator. I'm a jack of many trades, and I'm no slouch at negotiating. I can help them out if they want to form their own union. Clearly, they need to in this county. And I just want to close with, we needed help a decade ago. Anything you can do to speed up the timeline, give us what we need so we can just live our lives in this beautiful place and raise our families and then go off into the pasture like anyone else. Thank you for your time. Thank you for listening. Thank you for your work.
Thank you.
Good afternoon. I want to thank you all for coming. My name is Quavia, and my husband was born spina bifida, so he is chronically ill. We have spent, I don't know, maybe $2 million. We've been charged probably my insurance and $2 million maybe. I've lost track. But I was at CHOMP because they told me I hadn't paid a bill of over $4,000, and they had sent it to collections, and it was being charged interest. And I said, I have proof that I paid that. And then, of course, then they said, oh, yes, here, we found it. First, they couldn't find it. And then, yes, now we can find it. Then I talked to a friend, and he said, oh, that happened to me. I went to the hospital in Natividad, and they said, I didn't pay my bill, but I did. And then his daughter in another state, she also paid a bill, hospital bill, and the hospital said, oh, no, you didn't pay it. And so, you know, being sent to collection, I found out, includes paying interest. So there's a very serious problem here that also needs to be looked at. But I also, we've been through many systems. We went to Salinas and had some very bad experiences there. Of course, they charge too much as well. An ambulance, for example, it's 7,000 something, just trip 40 minutes. My husband, emergency room, 8,000 maybe, one day, a few hours. And then like at Natividad, they pretty much, in my opinion, did not help him, but they charged us thousands for insurance. Then of course I'm paying, my husband's disabled, so he doesn't work. So I'm paying like 8,000, I don't know how many hundreds per year. Now and then certain things are not covered. So many things. So I'm asking you to look at the insurance companies, 3,300, 3,200 for 2 people per month, and it keeps going up. So there are many, many things that need to be done. Thank you.
Thank you.
Good afternoon. My name is Celica Valdez. I first want to thank you all for coming to Monterey. I am going to share my friend Irene's story, something that happened to her. Her name is Irene Martinez. She works at the Lodge Pebble Beach in Monterey County. She is a banquet cook for 24 years. She lives with her husband, her daughter, and her granddaughter. She got really sick that she has to go to SHOMP. Right now she's feeling better, but she's still paying the bill, part of the bills. So far she already paid over $18,000 already. She paid $500 4 times to doctors every time she goes to Community Hospital of Monterey Peninsula. They asked for minimum payment of $100, and there were times she used to go daily. Sometimes she didn't even have money to have a normal dinner for Christmas. Last Christmas, she got no money to buy any presents for her family. She got referred to United Way to help her pay her rent for that month. She got depression due to the stress she had because of the high bills. The prices of the hospitals are not affordable to working families. The treatment of the hospital staff was great, but the prices are not fair at all. She asked that the only hospital in our area became more affordable to us. They charge us like we're considered middle class, but charged like millionaires. Please do the right thing and help us to regulate the prices of hospitals. She knows that 3% cap was approved starting in 2026, but that 3% is still high. We need a lower sector target and to start sooner than 2026 because high prices in Monterey hospitals are killing us. Thank you, Irene Martinez.
Thank you. Thank you.
Mi nombre es Catalina Hernández. Primero que nada, darle las gracias al comité porque aceptó venir a Monterrey para ver en realidad lo que está pasando con los hospitales de Monterrey, que están los precios muy, muy, muy altos.
My name is Catalina Hernandez, and I want to start by thank you for the committee to coming to Monterey to address this issue of really, really high prices of the hospitals.
El 3% que está ahorita, que gracias a ustedes ya pusieron el 3% que pueden aumentar en el 2026, a mí todavía se me hace como muy alto, 3%. Nosotros que somos una comunidad muy pobres, que trabajamos de housekeeping o en los restaurantes, si no tenemos lo suficiente para pagar ese tanto que va a subir cuando nos enfermemos.
So us as housekeepers, janitors, right? We want to thank you for discussing the 3%, but we do feel like the 3% is still high for us, and it's something we wouldn't be able to afford.
Les pido, comité, que sería mejor que nos pusieran y nos ayudaran que fuera el 0%.
We ask you, the committee, to please seriously consider 0%.
Le doy muchísimas gracias por escucharnos y por venir a Monterrey. Gracias por venir.
Thank you so much for coming to Monterey and for listening to us. Thank you.
Thank you.
Good afternoon. Thank you for coming. My name is Raquel. I am here to support this campaign because I am afraid of this high cost of going to the Monterrey Hospital. In my experience, my son go sick, and I don't know that would have happened if he had to pay so much. Fortunately, he has insurance. We will be in a bad situation because he will not pay rent, and even then we will not be able to pay. This is why we demand that you lower the rate below 3%. Please, hospitals, be aware of this and listen to us. Thank you very much for coming, for listening, and for everything. Thank you.
Thank you.
Buenas tardes, mi nombre es Benita Herrera, trabajo en Highland Scenes, California. Soy housekeeping y trabajo por 26 años de housekeeping.
My name is Benita Herrera. I worked for 26 years as a housekeeper at the Highlands Inn.
Y muchas gracias por venir a escuchar nuestras historias y que esperamos que puedan hacer algo por nosotros porque en realidad de housekeeping no ganamos mucho dinero y tenemos que pagar cuando vamos a los hospitales un dinero muy exagerado.
Thank you so much for coming to listen to us as housekeepers. We can't afford the prices that we're facing at the hospitals right now.
Lo último que me ha pasado, hace 15 días llevé a mi niña, a mi hija al hospital porque tenía una fiebre muy alta, no podía bajársela, pero no quería ir porque sabe que el hospital de Monterrey cobra muy caro.
So 15 days ago, so 2 weeks ago, her daughter had a really high fever and needed to go, but they were afraid, right, because of the high prices to take her to the hospital.
Pero cuando ella se le empezó a subir la fiebre muy alta, yo la tuve que llevar y ella llegó al hospital, no tardó más de 2 horas, le pusieron un suero, nada más le sacaron 2 botes de sangre para ver qué tenía y en 2 horas llegó una persona, todavía ella no se quitaba la bata y llegó una persona diciéndole que su bill era de $9,500.
So they ended up, I took my daughter, we were just there for 2 hours. They gave her some fluids. They took a little bit of blood. And in that same visit, they told us it would be $9,000.
Nunca había visto que una persona en bata todavía del hospital llegara al bill. Ella estaba muy enferma y en ese momento se empezó a estresar mucho.
So I never seen someone be so sick and the hospital comes to demand payment in that moment. My daughter was very, very fragile and weak, and I've just never experienced that before.
Hasta este día mi hija tiene mucho estrés y ansiedad por el problema del hospital.
So it was very stressful for her in the situation being presented the bill while she was sick, and she's still very stressed and experiencing anxiety because of this situation.
Porque ella paga mucho de renta y no puede ahorita pagar el bill del hospital y está muy estresada.
So right now she can't pay the bill, so she's struggling to pay rent and deal with this bill, and she's really, really stressed out.
El 3% que han logrado que no suban los hospitales para nosotros es todavía mucho porque nosotros somos pobres, no tenemos tanto dinero para pagar, o pagamos el hospital o pagamos la renta. No podemos más.
So we think that 3% is still too high. We shouldn't be having to decide between paying rent and paying a hospital bill.
Nosotros no somos profesionales y no podemos ganar tanto dinero como la gente profesional.
So we are not earning as much money as housekeepers as people in higher earning professions.
Y gracias por escucharnos y espero que puedan hacer algo para que todas las familias puedan acudir en una emergencia al hospital, porque mucha gente no va al hospital y prefiere quedarse en su casa y a veces hasta morir.
So thank you for listening to us. This is serious because right now we're facing the issue of not wanting to go to the hospital and deciding to just stay at home and risk dying. And that's how bad it is.
Muchas gracias y espero que puedan ayudarnos en esta situación que tenemos.
Thank you very much for coming, and I hope that you can help us with this really difficult situation.
Thank you.
Perfect. Hi, my name is Esteban Rodriguez. I'm a bartender at the Monterey Beach Hotel, which is across the way, right on the beach out there. Last time I came to the board was on my daughter's birthday, April 24th. She couldn't make it. She wanted to come today, but she is busy. She has cheer practice, but she said hi. But more on a serious note, I already shared my story. I don't want to repeat that again. So I'm also a community leader for Seaside and also Salinas. And I wanted to share quickly a story that one of the community members that planned to come here but couldn't make it. She says, "Hi, I'm Lidovina. Well, it wasn't possible for me to go. I'm sorry. This month I had 2 appointments with the neurologist, and well, I don't have insurance, only Medi-Cal. With part of the cost, I will have to pay $4,600 so far. We are earning only $560 per week. Because of this, I would have to miss work another day, and we barely have enough with the expenses." This is just one community member here. I hear these stories a lot. Didn't mention I'm also a community health worker coordinator, my other job. So I have 2 jobs, single parent. But also, I'd like to point out that earlier in this morning, I did see some of the executives of Montage here, right? And they were listening to everything, but I kind of noticed that they left right before lunch, and then after lunch, we had the presentation of how much the administration makes, and I thought that was kind of a quite coincidence for them not to be here during that time, right? Because they're the ones that are making double of the time. Oh, that was quick. Anyways, yeah, I just wanted to share that. Thank you again for coming down here. I very appreciate this. And hopefully we can make a change. And again, like my previous people that came here, 3% is a little too much. Because you saw it in the presentations that the costs are really high here. If you could do something now, that'd be even better. Appreciate your time. Thanks.
Thank you.
Good afternoon. Good afternoon. My name is Clarissa Reyes Becerra, and I am the Programs Director for Centro Binacional para el Desarrollo Indígena Oaxaqueño. As you heard earlier from my compañera Marisela Ramirez, we primarily serve Mexican indigenous farm workers. Farm workers are essential workers who feed our nation, yet they are underpaid in dangerous, labor-intensive jobs and often face language and cultural barriers while trying to access our healthcare systems. During the peak of agricultural seasons of work, farm workers often go without health insurance because they are kicked off of Medi-Cal while they're finally not making a thriving wage, but a meager surviving wage for just a few months. And while they are kicked off Medi-Cal, often they forego healthcare in fear of exorbitant medical bills. We work with a lot of farm workers who go to Salinas, so that's Natividad and Salinas Valley Memorial Health. I know we're talking a lot about CHOMP, but we see a lot of them who go to Natividad. In our offices, we assist farm workers who receive medical bills from Natividad and Salinas Valley, which are in English, not in Spanish, against the law. And while the bill might have a small little line mentioning charity care all the way up at the top, it's tiny, all the family sees is that thousands of dollars bill. That's the big bolded number. And that's exactly what they were fearing in the first place. I remember in one of our meetings with the Chatino community, a man came up to us with a broken collarbone. It was literally sticking out. And he asked what he could do while he was waiting for his Medi-Cal to kick in for the Medi-Cal expansion that just recently happened for those regardless of immigration status. We told him, go to the emergency room. You need care. And he was just really afraid. And we told him to ask about charity care. Don't leave without asking about charity care. But there wasn't much more that we could do. Given these concerns with high costs for farm workers and workers generally, I wanted to make 2 big comments. Workers and families must be the primary beneficiaries of cost containment, or else cost containment will necessarily worsen existing health disparities. With nearly half of Monterey County residents enrolled in Medi-Cal, the importance of maintaining adequate payments to providers in the area is of vital importance, especially as the Salinas metropolitan area is considered a health professional shortage area. Finally, and most importantly, cost containment policy recommendations must be guided by community need. As healthcare entities work to cut costs, healthcare services with historically low profit margins, such as maternity and pediatric care, may be at greater risk of closing. We've already seen this at Me Memorial Hospital in King City, which closed its maternity ward in 2020, and we have also seen how other hospitals in counties, Madera and San Benito, have also experienced similar closures, which have primarily affected rural, low-income, farm-working families in the region. I hope we can prevent a similar crisis in Monterey County and find a solution that best serves working families in our county. Thank you.
Thank you.
Hi, my name is Lori DeVera. Earlier this year, I went to community hospital for kidney stone procedures. I have a genetic condition where I produce too much amino acid, and that's the acid that works with proteins. So it becomes concentrated in my kidneys, turns into crystals, then it goes into stones. I had 2 outpatient procedures at CHOMP to laser the stones and remove the pieces. My experience was very good, so no complaints about that. I'm here to talk about the cost of the procedure as a concerned member of this community. I'm over 65 years old, so I'm covered by Medicare. My husband retired from the union, so I also have a Medicare supplement plan. I'm lucky. I didn't have any out-of-pocket costs for these 2 surgeries. I used to work in healthcare. I like reading the EOBs. It helps me to understand the cost of my care. I know that my Medicare supplement plan is funded by the same money that goes to pay for the care of current union workers. So I want to make sure that that money is protected. For my 2 procedures, CHOMP billed over $86,000. Medicare paid about $15,000. And my portion, picked up by my supplement plan, was about $2,500. If I was still covered as an active member of the union's plan, as I was a year ago, CHOMP would have received almost $75,000. That's about $57,000 more than they got from Medicare. In other words, CHOMP would have received 5 times more. From the union's plan than from Medicare. I should also note that I would have paid more than $6,000 out of pocket for those surgeries as well.
2 minutes.
This seems like an outrageous difference to me. And that's where I ask the committee for any help that you can give in cost containment. Thank you, respectfully.
Thank you.
So I'm Lori's partner. I'm Julius DeVera. I'm a lifelong Monterey community member. Like Lori mentioned, I represented hospitality workers, and I was involved actually with this group when you guys launched. And we pulled together a coalition with the teachers, the farm workers, right, hospitality, building trades. And so this is a really important issue, right, as I knew. However, I'm living it because in October last year, I suffered a brain bleed and had a cranial hematoma, which means basically brain surgery. And I'm still in the recovery phase. As a Monterey resident, CHOMP was the hospital of choice, right? And great care, but luckily, I am a lucky guy because I am on Medicare. And as Lori mentioned, our family has a supplement. When we got the explanation of benefits, the costs that CHOMP billed Medicare was $575,000, more than $500,000. Now, I've been involved with this board and I've seen the data. Right? Great job with the research. That's exactly why you're here. Times that amount times 5. Just nominally, that's $2.5 million, right? That they would have gotten from my insurance if I was under 65, if I was not retired. In a fund like Monterey, where it's small, that is a catastrophe. The trickle-down effect, it's not even a trickle, it's a flood. The next years, you would be guaranteed a rate increase through the roof. My case, along with the COVID cases in the last few years, it's really put a damper on the working people. all our money is going to healthcare, insurance companies to pay off the hospitals. So I am so grateful that you're here. I remember talking about you guys coming to visit Monterey. You're in the belly of the beast, and these are the people that you can really affect. Thank you very much.
Thank you.
Hi, good afternoon, board, and also the community. Thank you for coming today. My name is Fortunato Pasqua. I'm currently a steward at the Lodge of Pebble Beach here in Monterey County. And speaking on an experience I had back in March 2023, where I was hospitalized at CHOMP. I had syncope, which is dehydration. And when I was there, I was only there for 4 hours. I'll make a long story short, I was billed over $16,000, 16,800. So if you do the math, 16,800 basically divided by 4 is over $4,000 an hour. Can any of you afford $4,000 an hour of medical care? Just something to think about. Again, thank you for being here and listening. Thank you.
Thank you.
Hello, good afternoon. My name is Morgan Baker. I'm a teacher in Salinas, and I've been a teacher for 9 years. And actually, I've just got questions. I mean, I've been ripped off by CHOMP too and some of the other institutions, but questions that I have are, when you were giving your presentation, you talked about the numbers of people, well, actually, you're talking about the percentages of how many people are getting Medicare and Medi-Cal at the different sites, how much charity work that they're doing, and the numbers there. The question that I had was, how many actual people are attending those hospitals? And I guess it's just a question. And also, what's the average income for the people who are attending those hospitals too? And also on the subject of the hourly rate that hospital administrators or hospital staff are receiving, I think it was $183 an hour. I think that was the number that you clocked in at. So is that also the monetization of benefits? Because I also know that, hospital administrators or hospitals like to advertise, like benefits packages and stuff like that. And one last question. I know that according to my friends who have worked in healthcare, they don't pay for healthcare coverage. It comes gratis. So I don't know if it's within the power of this board or this agency, but maybe you could also ask them to pay for healthcare themselves. That might be nice. All right. Thank you.
Thank you.
Good afternoon, Nikki Long. I just wanted to, sort of along the lines of a question, I wanted to share a very different experience I had. So I had a C-section delivery at CHOMP, still paying off that bill. But afterwards, they have a mother's group that meets every week, totally free, didn't have to pay a thing. I went to a brand new building, just been put up. There's still construction going on other buildings they have. I go in, there's like glass fronted, a circular building. It's incredible. There is nobody there. And I walk through a beautiful empty hallway to this massive conference room where I sit with other mums. We get free food. We sit and have a therapy. It's lovely. And then one day they said, oh, I'm so sorry, you can't use that room. You must go to the other. So I walked through empty hallways, 2 electric glass doors, through the Zen garden, into the incredible indoor basketball court where we held our therapy session that day. This is the same place that is charging people this much for these services that I don't understand. I have so many questions about what they're doing with this money, where it's going. And while I really appreciate the free services, I also wanted to make sure you heard that as it guides some of your research. Thank you.
Thank you.
Good afternoon, Board of Directors of OCA. Thank you for coming to our place, and also colleagues, friends, and visitors. My name is Romulo Uy. I just want to share with you my experience here in Monterey regarding my health issue. Uh, I work at Monterey Tides Hotel, known now as Monterey Beach Hotel. I'm standing here today not just as a union member, but as someone who has lived through a deeply challenging experience, one that I know many of you can relate to. Earlier this year, I was hit with a serious heart health issue that turned my world upside down. I spent countless hours in doctors' offices, and in March and April, I found myself hospitalized. I'm grateful for the care I received, but the relief of getting better was overshadowed by a growing worry, the mountain of medical bills that follow me home. I have health insurance, but even with it, I am responsible for 20% of the total cost. On papers, that might not seem like much, but let me tell you, when the bills start piling up, it feels like a crushing weight. I had to break down these payments into installments just to manage. And honestly, if I had not been working two full-time jobs with a second insurance to help cover some of the cost, I don't know where I would have coped. But not everyone is so lucky, and the reality is healthcare here in Monterey
2
is
minutes.
incredibly expensive. This experience has opened my eyes to something that I think is crucial for all of us to consider. The need for real change is how hospital bills are handled and the need to ensure that healthcare in its entirety is affordable for everyone. It's not enough to survive an illness. We need to be able to afford the care that keeps us healthy in the first place. No one should have to live in fear of financial ruin just because they need medical attention. No one should have to choose between getting the care they need and keeping their head above water financially. I'm standing here today to ask for your support in advocating and pushing for a healthcare system that works for everyone. We need stronger regulations, not only on hospital billing practices, but across the board. On the cost of healthcare itself for us, simple workers, it's time for transparency, fairness, and a commitment to making sure that healthcare is affordable to all of us, not just for a privileged few. Thank you for listening to my story. I hope that together we can push for the changes we desperately need to make healthcare a right that everyone can afford. Thank you.
Thank you.
Hello, good afternoon. Thank you so much for being here. We truly appreciate it, especially me. I am 65. I plan on retiring in a year, but I don't know if I'll be able to or not because of the high cost of medical care. I'll have a good pension. We have a 401k. My husband's already retired, but he has a chronic illness. It's $15,000 every 8 weeks for his treatment, and this will continue until his death, which I hope is a very long way into the future. So with not having my insurance any longer after I retire, I really worry about the fact of paying for a supplement. If I have to pay for this, how much will it cost me to be able to cover his medication treatment? Will we be able to travel? Will we be able to enjoy our senior years? Or will we be stuck at home because the only money we have will be put to covering the supplement that he needs to stay alive? So that is a very short statement. I didn't take up your 2 minutes. I'll save you a few seconds. But I just wanted to say there's so much to this, and we really need your action. I need it today. So I need it now so I can happily retire in next May. So thank you again.
Thank you.
Good afternoon. My name is Hector Aspilcueta. I am the union organizer with Local 19. I've been living in this area for almost 40 years. And in those 40 years, I have seen many changes. Just to give you an idea of what we're facing today, my daughter was born back in 1992, and my health insurance through the union paid 100%. I didn't have to pay a single penny when my daughter was born. Today, that is no longer true. I mean, you hear the stories over and over again of how criminal these prices are. This might not be illegal, but it's totally immoral. We have housekeepers, cooks, dishwashers that do not make $40 an hour, not even $30 an hour. And they still have to face an increase in healthcare costs. In the last 2-3 years, when we negotiated contracts, hoping that this money will be enough to put more money onto wages, and they are going 40-50% of that money into our health insurance plans just to maintain the same level of benefits. So our members are frustrated, are angry, and totally desperate to find a solution. And we know regulations sometimes are the best thing to make sure that hospitals, especially in Monterey County, do not abuse our residents. We live in a very expensive area, and you all know that. So we hope that through these stories that you hear today, you can back and say, it's zero increase in Monterey County. 3% is already way too high. We are already paying too much for health insurance. So thank you very much for coming to Monterey, and you have a chance. Go around. It's a beautiful area, but the struggle is real for workers in Monterey County. Thank you.
Thank you.
I'm Ivana Krajinovic with Unite Here Health. I wanted to start by thanking you all for coming here, as many other people have, but I also want to really thank the staff. I know that it's not easy to bring this show on the road. And I wanted to also thank the staff and the presenters for putting together such a robust presentation. I'm just speechless, really. The amount of data that has been provided here way exceeded, and the discussion that you all had about next steps. I mean, we couldn't be happier about that. I do want to give you a little preview, though. I think maybe if you were thinking, well, we came to Monterey, then it's going to be easier up in Sacramento because we won't have those hordes of people from Monterey coming. Well, it feels like we're not quite done yet. So, we're going to keep going and keep pushing for, a lower spending cap as quickly as possible. But I want to also, mention that the quicker you act and the more definitively you act, you send a message to this industry. This industry has the power to voluntarily drop their rates. They have the power to make arrangements with us. And I think what you've done today, I mean, Chomp maybe is not in the room, according to Esteban's research, but I'm pretty sure that they're listening in, and they need to get the message, right? And if you move quickly, I think that gives us more leverage to work this out, so you never have to apply a different spending cap to them. Our goal is to get them in line, not to punish them, right? So we really hope you act quickly and don't wait until 2028 to make a move on this. And thank you so much for coming.
Thank you. Now we're going to turn to our members of the public who are online. We currently have 7 who have used the raised hand feature. I just do want to note that we have to vacate the room at 5 p.m. and so we'll take as much public comment as we can until that time. We ask that you keep your comments to 2 minutes or less so that we can get through now what is 8 members with their hands raised. As we approach 5 p.m., if you haven't had a chance to speak but have your hand raised, we do urge you to submit your public comment in writing to oka@hchi.ca.gov, which is on the screen. I'll also just make sure people online who have raised their hands know that once we unmute you on our end, you'll still need to unmute yourself, and you'll find a mic icon in the upper right-hand corner of your screen. You click that to unmute. And with that, we'll start with Bianca Blumquist. You've been unmuted on our end. Please unmute and go ahead.
Thank you so much for your time. Thank you to the board for facilitating this incredibly important meeting, and to the countless workers, consumers, and business owners who took time out of their incredibly busy days to uplift these experiences. This has been an incredible day for us at Small Business Majority, so I appreciate it. Again, my name is Bianca. I'm California Director for Small Business Majority. We are a national nonprofit organization representing 85,000 small business owners nationwide, 20,000 here in California. 2/3 of the folks in our network are folks of color, and 2/3 are women entrepreneurs. So again, thank you for giving us the time to speak today. I do want to share some remarks from a business owner in our network who had to jump off. Her name is Victoria Leone. Her remarks say, when I started my nonprofit, healthcare costs were not a primary consideration. I've been a registered dental assistant for 30 years and continue in this role, which allows me to meet the income threshold for government insurance through IEHP. Because of these benefits, I made the decision not to increase my income, as it could adversely affect my insurance coverage. When I launched Fostering Kids for Life, her nonprofit, I knew from the beginning that providing insurance for myself or any potential employees was simply not feasible. Grants I receive are strictly designated for the youth that we serve, covering their basic needs. Insurance was simply not a consideration because I knew it wouldn't be financially possible. As a self-employed business owner, healthcare costs have significantly impacted my decisions. I don't pay myself from the nonprofit, instead maintaining my dental assistant job to stay within the income threshold required for my government insurance. As a single, divorced 58-year-old Hispanic woman with health conditions like fibromyalgia, it's critical that I maintain my health insurance, even if it means sacrificing my salary and the possibility of hiring employees.
2 minutes.
Expanding Fostering Kids for Life is something I'd love to do, but healthcare costs are a major barrier. Even when funding opportunities arise, they're often one-time grants that wouldn't provide sustainable insurance coverage for myself or my employees. On a personal level, the sacrifices are immense. The only benefit I receive from owning a nonprofit is the deep satisfaction of serving others. The healthcare system is so out of reach for someone like me that I try not to dwell on it, as it would only lead to depression and hopelessness. I continue to work as a dental assistant, maintain my low income insurance, and hold on to the hope that one day a major grant would allow me to pay myself and my employees with the added security of healthcare. But for now, the idea of having employees with insurance is more of a quote unquote pie in the sky dream than a reality that I can count on. Thank you again for listening to these remarks from business owners throughout the state. Thank you for making the time to appear in person, for the countless folks that are also there with you. And thank you to Health Access and the coalition partners for facilitating these conversations. I really appreciate it. Thank you.
Thank you. Next, we'll turn to Paula. Paula, we are unmuting you on our end. Please unmute and go ahead. Try that one more time. Yes, hello, please go ahead.
Yes, okay. My name is Paula Payone. I'm a stay-at-home mom, and I recently returned to Monterey like last year after 3 years abroad. Last April, I was diagnosed with colon cancer. I had surgery at CHOM, and I am currently undergoing chemotherapy. I'm originally from Italy, where healthcare is a right, not a luxury. So it has been quite shocking for me to learn that my care here so far has costed about $200,000, $180,000 just for the hospital stay. I'm lucky as I have a good insurance, so my copay is only 10%. But as of today, I still have pending claims, and I don't know what to expect, since my insurance only approved 3 of the 5 days I spent in the hospital. It would have been nice to know ahead of time what the insurance would have covered and what not. It would have been nice to know in advance that I was expected to pay $5,000 as a deposit the day before being admitted to the hospital. Based on what gross amount, no one was able to tell me. It would be nice to have clear statements, or at least have some ease in contacting someone from the billing department at CHOM who could give the patients clear explanations and just guide us through the whole process. Last but not least, it would be nice if there were better communication before hospitals and insurance companies, saving us patients an incredible load of legwork on top of what we are already going through with our own lives. Thank you.
So thank you so much. Now we'll turn to speaker 415-310-2222. We are unmuting you on our end. Please go ahead and unmute and begin. The 415 area code ending in 2222. Please unmute on your end, the upper right-hand corner, the mic icon.
Thank you. I appreciate it. Thank you, board. Thank you, speakers. Thank you, staff. My experiences have been, I don't want to echo everybody else's, but in line, meaning a short-term 2-hour stay resulted in a $26,000 bill for dislocated shoulder. Then a fractured skull, had to do emergency care, but the follow-up care, needing a primary doctor and then an ENT and a neurologist, you cannot get in to see any specialist unless you're going through your primary care doctor. The primary care doctors, you can go through 15 to 20 of them, and they're not taking on any new clients. So once you have a primary care doctor, so as a practical reality, you go to see, you get an appointment with your primary doctor, might take a few months, then you do get in to see them, then it'll be 4 to 6 months to see a specialist. So in the reality, fractured skull, I need help many times in 24 to 48 hours, or certainly less than 72 hours. But the system, the way it works here, and I'm sure many other places, but nevertheless, it would take me feasibly 6 to 9 months to see a doctor, a specialist, either a neurologist or ENT, excuse me, your nose and throat. But nevertheless, long story short is the lower percentage of people utilizing their health care is, even if you want to get into the system, it's gamed. So unless you go to emergency services, which then the guillotine falls, going through the regular process of appointments, it's just not viable if you need expeditious care. Thank you for your time.
Thank you. Next, we'll unmute Brandon Lindley. Brandon, please go ahead and unmute on your end.
Good afternoon from Palm Springs, California, where it's 105 degrees. My name is Brandon Lindley. I wasn't able to make the commute up there, but I have a small retail business in Palm Springs, Sweet Boss LLC. And I opened up about 7 years ago, and health benefits were definitely a significant part of my planning process with the Small Business Development Center, who assisted me with my business plan. But the true cost of starting a plan, especially HMO versus PPO, are very vague. They're not transparent enough to create an accurate budget. And as my business has seen growth and recession, healthcare costs are always a constant concern for me. The challenge is that insurance rates are unpredictable. And for small businesses like myself that have less than 10 employees, I don't get access to generous group health plans with affordable competitive rates at all. Every time I hire a new employee, I face the struggle where I have to send in a census every single time for each employee that I hire that's eligible for benefits. And then the insurance company comes back with a rate based on the age, the gender, and the zip code of the individual. So what happens is that younger employees that I hire get a much more competitive rate, and people that are over 40 or even over 50, much higher rates for healthcare. The costs have been really affecting my ability in hiring decisions to think clearly most of the time. And I have to question, can I afford to provide full benefits for more than one full-time employee per store? So relying on part-time workers becomes the meat and potatoes of my business. And with sales for me doesn't exceed usually $350,000 annually, every dollar matters. And sometimes I have to be so frugal that I have to skip paying myself. So with all of these things happening with healthcare, In order to be competitive and to compete and succeed,
2
small
minutes.
business owners like me need access to fair and affordable healthcare packages that larger companies can negotiate. Thank you so much for your time for considering this for business owners.
Thank you. And we'll take this one last speaker before we have to turn to the Vice Chair, Sandra Gonzalez, to adjourn the meeting. So we're turning to JC. JC, we've unmuted you on our end. Go ahead.
Yeah, can you hear me?
Yes, we can.
Okay, thank you. So first of all, thank you very much for this meeting, to the board, as well as to the citizens sharing their concern and their horror stories. My story is a small horror stories compared to one, but anyways, looks like I was so I'm a small business owner, and I have insurance via Covered California. I chose the low premium, high deductible plan. At the end of May, I was feeling and diagnosed with a bladder infection, which I asked the nurse, the telehealth nurse, to recommend me, and she recommended me. I went to ER. Basically, when you look at the internet, the nurse got it wrong. Really, for a bladder infection and some pain, you go to urgent care, not ER. Anyways, I went to ER. That's my fault, I guess. I complained to the insurance. They denied my complaint and my appeal. I also reached to DMHC, and they also denied my complaint regarding the insurance. My insurance plan is VHP. So then I went to let's go to the bill. Basically, for 3 hours spent at the ER, I was billed $18,000. After insurance, it's down to $9,000, right? What I'm not very happy, of course, is the rate, but also the fact that they shoveled a CT scan on me. When you do a cursory look on the internet, really a CT scan is completely unnecessary. Once you have determined that the bacterial infection is in place, you don't need to do a CT scan. They went ahead, shoved that procedure on me, and billed me for it. So anyways, I also constantly ask for the cost of ER while I was in the ER, and I was denied. I never got a cost or even a remote proxy of what it would cost. Anyways, moving forward,
JC, that's 2 minutes.
Yes, I'm planning to hire a law firm, similar to the firm that helps you check your credit cards. And I hope, and I think I will, shave about 25% of the bill that they still standing in front of me of $9,000. Thank you so much. If we can get the slides of today's meeting, that would be awesome, but I'll visit your website.
Thank you. That concludes public comment, and I will turn to Vice Chair Dr. Sandra Hernandez.
I'm sure there's a Gonzalez in the family, so it's not a problem. I really just want to thank everybody who came out today from the community, all of the workers, all the community leaders, those of you who called in virtually for a really robust input for this board, and for the staff who did an amazing job both with the materials but also with the logistics. Thank you for doing that. I think all the board was wanting to come to Monterey and be able to be in your community and hear the feedback. And I know the staff has heard that, and we look forward to trying to address some of the significant issues that are paramount and well documented here. So thank you, everybody. We stand adjourned.